Chapter 7, Part 1 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 7, General Complications of Wounds 1. Gas gangrene. For years before the present war, emphysematous gangrene complicating civil wounds was so rare that it might truly be said to have been non-existent. During the South African campaign, it was so rare that writers have not referred to it. Yet during the present war, both on the Western and Eastern fronts, it has been not only the most frequent, but also the gravest complication of gunshot wounds. The present war has differed so far in many important respects from the South African campaign. In the latter case, fighting was for the most part taking place in the open and on virgin soil. The rifle was the chief weapon of offense and defense, and the army was constantly moving. Today we are fighting over ground heavily fertilized by both animal and human excreta. Siege warfare, alternating with attacks and steady slow advances, has taken the place of fighting in the open. The stupendous weight of artillery employed on either side has been almost inconceivable, whilst trench mortars, hand and rifle grenades, bombs dropped by airmen, asphyxiating gases, flame, and the like have all added to the terrors of the present campaign. The degree of mutilation and tissue destruction shown in the present war wound is highly favorable to the life and proliferation of anaerobic bacteria. But this is not all. Just as important for the existence and rapid proliferation of these organisms in a wound is the general condition of the soldier at the time he is wounded. If his resistance to infection be lowered by fatigue, as was so often the case earlier in the war, if after receiving his wound he suffer from severe hemorrhage and shock, then the ideal conditions exist not only for the proliferation of these organisms in the wound itself, but also for their rapid spread into neighboring tissues. It was distinctly noticeable that gas gangrene was not very prevalent amongst fresh troops that had gone direct into action, whereas it was almost universal in the case of tired troops that had, prior to action, undergone long spells in the trenches. Even the smallest and the most harmless-looking of wounds, such as small Sutton wounds involving only the soft parts, have been complicated by gas gangrene in fatigued men. Localized gas gangrene. The rate of spread of the infection varies enormously. Thus, in some wounds of great severity, the infection may become localized. Gas, with its characteristic foul odor, exudes from the wound, yet there is no tendency to spread, and the general condition of the patient is good. Cases of this kind, it is true, are usually those of wounds involving the soft parts only, but we have also seen localized gas infection where bone has been implicated. This local type of gas infection occurred chiefly in men who had gone fresh into action. Slowly spreading gas gangrene. Again, the infection may spread slowly, and this has happened in wounds which have caused hemorrhage and shock. Men so wounded, who have gone fresh into action, have had their resistance lowered for the time being by the hemorrhage and shock occasioned by their wounds. It would seem, however, that they are not totally deprived of resistance, and early surgical measures have often sufficed to arrest the spread of infection, provided everything possible was also done to improve the general condition. Gas gangrene involving single muscles or muscle groups. Infection has often confined itself to single muscles or groups of muscles. We have now seen many such cases both at the clearing station and at the base hospital. The muscles most frequently involved in our experience have been the gluteus maximus, the gastrocnemiae, and certain of the quadriceps group of the thigh. We have, however, seen cases in which such muscles as the sartorius and the biceps brachialis have been singled out. Fulminating gas gangrene. In contrast to the forementioned is the fulminating type. Here it would appear that either the individual powers of resistance are nil or the infection is of a more severe type. There is strong presumptive evidence in favor of the former view, for others wounded on the same ground and during the same engagement have shown either the limited or the slowly spreading variety of infection. The rate of spread of infection in true fulminating gas gangrene is well nigh incredible, and the appearance of its victims almost beyond description. One or two examples will suffice to illustrate this. After the Battle of blank, there were many wounded lying out both in no man's land and in the blind ends of certain listening saps. Though only a comparatively short time, 8 hours or so, had elapsed since the receipt of their wounds, most of them were either dying or dead. Of the dying who were brought in, but few lived more than an hour or two. Some of these men hit in the lower extremity only 8 hours previously were gangrenous to the umbilicus, while others hit in the arm were gangrenous up to and beyond the corresponding nipple. They presented a typical cyanotic color about the lips and an ashen appearance about the face, while the eyes were bright and watery. Mercifully, their end was both rapid and painless, and they were buried in the line. Some of the dead in the ends of these saps had for military reasons to be left, and one of us had the opportunity of seeing their condition within 24 hours of being wounded. They were one bloated, gangrenous mass. So rapidly had the swelling appeared, and so extensive was its nature, that the tunic, trousers, and even in 1 or 2 cases the boots, were burst open, and through the rents protruded the familiar greenish-black swollen and blubbed skin. Nor was this all, for the periscope on the following dawn revealed the bodies of many others in a similar condition. It is a strange fact, but nevertheless true, that on the following night, when the few who survived were rescued, the majority of the living were those who had sustained wounds of the abdomen and chest, and considering what they had gone through, their condition was remarkably good. In not one of these penetrating abdominal wounds that were rescued alive was there any trace of gas gangrene. Whether or not the peritoneal cavity can better resist this infection is an open question, but on this particular occasion it was a very noticeable point. Another instance of rapid onset may be quoted. In a certain part of the line, a man wounded in the thigh was brought to the regimental aid post, where his wound, one of the penetrating variety, was dressed by one of us. We could not move him owing to heavy gunfire which was then going on. After 1 hour, the orderly reported that the man was in much pain. On inspecting his wounded limb, it was found that the bandage, at first loosely applied, was now very tight and the limb was swollen. The bandage was reapplied loosely. 1 hour later, that is 2 hours after the wound, the orderly again reported that the man's limb was very swollen and getting discolored. An inspection proved that he was right. The wounded man looked exceedingly ill and was feeling sick. This was a typical case of fulminating gas gangrene, and the limb was immediately amputated. This latter procedure undoubtedly saved the man's life, and he reached England safely. This example is only one out of many that we saw in the line, and although we were able to evacuate some of them, yet there were a number in which immediate amputation had to be carried out. In all amputations, performed in the line, as well as those performed at the field ambulance or casualty clearing stations, the same typical yellowish-green gelatinous substance was present in all the connective tissue planes. In such cases, the whole limb had become involved and not isolated groups of muscles. Hence it struck us that the term massive gas gangrene was suitable and expressive of this condition. Another very dangerous wound from a gas gangrene point of view is a penetrating wound of the back, where the missile, with its concomitant piece of clothing, comes to rest just behind the peritoneum. In such cases, a retroperitoneal hematoma results. The wound of entry by contraction or herniation of the muscles of the back becomes closed, and the most ideal conditions result for the life and proliferation of the gas gangrene bacillus. These patients arrive at the casualty clearing station suffering with acute abdominal symptoms, due, no doubt, to pressure exerted by the gas or blood clot on the posterior parietal peritoneum and the retroperitoneal nerve plexuses. Laparotomy has in many cases been performed and the abdominal wall subsequently closed. Such a procedure is followed by the rapid appearance of gas gangrene in the abdominal incision, and this condition spreads with alarming rapidity over the entire anterior abdominal wall and soon causes death. One case out of a number we can call to mind is that of a wounded German who had been hit in the back by a piece of high explosive during the Somme offensive. He was admitted to the casualty clearing station within 18 hours of his being wounded and was operated upon by one of us, as he presented acute abdominal symptoms with persistent vomiting. No damage to the gut had occurred, and the posterior peritoneum was intact, but there was present an extensive retroperitoneal hematoma. The abdomen was closed, and the piece of high explosive with clothing and blood clot were removed from the wound in his back, the wound being left widely open. 4 hours later, the whole of the anterior abdominal wall was brick red and blebbed, and resembled in appearance a cooked ham. He was delirious and restless, and died 2 hours later of acute gas gangrene toxemia. In this case, as in other similar cases, the infection had traveled forwards from the back in the retroperitoneal tissues to the anterior abdominal wall. Thence, through the laparotomy incision, it had found its way into the subcutaneous fascia of the abdominal wall and had spread here with lightning rapidity. These few cases were a lesson, because in all such wounds of the back giving rise to acute abdominal symptoms, it is a golden rule to have an X-ray taken first, and when the position of the missile and its depth are known, it should be removed without delay. At the same time, all blood clot should be cleared out and the wound of entry excised and enlarged. In a large number of these cases, the missile will be found to be extraperitoneal, and the prognosis is good if the missile and clot be removed at once. Gas gangrene and serous cavities. It is an interesting fact that a piece of missile with its concomitant piece of clothing, when once it has entered the peritoneal cavity, very rarely gives rise to gas gangrene. In only one such case have we seen gas gangrene occur, and this out of a large number. This particular case was that of an officer who had been hit in the buttock, the missile entering the right iliac fossa external to the cecum and lodging there. A space was shut off, and when the abdomen was open, broken down blood clot and gas escaped. The gut was uninjured, and B. perfringens was isolated from the discharge. It would seem that the peritoneum possesses a resisting power to the gas gangrene bacillus of a higher degree than that of other tissues, and this is borne out by the findings in the wounded who were still surviving after the Battle of blank already alluded to. It is of interest that gas gangrene is rarely seen in wounds of joint cavities in which the bones entering into the formation of the joint have not been damaged. In many cases, we have extracted pieces of missile with clothing from joint cavities, especially the knee joint, and such cases have never shown gas infection. One case that particularly comes to mind is that of a sapper who was wounded in several places with a high explosive shell. In all his wounds, except one, which penetrated the right knee joint, there was gas infection. The wounds were excised and the foreign bodies extracted. The knee joint was next dealt with, and a piece of high explosive and clothing were removed. There was no gas present in the joint, and he made a good recovery. In the pleural cavities, however, gas gangrene under certain conditions seems to flourish, and there is probably an explanation for this. Most wounds of the lung are complicated by hemothorax, the blood of which may often harbor infection. Such material constitutes ideal pabulum for anaerobic bacteria. We have never seen gas gangrene occur in a true case of pneumothorax. It would appear, then, that serous cavities possess a higher power of dealing with anaerobic bacteria and preventing their growth. Gas gangrene infection of brain. The brain has on several occasions been the site of gas gangrene infection. In a number of Tryphane operations performed by us, gas with an objectionable and very characteristic odor has issued from the perforation in the dura mater, and in some cases, although gas was present, the patient has before operation shown no symptoms beyond those of headache and perhaps a monoplegia. Recovery in the majority of these cases has been complete insofar as they could be observed up to the time of leaving hospital, usually 10 weeks, and thus we must conclude that gas gangrene in these cases is of the limited type. B. perfringens was isolated from the discharge in all these cases. We have seen a few instances, however, of massive gas gangrene of the brain, and it is surprising how long a man can live with this condition. We may quote one case as an example. A German from the 162nd Regiment was struck over the head with a piece of iron. On admission to the casualty clearing station, it was found that half of the calvarium had been battered in and a large piece of scalp was missing. He was perfectly conscious and rational, but was completely paralyzed on one side. He was taken to the theater, where it was found necessary to remove large quantities of diseased bone. The dura was badly torn, and the exposed brain was in an advanced condition of gas gangrene. The smell was of the characteristically offensive kind, which is so typical of gas infection of the brain. The brain was covered with a dressing, as the scalp deficiency was too great to allow of its being covered with scalp tissue. This man lived for 5 days and was conscious almost to the last, although each day large portions of the broken down gangrenous brain were being removed in the dressing. This was not an isolated case, but one of a few. In scalp wounds uncomplicated by fracture of the skull, and in wounds involving the soft structures of the face, gas gangrene is an extremely rare complication. This is perhaps explained by the liberal blood supply of these parts. Gas gangrene and maggots. It is said that everything possessing life serves some useful purpose. Can this be said of the domestic fly? We know that these creatures convey infection and are justly looked upon as potential dangers to society. Every effort has been made to exterminate them as far as possible in the present war, and such efforts have not been in vain, for the numbers of flies both on the eastern and western fronts have, on the whole, been kept well within the limits of toleration. We have already stated that flies are a source of infection to wounds, but can any useful role be ascribed to the fly as far as wounds are concerned? In order to frame an answer to this question, we can only speak of what we have actually seen. During the Somme offensive in 1916, many wounds of a very serious nature arrived at the casualty clearing stations infested with maggots. These maggots were of 2 varieties, the small and the large. Whichever type of maggot was present, the salient fact stood out that maggots and gas gangrene did not exist together in the same wound. From the same regiment during the same action, wounded men arrived, some suffering from a severe gas gangrenous infection of their wounds, whilst others who were fly-blown showed no gas infection. Again, at the clearing station, some grossly infected gangrenous wounds were put outside the marquees, partly for their own benefit and partly for the benefit of those lying in the same tent. To a few of these wounds, flies gained access in spite of all preventive measures. The wounds became fly-blown, and with the appearance of the maggots was associated the disappearance of the gas infection and the immediate improvement of the individuals concerned. Exactly the same phenomenon has been observed in the Eastern theater. An explanation of this we do not venture to suggest, but still the fact remains, and we have been concerned in so many of these cases that we far prefer to see and treat a wound that is alive with maggots than a wound complicated with severe gas gangrene, for the former cases have all done remarkably well. Maggots appear to stay in a wound only so long as there is dead tissue present for them to live upon, and they do not seem to exert any harmful effects on living tissue. Maggot-infested wounds are most commonly seen in the case of men who have been lying out with their wounds uncovered. By the time such men reach the casualty clearing station, it is usually too late to perform wound excision, and under these circumstances, the best treatment is slow, continuous irrigation with normal saline solution. We are of opinion that at such a stage it is unwise to destroy maggots, but better to let them continue their existence until they have digested all dead tissue, since patients do not seem to suffer, but rather benefit by their presence at this particular stage. We have already quoted cases in which gas gangrene infection of wounded tissues has subsided with the appearance of maggots. We can also quote cases to prove the converse. A good instance is that of Private Blank, 5th West York's Regiment, who was severely wounded in the right leg. Both bones of the leg were fractured and comminuted, and the wound was literally crawling with maggots. There was no active gas gangrene infection present. The maggots were washed away with 1-in-20 carbolic acid. Upon their disappearance from the wound, gas gangrene infection set in. This happened on more than one occasion, and is, we think, further proof that these two conditions rarely, if ever, coexist in a wound. Etiology. The causes of gas gangrene in wounds have already in great part been referred to both in the present chapter and in that on the Bacteria of Wounds, page 65. It is desirable, however, to summarize them here. In the etiology of gas gangrene, predisposing causes and exciting causes occupy an equally important place. In this, probably more than in any other disease, is the combination of causes absolutely essential. In the absence of predisposing causes, the exciting causes, namely the anaerobes, which are in almost every wound, are in every case impotent. The converse, of course, holds equally. The predisposing causes comprise the following: 1. Gross local tissue injury. 2. Absence of oxygen at the site of initiation. 3. Presence of multiple infection. 4. Presence of devitalizing general conditions, especially fatigue, shock, and hemorrhage. 1. Gross local tissue injury. As a general rule, there is no type of tissue injury so favorable to the onset of gas gangrene as that produced in gunshot wounds, especially in those due to modern heavy and high-velocity projectiles such as high-explosive trench mortar shells, bombs, etc. That this is so is apparent from the fact that gas gangrene has been such a very rare event in connection with any injuries other than the wounds of the present war. What are the peculiar characteristics of this tissue injury which render the wound so liable to gas infection? They are A. the fact that muscle is so often one of the tissues involved, and B. the condition of stupor which is commonly produced in those muscles. In almost all wounds, except mere scratches and abrasions, muscle is involved, and especially in shell and bomb wounds, It is so devitalized by the damage as to be the equivalent of dead tissue so far as the saprophytic anaerobic organisms are concerned. Reference has already been made in earlier chapters to the state of muscle stupor, which is so common in the immediate neighborhood of modern wounds, a state in which such muscle does not bleed and does not contract when stimulated. Muscle in this condition has no powers of vital resistance. It is for the time being a mere dead mass of organic matter, which is from the chemical point of view an inert and rich accumulation of muscle sugar and protein. The muscle sugar or glucose is a substance most readily fermentable, and no resistance is offered to agents which endeavor to ferment it. Hence, a carte blanche is given to any sugar-splitting anaerobes which may, and usually do, chance to be present in the wound. They have a rich storehouse of suitable food to luxuriate in, and nothing to prevent them doing so. They begin, therefore, to develop with enormous rapidity at the expense of tissue, and once their growth has become established, they have a way of their own of providing for the continuance of their growth and the spread of the gangrenous process. This end they are able to achieve in a considerable proportion of cases, although in many the spread is arrested. The spread of the gangrenous process appears to be aided by another characteristic of the muscle injury, namely the microscopic separation of the muscle fibers and fibrillae, which may occur for some distance above and below the penetrated part of the muscle immediately on being hit by modern missiles. This point will be referred to later in more detail. 2. Absence of oxygen at the site of initiation of gas gangrene. Absence of oxygen is essential for the growth and development of anaerobic organisms. It is a condition brought about in recent wounds by two factors, A, muscle edema, and B, aerobic organisms. A. The muscle swelling or edema which supervenes within an hour or two of the infliction of the wound has been elsewhere described. This swelling tends to obliterate rapidly the communications between the wound interior and the open air. If the wound of entry be small, the muscle often herniates through it, completely cutting off air entry into the wound surface. But even if this complete exclusion of air be not brought about, the irregularities of the walls and floor of the wound are such that the muscle swelling must often succeed in rendering little spaces and cavities airtight, and by absorption of oxygen such spaces soon become oxygen-free. These spaces are the sites of initiation of the gas gangrene process. See Plate 2. B. The second factor which tends to produce absence of oxygen in wounds, and especially in airtight spaces in wounds, is the presence of aerobic organisms. These are practically always introduced along with the anaerobes. They grow readily in all kinds of wounds, and during their growth absorb oxygen greedily. This can be experimentally shown in the laboratory by culturing aerobes along with anaerobes in an airtight apparatus where the amount of air is limited. For example, if two test tubes of culture medium be joined by a U-shaped rubber tube and a vigorous aerobe such as B. subtilis sewn on one medium and an anaerobe on the other medium, the oxygen absorption produced by the aerobe is in itself sufficient to allow the anaerobe to develop. The oxygen absorption in such an apparatus is almost as great as would be produced if a solution of pyrogalate of potash were substituted for the aerobic culture in the second tube. Hence, the presence of aerobic organisms appears to favor strongly the absence of oxygen in closed tissue spaces and thus indirectly favors the onset of gas gangrene. 3. Presence of multiple infection. The type of multiple infection which is so favorable to gas gangrene initiation is a combined aerobic and anaerobic infection. Such has often been proved to be present in 70 or 80% of all war wounds. The aerobes act not only by absorbing oxygen, as has been already explained, but are also symbiotic in two other ways. A, by their toxic action, whereby they further devitalize the tissues, and B, by taking up the attention of any polymorphonuclear leukocytes or other phagocytes which may gain access to the site of activity. With regard to A, it is to be remembered that the causal anaerobes of gas gangrene have no power of growing in healthy, active, living tissue, and that anything which produces a local devitalization of tissue, such as the toxins of aerobes, has a most powerful influence in aiding the onset of gangrene. This point has been proved many times by animal inoculations. We may in particular quote those performed by Dean and Watt with strains of B. aerogens capsulatus, B. pifrinogens, and of B. edematous malingi, B. sporogens, which they injected into guinea pigs. Their conclusions were as follows. 1. The subcutaneous injection of pure strains does not, as a rule, produce any signs or symptoms of disease. 2. If the tissues are damaged by a parasitic microorganism, Staphylococcus aureus was used, foreign body, or other irritant, the introduction of B. aerogens capsulatus or B. edematous maligni may, in a comparatively small number of cases, lead to local gangrene and the death of the animal. Tissier, in experiments already quoted, page 51, goes further and finds that if the tissue into which the animal injections are made be damaged, as in wounds, gangrene can be produced in practically every case by injection of aerobic with anaerobic cultures. Further, the more virulent the aerobe which is associated with the anaerobe in these injections, the more quickly is the death of the animal produced. He finds that the Streptococcus pyogenes is the aerobe which favors the greatest degree of anaerobic activity. This is of the greatest interest and importance in view of the fact that the commonest combination of aerobe and anaerobe in wounds is a Streptococcus and B. pifrinogens. The practical universality of mixed aerobic and anaerobic infection in gangrenous wounds points also to the importance of such symbiosis. The Streptococcus is well known to be one of the most harmful aerobes to tissue in a local or spreading inflammation, and it seems probable that its local toxic and devitalizing action is a factor of great importance in determining the onset of gas gangrene. With regard to B, another aspect of the symbiosis of aerobic and anaerobic bacteria in wounds is brought into view. It is the fact that anything which prevents, in some degree, phagocytosis of anaerobes aids their growth. In this connection, Tissier's further observations are important. He found that Vibrio septique, harmless in a dose of 2 cc of a liquid culture if alone, when mixed with Staphylococcus albus, kills a guinea pig with damaged tissues in 20 hours, and when associated with Staphylococcus albus and B. mesentericus fuscus, kills in 6 hours. That the presence of a harmless organism like B. mesentericus should make such a great difference to the result is a fact of considerable interest and importance. B. mesentericus, when injected alone into animals, produces practically no effect and is rapidly removed by phagocytes. Now, it is well established by numerous observations on non-gangrenous wounds containing anaerobes, and also on wounds in which gas gangrene is spreading, that anaerobes are very readily phagocyted by the polynuclears and macrophages, but that in spreading gas gangrene, the process may be so rapid that these organisms rapidly outdistance the phagocytes. These facts would appear then to suggest that primary phagocytosis of the anaerobes, which is after all merely a phase of healthy tissue reaction, is of great importance in preventing the onset of gas gangrene. If this be so, it seems to suggest a possible explanation of the experiments with B. mesentericus, namely that the latter organism, by attracting to itself the available polynuclear phagocytes, thereby leaves the anaerobe more free to establish itself. If such be the case with B. mesentericus, it must be still more true of more virulent aerobes. The theory further accords with the well-known fact that multiple mixed infection is the rule in gangrenous wounds, and it suggests another way in which the aerobes in wounds foster the activity of the anaerobes. 4. Presence of devitalizing general conditions, especially fatigue, shock, and hemorrhage. The influence of these conditions appears to be all-important in determining the relative frequency of gas gangrene in a series of wounded men and also its degree of severity. This point has been previously dealt with, and there remains to be added the experience gained during fighting periods and during quiet times on this front. In quiet times, when occasional men are hit by shell fire while doing their normal rounds of duty in the trenches, gas gangrene is quite a rare complication of wounds. In 2 large rushes of casualties which occurred, however, after long and arduous artillery and other military preparations involving for the men much night work with excitement, loss of sleep, hard physical work, and finally the exacting work of uphill fighting in the open, great majority of the wounds were gas gangrenous. In a large proportion of these, the other conditions were almost the same as in wounds received in quiet times. The same type of high explosive was employed, and many of the wounds were treated almost as expeditiously as in normal times, and yet they became gangrenous. This striking fact is illustrated also in other fronts at the present time, where the incidence of gas gangrene has much diminished since the earlier part of the war, although conditions of tissue injury, multiple infection, etc., remain the same. The explanation may be in part due to a prompter and better mode of treatment of the wounds, but undoubtedly the most predominant fact is the difference in the physical condition of the men at the moment of receiving the wound. They are now more often relieved, and their physical welfare attended to much more efficiently. Lastly, the fulminating type of gas gangrene, which has been previously described with special reference to those wounded men whose bodies were seen swollen with gas almost to double their normal size within 8 to 12 hours after the infliction of the wound, is a rare experience at the present time, and this fact seems to point also in the same direction, that the devitalizing conditions of fatigue which then existed were highly important predisposing causes, not only of gas gangrene, but of the severest type of gas gangrene. It should always be remembered that gas gangrene cannot supervene in the living body unless there be a very greatly diminished tissue resistance. This is a sine qua non of gas gangrene in wounds, for the infection is present in nearly all cases. Conditions of severe fatigue and also obviously of shock and hemorrhage, which notoriously weaken the vital reactions of the tissues, cannot fail, therefore, to be of immense importance in determining the incidence and severity of gas infection. Exciting causes of gas gangrene. These are, of course, the anaerobic bacteria, whose source is fecal material, and whose spores gain access to wounds in pieces of clothing and soil carried in by the missile. These have been dealt with in detail in the chapter on the bacteria of wounds. Pathology. On this important and interesting subject, a new literature has sprung up in the past 2 or 3 years. The earlier papers on this subject were by Dest Emery and Kenneth Taylor, who took somewhat different views of the gangrenous process. These views were summarized later by Cuthbert Wallace as follows. Dest Emery's view. The toxin kills the leukocytes, which are the natural protection of the body. To have a sufficient supply of these, it is necessary that the circulation be intact. Therefore, tissue devitalized by trauma, by constriction of the limb, or by actual damage will favor the disease. Why, however, does the disease not stop when healthy tissue is reached? The explanation lies in the fact that the toxin, when present in large amounts, inhibits immigration and kills the leukocytes. If there is no free escape, the toxin accumulates to such an extent that it soaks through the healthy tissue and kills the defensive leukocytes, and so the gangrene spreads. Taylor's view. The mechanical action of the pressure produced by the gas is usually, if not always, the most important part of the infection. It brings about the death of the tissues from A, the resulting anemia, B, the actual mechanical fragmentation of the muscle substance, C, the mechanical scattering of the infection. He shows in the earlier part of his paper that the experimental injection of the exotoxin produces softening of muscle and parenchymatous degeneration of the liver cells. His experiments in vitro show the same effect on pieces of muscle. He suggests that the rapid systemic intoxication is produced by the breaking down of the muscle substance, as injection of the exotoxin does not produce an effect comparable to that seen in the clinical course of the disease. Cuthbert Wallace points out that these two theories differ mainly in the part played by the gas. Taylor thinks it plays the most important part in the spread of infection, while Dest-Emery lays most stress on the bacterial toxins. Taylor believes that the disease is mainly one of muscles. Dest-Emery thinks that this is a mistake, and that it is only the fact that there is so much gas produced from muscle sugar that leads to this assumption. In commenting upon gas gangrene from his own experience, Cuthbert Wallace gives it as his impression that the disease is chiefly one of the muscles. The tendency of later writers, such as McNee and Dunn, has been to regard the disease as essentially one of the muscles. The latter writers have made a careful and elaborate investigation into the method of spread of gas gangrene into living muscle, from which they conclude that the rapidity of spread is accounted for by the peculiar anatomical structure of the muscle tissue. The sheaths enclosing the long individual fibers are so easily detachable as to form potential spaces into which toxic material can readily pass, causing necrosis of the fibers. It is obvious, therefore, that some confusion of thought exists as to the actual sequence of events in the spread of gas gangrene. The present writers, in view of experience gained in the line, at the casualty clearing station and the base hospital on two fronts, are not disposed to concur entirely with this later tendency to regard the disease as essentially one of the muscles. It is admitted that muscle is involved in by far the vast majority of cases of gas gangrene. The reason for this is, however, believed to be that in the vast majority of severe wounds with gross damage to tissue, muscle is one of the tissues most severely involved, and also that grossly injured muscle is a very favorable medium for the growth of sugar-splitting anaerobes. On the other hand, however, numerous cases have been met with in which the disease has been both confined to tissue other than muscle and has been observed to spread in tissue other than muscle. In proof of this point, the authors can quote 6 types of wounds which they have observed. 1. Hemothorax cases in which localized areas of gas gangrene occur in the extravasated blood clot. In penetrating chest wounds with hemothorax gas gangrene never occurs where there is free air entry into the open pleural space. But in a large number of these cases, the pleurae very rapidly shut off from the wound accumulations of extravasated blood. If B. perfringens or other anaerobe has chanced to lodge in these, it finds itself implanted in a most suitable culture medium under anaerobic conditions. B. perfringens is well known to have no power of growing in healthy fresh serum, but it grows vigorously in serum from the body after death and in serum which has been trypsinized, and occasionally also in the bloodstream during life when that has been altered by the presence of another organism or by some devitalizing condition. It is the same with blood which has been extravasated and bottled up in the tissues for some time. It is an inert dead mass and practically a foreign body. As such, it is a culture medium most suited to the tastes of B. perfringens. Hence, in those closed-in accumulations of extravasated blood in the pleural cavity, we often find circumscribed putrid areas of gas gangrene. 2. Retroperitoneal hematomata caused by spent pieces of shell. Gas gangrene is well known to occur in these and to spread round to the anterior abdominal wall, not in the abdominal muscles, but in the retroperitoneal areolar tissue. It is true that here the muscle in the neighborhood of the wound is also damaged, though usually not very grossly so. But in most of these cases, no evidence of anaerobic activity is found in the muscles, and the gaseous edema is confined to the cellular tissue. Here again, in the blood clot, deep down in the wound and far away from the atmospheric oxygen, a suitable anaerobic culture medium is formed for the causal organisms. 3. Gas gangrene of the brain. A considerable number of these cases have been seen. Here it is the brain tissue which is affected by the gangrenous process. Gas gangrene practically never spreads in the membranes, for they quickly shut themselves off, and in addition, like all serous membranes which are actively phagocytic, they have very great powers of resistance to anaerobes. 4. Gas gangrene in wounds of subcutaneous tissue only, muscle not being involved. This was seen by one of us in the earlier days of the war again and again in the line. The case is recalled in particular of a regiment which took part in a famous battle in May 1915. When these men went into the trenches to take the place of another unit, they were hardly able to crawl and were in fact worn out with fatigue. Many of these men fell victims to machine gun bullets. Some of them were seen 8 hours after being hit, and they were then dead, and the whole of their subcutaneous tissues blown up with gas. One such case in particular is recalled, which was examined most carefully for wounds, and the only one discoverable was a superficial bullet wound of the thigh, which had not penetrated the deep fascia. Such cases rarely occur now, and are probably accounted for by the extremely fatigued condition of the men at the time of being hit. 5. Gas gangrene in the subcutaneous tissue following surgical emphysema. One remarkable case of this nature was seen by one of us. This was a penetrating wound of the chest with extensive surgical emphysema all over the trunk and genitals. Within 48 hours, this emphysematous area became the seat of gas gangrene, which spread rapidly throughout the subcutaneous tissue and brought about the fatal issue. It should be remembered in this connection that when the entry of the air into a surgical emphysema is stopped, the air becomes very rapidly absorbed, and it has been proved that the oxygen of this air is absorbed more quickly than the nitrogen. Thus, within a day or so, there would remain a large area of subcutaneous tissue with meshes filled with nitrogen. Such tissue, insofar as the separation of the planes is concerned, resembles the similar condition in recently wounded muscle, and in the latter, B. perfinogens luxuriates very commonly. 6. Gas gangrene spreading upwards in a limb in the areolar tissue around the vessels, in the intermuscular septa, and in the subcutaneous tissue. This is a matter of common experience in connection with wounds of the leg. If the muscle be damaged and gas gangrene occur, it commonly spreads upwards in the muscle sheath and between the fibers until it reaches the insertions of the muscle around the knee joint. Its further upward spread takes place in the areolar tissue around the great vessels, whence it spreads into the subfascial areolar tissue planes of the thigh. In an amputation through the thigh performed for such spreading gangrene, this areolar tissue can nearly always be seen to be greenish-yellow and edematous or even gelatinous. In some cases, the upward spread from the leg wound takes place in the subcutaneous connective tissue, whence the process spreads to that of the thigh. These are the cases in which the thigh becomes crepitant. End of Chapter 7, Part 1. Chapter 7, Part 2 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery, From Firing Line to Base, by Basil HUGHES and H. Stanley Banks. Chapter 7, General Complications of Wounds, Part 2. From what has been said, it becomes evident that gas gangrene is a disease of any devitalized tissue. The only tissue which seems almost exempt from its action is that of serous membranes. the reason probably being that they are so actively phagocytic and that B. perfrinogens and other anaerobes very readily succumb to phagocytic action, especially to that of macrophages. Even serous membranes are, however, not in every case exempt, for we have seen very occasional cases of gas gangrene in the peritoneal cavity and in the knee joint, and more commonly in the pleural cavity, as already stated. At the same time, however, it is in the muscles that gas gangrene is found most frequently and most typically present, the reasons probably being that muscle is so frequently damaged in war wounds, that the damage is of a special kind, and that the damaged muscle is an exceptionally favorable medium for B. perfrinogens, which is the most common primary causal organism. In many cases, as is well known, the infection is contained entirely within a single muscle or group of muscles, and the disease can be arrested by ablation of such muscle or group. What is the special nature of the damage done to muscle in a war wound? One of us had the opportunity while in the line of securing a number of specimens of wounded muscle within a few minutes of the infliction of the wound. These specimens included the part of the muscle actually penetrated by the missile, the varying lengths of the muscle above and below the wound which did not contract nor bleed, and a certain amount of healthy living muscle in the parts distal to the latter. The specimens were cut off with a sharp scalpel and immediately placed in 75% spirit. Subsequently, the tissues were dehydrated, embedded, and cut. The sections show the appearances illustrated in Plate 2. The striking abnormality presented by sections through the muscle stupor area was the presence of considerable spaces within the individual muscle fibers and between them and the sheaths. In the neighborhood of these spaces, the fibrillae had a crushed appearance. These spaces in the fibers and between fiber and sheath were shown by serial sections to extend for a varying distance of 1 inch or more up and down the muscle on each side of the wound. In some cases, these appearances extended in modified degree almost to origin and insertion of the muscle. In another set of sections of muscle removed about 2 hours after the infliction of the wound, when the muscle was in the state of acute muscle edema, the following appearances were presented. The spaces between fiber and sheath were larger than those of the first set and extended a great part of the way or the whole way around the fiber, so that the fiber was partially or wholly cut off from its blood supply in the sheath. In some sections, spaces were also seen within the fibers themselves. It was presumed that these spaces had been filled with extravasated lymph. At the time when the sections were taken, there were no appearances of the onset of infection. McNee and Dunn have shown that in a muscle in which spreading gas gangrene is occurring, the following appearances are presented in the part distal to that which is actually gangrenous. 1. Many of the fibers are completely separated from their sheaths by considerable spaces. 2. Those fibers which are so cut off from their blood supply show coagulation necrosis. 3. The other fibers in the section show paler staining reaction and partial loss of striation. 4. These appearances gradually tail off as normal muscle is reached. We have been led to believe from such histological work and from our clinical experience that the sequence of events when a wounded muscle becomes invaded by gas gangrene is usually represented in the following stages. 1. Disruption. 2. Lymph exudation. 3. Infection. 4. Gas and toxin formation. 5. Extension. 1. Disruption. The mechanical effect of the missile is to drive a volume of compressed air into the muscle substance. This air, following the path of least resistance, is simultaneously forced up and down the muscle substance between and within the individual fibers, separating them from their sheaths. Air spaces are thus produced between and within the fibers for a varying distance in the muscle on each side of the penetrated part. At the same time, the vitality of the fibers themselves is impaired by the mechanical violence and by the anemia produced by pressure of the air and the interruption of the blood supply. 2. Lymph exudation. Within a short time, reactionary edema occurs, the spaces become filled with lymph, and the muscle swells. The lymph coagulates, the muscle herniates out of the wound owing to increased pressure, and access of air to deeper parts of the wound may be cut off. The fibers are devitalized from pressure and consequent diminution of their blood supply. 3. Infection. The anaerobes introduced into the depths of the wound along with the micelle find in the devitalized muscle fibers the coagulated lymph in the muscle spaces and the absence of oxygen congenial conditions for their growth and development. 4. Gas and toxin formation. The saccharolytic group, especially B perfinogens, are the first to act vigorously. They ferment the muscle sugar, forming acids and non-odorous gases, and cause the muscle to die and its color to change to brick red. A proteolytic action next takes place, and this is caused in part also by B perfinogens, but chiefly by the proteolytic group of anaerobes, of which B sporogenes is the commonest. The result of the protein lysis is the liquefaction of the lymph and putrefaction of the muscle fiber. The liquefaction of the lymph may be partly due to aerobic organisms. From the muscle proteins are formed amino acids, ammonia bodies, and malodorous gases, mostly compounds of sulfur, and the affected muscle at this stage becomes blackened by the interaction of the iron from hemoglobin and the sulfur. The typical and profound toxemia of gas gangrene now occurs, the chief agents probably being, as Dale has shown, the extremely toxic ammonia bodies formed from disintegrated protein. To a certain extent, also, the milder true bacterial exotoxins exert their poisonous action on muscle and liver cells. 5. Extension. Gas formation, which commenced early in the stage of infection, steadily increases and exerts an increasing pressure. This pressure enables the gas to pass further up into the normal muscle together with the liquefied lymph, stripping the muscle fibers from their sheaths and causing their devitalization by pressure and consequent anemia. The diffusible toxins from the actively gangrenous area rapidly pass up in the lymph stream and in the liquefied extravasated lymph within the fiber sheaths, causing necrosis of the stripped and devitalized fibers. B perfinogens and later other anaerobes rapidly follow in the same paths and ferment and digest the necrosed fibers. A vicious circle is produced, and more tissue becomes gangrenous and more toxin is produced as the process extends. The advance of the process is so rapid that a leukocytic reaction cannot develop in time to check it. Hence, in rapidly spreading gas gangrene, the bacilli are always found in advance of the leukocytes. When the end of a muscle is reached, the toxin-containing fluid may be forced into the areolar tissue around the vessels and by this route spread into the remoter parts. Ablation of the infected muscle before the infection has passed beyond it may stop the process. The process may also be arrested by free incisions through the advancing infected fluid in the muscle sheaths, whereby the anaerobes are rendered less able to attack the devitalized fibers. If in any way the rapidity of the process is arrested, a leukocytic reaction is able to develop, the bacilli are phagocyted, and the gangrene becomes localized. During this saccharolytic period of muscle invasion, the color of the muscle is brick red, and its consistence friable and spongy and not unlike congested lung tissue. This is the stage of red death. When the proteolytic period begins, the color changes to an olive green and thence to a glistening black, and the odors at the commencement of this stage are very foul. This is the Black Death stage. As gas accumulates, the skin becomes tense, dirty white, then mottled with purplish areas, and finally blubbed, the blubs containing fluid stained with altered blood. In tissues of the body other than muscle, the initiation and spread of gas gangrene is exactly similar, except that it is a much slower process and more liable to become arrested and localized at any stage. Extravasated blood, brain, and areolar tissue are less readily fermentable substances than is muscle, and less suitable as pabulum for anaerobes. In addition, the spaces in their substances into which toxic fluid can pass are much less easily formed than in the case of muscle, where fibers separate readily from sheath. In some cases, however, such as in gas gangrene superimposed on a surgical emphysema, where the tissue spaces are already opened up, the spread may be very rapid. In case of severe fatigue, the vital resistance is much diminished and the rate of spread correspondingly increased. The final stage of gas gangrene is successful invasion of the bloodstream by the bacilli. This occurs when the blood is sufficiently altered to permit of it. In most cases, the change is not brought about until just before death, but in occasional cases, the bacilli enter the bloodstream at a comparatively early stage and cause paemia or metastatic gas gangrene. Such a condition is almost invariably fatal, although a few recoveries have been reported. Symptoms of gas gangrene. Symptoms will depend upon whether the condition is early or late. Early gas infection may give rise to no symptoms at all beyond pain. A very large proportion of war wounds contain the gas gangrene bacillus. In many of these, the infection never becomes established. In others, it is arrested at a very early stage and the symptoms are minimal. Gas gangrene gives rise to definite symptoms only when it has firmly established itself. Intermediate stage. In what may be called the intermediate stage, there is much pain owing to swelling, and the affected part is usually resonant to percussion. At this stage, constitutional symptoms due to toxemia are present. The lips present a peculiar cyanotic color which is typical of the condition. The patient looks ill, the pulse is rapid, and the temperature varies between 102 degrees and 103 degrees Fahrenheit. Gangrenous stage. In the final or gangrenous stage, the skin assumes all hues from a brick red to a blackish green. Blebs appear containing both fluid and gas. The typical smell of gas gangrene is present, and the whole part is now painless and dead. Constitutional symptoms, the result of toxemia at this stage, are most pronounced. The patient is ashen about the face, cyanotic about the lips, the skin is cold and clammy, the temperature is often subnormal, the pulse running and weak, and often there is coffee ground vomiting. The prognosis in the latter stage is exceedingly grave, and many of these patients die unless rapid and energetic measures be taken. Diagnosis. The whole secret of success in treatment lies in an early diagnosis. The first important observation to be made is whether or not a swollen condition of the tissue is present in the neighborhood of the wound. Secondly, is the foreign body still in the tissue or has it emerged? If there be swelling of the wounded part, and if the wound of entry be caused by a small missile, the swelling may be due to one of the three following causes. 1. Hemorrhage into the tissues, the result of a wounded vessel. 2. Edema of the tissues due to trauma. 3. Gas formation. In the case of hemorrhage, the limb is uniformly swollen and firm to the hand. The pulse in the vessels below may be good, and on gently compressing the limb, blood clot can often be expressed from the wound of entry. The swelling is dull to percussion, and pain, though present, is not acute. Finally, the situation of the wound may give some indication as to the possible source of the hemorrhage, and an X-ray will confirm the presence or absence of gas in the tissues. If the swelling be due to traumatic edema, there is acute pain on palpation, with herniation of muscle from the wound, and the part is non-resonant. As a rule, at this stage, there are no constitutional symptoms. If the swelling be due to gas formation, the part is tender to the touch, it is resonant to percussion, and constitutional symptoms are present. If the foreign body be still in the tissues, and if there be no obvious swelling of the part, though pain be present, an X-ray will reveal not only the position of the foreign body, but also the presence of gas. If doubt exists about the gas shadows shown on the plate, another X-ray taken an hour later will determine whether the shadows have altered in size. If this be the case, it may be concluded that gas formation is progressing. The general condition and appearance of the patient are valuable guides, for there is a characteristic facies already referred to associated with gas gangrene toxemia. In the advanced stage, when the skin is discolored and blebbed, the diagnosis is obvious. Complications of gas gangrene. These are 1. Local spread of the condition, 2. Gas gangrene septicemia, 3. Gas gangrene pyemia. The rate of spread of gas gangrene in the tissues varies. In some instances, it is slowly progressive. A wound may have been satisfactorily excised, leaving a resulting wound surface which to the naked eye appeared both clean and healthy. Within the next few hours, the tissues adjacent to and at some distance from the wound itself are found to be the seat of a spreading gas gangrene. On the other hand, the rate of spread may be much more rapid, as is shown by the following example. Lieutenant Blank was wounded on August 4, 1916 in France. He arrived at a casualty clearing station 12 hours later with a large, dirty wound of his right leg involving a compound comminuted fracture of the tibia. The wound was excised piecemeal and a suitable dressing applied, in this case a salt pack owing to hemorrhage. 5 hours later he was cyanotic about the lips, was an ashen color, and was vomiting. An examination revealed a spreading gas phlegmon which had reached halfway up the thigh. A rapid guillotine amputation through apparently sound tissue was performed, and both arrest of the gas infection and recovery of the patient followed. Gas gangrene may be lighted up in a wound which has settled down and appears to be undergoing a satisfactory and uncomplicated course of sterilization. The following case illustrates a not uncommon occurrence. Private Blank was wounded on May 8, 1917, in the Balkans. He sustained a compound comminuted fracture of the right humerus in its upper third, which involved the shoulder joint, and a severe compound comminuted fracture of the right femur in its lower third involving the knee joint. The comminution in the case of the femur had contused the popliteal vessels. All went well until the 10th day after the injury, both temperature and pulse being normal. Suddenly and without warning, a severe secondary hemorrhage occurred from the damaged popliteal vessels. An amputation was performed through apparently healthy tissue, yet within 2 hours of the amputation, the stump being left open, a fulminating gas gangrene starting from the stump and spreading up the thigh to the abdominal wall occurred, and death followed in a few hours. Gas gangrene septicemia. B. perfringens septicemia, though comparatively rare, has nevertheless occurred in a number of cases. It would appear that a severe toxemia, the result of gas gangrene, is a far more rapidly fatal condition than that of a true gas gangrene septicemia. In the former case, cyanosis of the lips, an ashen appearance of the facies, a cold, clammy skin with a rapid, weak pulse, subnormal temperature, and biliary vomiting constitute the typical picture. In strong contrast are the symptoms of gas gangrene septicemia, for here the patient has usually a good color, the tongue is clean and moist, the appetite is good, the evening temperature reaches 102 degrees to 103 degrees Fahrenheit, coming down to normal or below normal each morning. This type of septicemia may continue for days or weeks, the patient still keeping up, until finally the blood infection becomes complicated by the presence of other organisms, either streptococci, staphylococci, or even B. coli. At this stage, the patient steadily takes a downhill course. He goes to skin and bone, bed sores supervene, and he dies. We have, however, seen a few cases of uncomplicated gas gangrene septicemia recover. Gas gangrene pyemia. This rare condition is usually a complication of wounds in which bones, chiefly of the lower extremity, are involved. The appearance of these metastases is most extraordinarily rapid and unexpected, and when once established, the condition is extremely fatal and death rapidly follows. 1 or 2 examples will best illustrate this complication. Private Blank fell off the back of a lorry, sustaining a severe compound fracture of the left tibia and fibula in the lower third. He was admitted to hospital, where the wound was immediately attended to under an anesthetic. On the following day, despite the regular hourly installation of the hypochlorites, his leg had become gangrenous up to the knee. Amputation was performed through the lower third of the thigh, the flap stitched open, and regular hourly installation of antiseptic into the stump was carried out. The same evening he was rational, taking food and reading a magazine. He complained, however, while one of us was in the ward, of some stiffness over his left scapula. An examination at 8 p.m. revealed nothing. At 3 a.m. there was a large area over the posterior triangle of the neck, which was crepitant and had commenced to become discolored. At 4 a.m. he was dead. An early post-mortem examination revealed gas in all the organs of the body, and a histological examination of the liver and heart muscle revealed a condition of acute autolysis. A bacteriological examination of the heart's blood very soon after death showed B. perfringens to be present in pure culture. Private Blank sustained a gunshot wound of the left thigh involving only soft structures. The wound was lacerated, but appeared to be clean and sterilizing satisfactorily. On the second night after admission, that is, the third day after injury, he complained of pain in the right buttock, and an examination revealed a brick-red, blebbed, and crepitant condition of the skin and subcutaneous tissues. He had commenced to vomit and presented all the symptoms of an acute gas gangrene toxemia. He died 2 hours later. The post-mortem findings were identical with those of the preceding case. We have witnessed 2 cases where gas gangrene metastasis has occurred in the lung. One of these cases, which was associated with a severe compound fracture of the femur, recovered. The other case, associated with a wound of the opposite lung, died. The latter case is especially interesting in that there was a second infarct in the penis. The result was at first an acute, painful state of priapism. Later, the penis became crepitant, very discolored, he could not pass water, and a catheter passed only with difficulty. Free incisions were made into the organ, which, however, did not arrest the gangrene. He lingered for 10 days before death. In both these cases of lung metastasis, the breath was very foul and pungent, the odor resembling that of true gangrene of the lung. Treatment of gas gangrene. It would seem that surgical measures alone are in a number of cases insufficient to arrest the progress and spread of this condition. There is evidently something more than the exciting cause to be dealt with, and the more we see of the condition, the more we realize this important fact. After a wide experience of wounds extending over 3 years, we are day by day coming to the conclusion that the general condition of the soldier at the time he is wounded is of paramount importance in determining the onset or severity of gas gangrene. Surgical attention to the wounds and the parts around it must form the mainstay of treatment when the condition is well established, but it should ever be remembered that this is in a broad sense only a fraction of the treatment. The treatment of gas gangrene will comprise 1. Treatment in the line and at the forward units. 2. Treatment at the casualty clearing station. 3. Treatment at the base hospital. Treatment in the line and at the forward units. Treatment here is mainly prophylactic and aims at improving the general condition and helping the natural powers of resistance. All wounded men should, if possible, be made thoroughly warm, given hot and nourishing drinks, with stimulants if shock be present. Hemorrhage should be immediately arrested, and any fracture should be securely immobilized prior to transport. At the advanced dressing station, further hot drink should be administered, and food if the patient can take it. A short sleep, if conditions permit, is most desirable before transport to the field ambulance. If available, large quantities of sodium bicarbonate should be given by mouth. At the field ambulance, the wounded part should be inspected and the dressing removed. The wound should be filled with hypochlorite solution, and a gauze dressing soaked in this antiseptic should be laid over it. Over this, a piece of jaconet should be placed, and wool with a loosely applied bandage completes the dressing. Hot, stimulating drinks should be given at this unit, and a sleep allowed if conditions permit. Glucose and sodium bicarbonate should be administered by mouth if the patient can take it. It may happen, however, that in some situations it is impossible to get a wounded man out of the line immediately, and he has to stay for some hours at the regimental aid post. In this case, the first field dressing must be removed and the wound filled with Dakin solution or Usol and a loose dressing applied. The limb must be carefully watched for any swelling. Should gas gangrene supervene, and we have seen this occur within 2 hours of being wounded, and should the condition be spreading, then amputation is the only hope. Men arriving at the field ambulance with limbs gangrenous and dead should undergo amputation at once. They should not be sent on to the casualty clearing station in this condition unless it is absolutely necessary. During the operation, normal saline solution should be administered intravenously or subcutaneously, and with it 3 or 4 teaspoonfuls of sodium bicarbonate to the pint. This latter drug has often done good in bad cases. It is highly probable that its beneficial action is due to the neutralization of the acid products of fatigue present in the tissues at this stage. Should gas gangrene be established in a wound by the time the field ambulance is reached, and should it be slowly spreading, then excision of the wound with free incisions into adjacent tissues and the application of a Carrel-Dakin dressing should be practiced. Field ambulances, as we knew them in France, had not only the accommodation and equipment necessary for doing this work, but they had many competent surgeons willing and eager to carry it out. From what we saw at the casualty clearing station, surgical work performed at the field ambulances was always good and sound, and patients who had been fortunate enough to receive early treatment at these units invariably did well. Treatment at the casualty clearing station. Treatment is both local and general, and depends upon the degree of gas infection present in the wound and neighboring tissues. The 4 chief types of gas infection seen at these latter units are 1. A gas infection localized and confined to the wound, 2. A slowly spreading type, 3. Cases in which single muscles or groups of muscles have been picked out, 4. A fulminating type. 1. Gas infection localized and confined to the wound. This condition is always an indication that the wounded man is holding his own against the infection. Hence, at this stage, nothing must be done which may in any way jeopardize his chances by diminishing his resisting powers. A rapid excision of the wound should be performed under ether anesthesia, normal saline with bicarbonate being slowly administered intravenously during the operation. The wound, now excised, should be immediately submitted to a process of continuous sterilization by the Carrel-Dakin method and the patient returned to bed and made warm. Let it be repeated that the operation should be carried out with all possible speed, for a long operation is at this stage most harmful and may easily turn the scale in the wrong direction. 2. The slowly spreading type of gas gangrene. Excision of the wound must be carried out with all possible speed in this class of case. This completed, free incisions must be made into the neighboring tissues down to and including the deep fascia, and extending well beyond the limits of spread of the infection. Continuous sterilization is now started at once by the Carrel-Dakin method, and the patient is sent on to the base hospital as soon as possible. 3. Cases in which a solitary muscle or groups of muscles have been singled out. Treatment here is complete excision of the affected muscle or groups of muscles. It is useless to try and remove part only of an infected muscle, as the process will certainly recur in that part that has been left behind. After excision has been performed, a Carrel-Dakin dressing is applied and the patient evacuated as soon as possible to the base. 4. The fulminating type. Here the rate of spread of infection is so rapid that within a few hours not only may a whole limb be dead and putrid, but the process may have encroached for some considerable distance onto the trunk. Immediate amputation by the most rapid means possible is the only treatment, and although the diseased condition of a limb may have extended so far that healthy flaps cannot be fashioned, the surgeon should not hesitate to perform amputation, even if he have to do it through unsound or even gangrenous tissue. In cases where the disease has extended from the limb to the trunk, high amputation should still be carried out, and free incisions made into the diseased tissues of the stump and trunk, such incisions extending well beyond the limits of the disease. These amputation stumps are usually of the guillotine or flesh variety, and both to them and the diseased incised tissues above them a Karel-Dakin dressing is applied and an energetic continuous sterilization started with as little delay as possible. If the gangrenous process has reached a level below the knee, amputation can be carried out in the lower third of the thigh. We have laterally employed the method of equal long anterior and posterior skin flaps with a guillotine division of the muscles at a higher level and a division of the bone still higher up. Should the flaps contain much disease, they are stitched back and the open stump is submitted to continuous sterilization by the Karel-Dakin process. If, on the other hand, the flaps appear to be sound, they are brought together with 5 or 6 sutures and Karel's tubes are included in the stump. Hourly installation of the antiseptic into the stump is carried out, and in a large percentage of cases the stump has healed without any trouble. A number of cases arrive at the casualty clearing stations in a desperate condition of toxemia. The main point that the surgeon should aim at is to cut off the supply of toxin to the individual, and this can only be done by removing the diseased part. Even though he can remove only part of the diseased tissues by amputation through gangrenous material, he is nevertheless diminishing the dose of toxin the patient is receiving. We have now performed very many amputations through gangrenous tissue, and in a considerable number of these the disease has spread to the trunk. Results quite justify the procedure, and out of a special series of 50 cases treated at a base hospital, there were 12 deaths and 38 recoveries. Out of the 50 cases, gangrene had reached the trunk in 6, and out of the 6, 3 recovered. In every case, amputation was performed through gangrenous tissue. This then gives a recovery of 76%. All the 38 cases were kept until the stumps had healed, and all were submitted to secondary suture. It would appear that when once as large a part as possible of the disease is removed from the individual, with a proportionate reduction in the amount of toxin absorbed, then with the aid of active antiseptic measures, the patient's resistance is often sufficient to overcome the remaining infection. It must be remembered that amputation in these desperate cases has to be carried out very rapidly, and the quickest method is the flush amputation. Should the leg be involved and the condition of the patient critical, flush amputation through the knee joint is the quickest and safest method, taking care to remove the patella. There are no hard and fast rules to be laid down in the methods of performing these amputations, for each case must be treated by whatever method is quickest and best. A flush amputation should not take longer than 5 to 7 minutes from start to finish, and we have now done a considerable number in this time under gas anesthesia. There is little shock, in fact, far less shock than is occasioned by the use of other general anesthetics, and the poisonous effect of such general anesthetics on the internal organs of excretion already overloaded with toxins is thereby avoided. During the operation, saline solution with sodium bicarbonate and brandy should be run into the subcutaneous tissues of the axilla. 2 pints of saline and bicarbonate with 1 ounce of brandy has been the amount we have always employed. On return to bed, hot water bottles are applied and the patient soon breaks into a sweat. Calomel, 5 grains, should be given at once, followed by a dose of salts and an enema if necessary. Hot, stimulating drinks and easily digestible food are given, and glucose in doses of 1 drachm 3 times a day seems to do good in these cases. We have administered glucose both by mouth and rectum very frequently to these cases, and certainly it seems to have an effect which is both immediate and lasting, and we can strongly recommend it. When the trunk is involved, the disease usually occurs in the abdominal wall as a complication of gunshot injuries of the back, which have given rise to abdominal symptoms necessitating laparotomy. Free incision is the only treatment. We treated a few of these cases, for we have not seen many, with salt packs, but when once the condition is established in the anterior abdominal wall, the disease has almost always proved fatal. We saw only 2 recoveries, and these were both of a limited type. Anti-gangrene vaccine. We have given this vaccine a fair trial, both in early and late cases, but not in a single case can we say that it influenced the course of the disease. Perhaps its use as a prophylactic may be of some good, but of this we can say nothing definite, as it was not widely used in this connection. Treatment at the base hospital. Men arriving with gas gangrene at the base hospital are those who have not received treatment at the casualty clearing stations either through rush of work or on account of the apparently insignificant nature of their wounds. Small wounds of soft parts in which the missile with its piece of clothing are still present, and which when leaving the casualty clearing station appeared harmless, have by the time the base hospital is reached lighted up into an acute spreading gas gangrene. This we have seen times out of number, and although no blame whatever can be attached to the clearing stations to whose surgeons from experience our sympathies go forth, it shows the importance of the universal early removal of foreign bodies and the excision of an infected wound. The treatment of gas gangrene at the base hospital does not differ at all from that recommended at the casualty clearing station. The main point is an energetic and thorough sterilization of all gangrenous wounds after excision by the Karel-Dakin method. The more we have persevered with this method of treatment, the more excellent have been the results. Amputation stumps as they reach the base hospital are often crude, but to those with experience of the work of a busy casualty clearing station, this is quite understood. At the latter unit, these operations are mainly life-saving in nature for men whose condition is desperate. Hence, the same surgical finish must not be looked for as could be obtained when the wounded man's general condition allows of a longer anesthesia. Treatment of the complication of gas gangrene. Local spread of the condition. Despite thorough excision of the wound, the condition in debilitated men may spread, although since the adoption of the Karel-Dakin scheme, this is far more rare than formerly. Free incisions into the diseased tissues should be immediately carried out, and at the same time a barrage of some suitable antiseptic can be put up in the sound tissue beyond the area of spread. Hydrogen peroxide, oxygen, or a full-strength solution of potassium permanganate have been injected into the apparently sound tissues of a limb above and below the areas of spread. These antiseptics have been introduced both into the subcutaneous and deep tissues and have been made to completely surround the limb. Prior to the Karel-Dakin treatment, when this complication was not infrequent, potassium permanganate seemed in a few cases to do good, but we never saw any benefit follow the use of oxygen or hydrogen peroxide. Acute gas gangrene toxemia. In severe gas gangrene toxemia, where cyanosis of the lips, an ashen appearance of the face, a cold, clammy skin with uncontrollable vomiting are present, the outlook is extremely grave. The local condition should receive attention on the lines already laid down. The stomach should be washed out with bicarbonate of soda, a drachm to the pint. An enema should be given to induce the bowels to act. An intravenous saline with bicarbonate should be administered. Fraser and Bates recommend the use of intravenous Usol. We have repeatedly tried this but have seen no good result from its use. Nourishing liquid diet should be given if the patient can take it, and glucose has in many instances been of value. Gas gangrene, septicemia, and pyemia. It seems that no treatment benefits this fatal complication. In some cases of septicemia of a subacute type, the patient lingers on for 3 to 6 weeks before death. In these latter cases, the tongue is clean, the color is good, and the patients eat well. Later, they gradually waste, develop bed sores, and finally die. Out of 5 cases of gas gangrene pyemia, all died within 48 hours of the appearance of the metastases. No treatment seems of any avail. End of Chapter 7. Part 2. Chapter 8 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery, From Firing Line to Base by Basil Hughes and H. Stanley Banks. Chapter 8. General Complications of Wounds 2. Tetanus. Tetanus was not an infrequent complication of wounds during the earlier weeks of the war, and during the battles of the Marne and the Aisne, many wounded men contracted it. Today, thanks to the universal use of the anti-tetanic serum, coupled with a more thorough and up-to-date treatment of wounds, it is a very rare event. This very fatal disease is due to infection of a wound through contamination with dirt or clothing. The specific organism is the tetanus bacillus. This bacillus is a sporogenous gram-positive anaerobe, the spore being terminal, giving it the appearance of a drumstick. It grows characteristically in stab cultures of gelatin, and in its sporogenous form it is very difficult to kill. Being a normal inhabitant of the soil, it is an ever-present danger to both men and horses who have been wounded, though horses will contract the disease from such causes as a picked-up nail. The size or extent of the wound is no criterion, for cases have occurred through the infection of trivial scratches caused by barbed wire, sores rubbed on the foot by a badly fitting boot, blebs that have broken on the foot, the result of frostbite, and the like. When once the bacillus has established itself in a wound, it is very difficult to isolate, being but one of a mixed infection. It is fairly agreed by most authorities that the bacillus does not migrate from the wound or its immediate surroundings into the tissues, but makes the wound a depot for elaborating its toxin. The toxin travels up the peripheral nerve trunks within the nerve sheaths and reaches the anterior horn cells, where some combination, probably of a chemical kind, takes place between it and the cell protoplasm. When the spinal cord is reached, some of the toxins get disseminated amongst the cerebrospinal fluid. By this means, motor cells are attacked other than those corresponding to the nerve trunks along which the toxin originally traveled from the wound. The interval of time elapsing between the infliction of the wound and the onset of symptoms varies from 5 days to weeks. The commonest period is about 8 days. Symptoms. The symptoms are local and general. Local symptoms. Small wounds, which are the site of tetanus infection, rapidly assume an indolent nature. The wound becomes dry and covered with an unhealthy-looking grayish membrane, and there is little or no wound exudate. These wounds respond slowly, if at all, to treatment of any kind. On the other hand, large wounds may appear perfectly healthy and doing well when tetanus sets in. The earlier wounds of the war, however, which were complicated by tetanus, were both highly infected and offensive. The earliest local symptom is spasm or stiffness in the muscle in the neighborhood of the wound. The stiffness or cramp complained of by the patient may be either continuous or intermittent. By comparing the injured side with the sound side, this stiffness or rigidity is readily felt. Such an early symptom should immediately arouse the suspicion of the nurse or sister who is looking after the case, and they should be urged to be ever watchful for and without delay report upon the slightest suggestion of anything of the sort should it occur. In other cases, the first symptom is trismus, or spasm of the masseters, preventing the patient from opening his mouth. There may be a feeling of stiffness in the muscles of the back of the neck. Any feelings of cramp in the jaw, neck, or limbs should be carefully watched for and reported by the sister in charge of the case. Often accompanying trismus is the rhizus sardonicus, due to spasm of the risorius muscles. Yet another early symptom is difficulty in swallowing, usually complained of by the patient, who will also say that his throat feels stiff. General symptoms. General symptoms may either follow immediately upon or be delayed for 3 or 4 days after the appearance of the local symptoms. They consist in general spasms of the muscles of the trunk, especially those of the back. They are exceedingly painful, causing the patient to cry out. With these spasms, the body is distorted, opisthotonous, pleuristhotnous, or empristhotonous resulting, the commonest being opisthotonous. With these intermittent spasms, which as the disease progresses become more frequent, the patient rapidly wastes, becomes exhausted, and finally dies, conscious to the last. Delayed tetanus. Tetanus has occurred in men some weeks after the reception of their wounds. This phenomenon, though not common, has occurred with sufficient frequency to demand attention. It would seem that tetanus, like other infections, can lie latent in the tissues of an open or healed wound for some considerable period. An injury or further operation has been sufficient to bring about its recrudescence in just the same way that we have seen sepsis lighted up in an old, healed second intention scar when a second operation has of necessity been undertaken in its immediate vicinity. Again, later operations for the removal of foreign bodies from tissues that have healed have in a number of instances been sufficient to give rise to tetanus. Here it is possible that the foreign body has become completely encapsulated with fibrous tissue, and though tetanus organisms be associated with it, yet they are harmless so long as the fibrous envelope is not destroyed. Diagnosis. This is not always easy. Early tetanus can be simulated by 1. Diseased conditions of the teeth, 2. Malaria of the cerebral type, 3. Septicemia resulting from wounds. Diseased condition of the teeth. On this front, we have now seen a number of cases of trismus due to an impacted wisdom tooth. A careful examination of the teeth should be undertaken, if necessary under an anesthetic, and if an impacted wisdom tooth be present, it should be removed. Trismus associated with an impacted wisdom tooth is always associated with pain in the tooth. There is no stiffness in the muscles of the back of the neck and no feeling of stiffness in the masseter muscles. Malaria of the cerebral type. Cerebral malaria complicating wounds may closely simulate early tetanus. There may be difficulty in swallowing, stiffness of the muscles at the back of the neck, while the wound has assumed an indolent character not unlike a tetanus-infected wound. The patient may even have a spasm, though this spasm does not resemble true tetanus. We have seen cases where the flexors of the forearm and hand have been strongly contracted, the patient assuming the so-called pugilistic attitude. As a rule, cases of cerebral malaria can be differentiated from tetanus, although on 1 or 2 occasions we have for hours been in doubt. In cerebral malaria, there are mental symptoms or drowsiness, and the patient does not complain of any pain, cramps, or feelings of stiffness. A history of previous attacks of malaria, an examination of the spleen, and finally a blood film will all help to clear the diagnosis, while an intravenous administration of quinine will often finally settle the question. Septicemia resulting from wounds. Fortunately, since the general adoption of the Carrel-Dakin system of wound treatment, septicemia has been a rare complication of wounds. There have been, however, a few cases, chiefly of the streptococcal variety, and the symptoms have on more than one occasion closely simulated tetanus. Convulsions, spasms of groups of muscles, slight arching of the back, and a characteristic tremor have all been present. These spasms differ from true tetanus in that they are painless. At the same time, these patients have been semi-delirious. Wasting and the rapid formation of bed sores have been present, but trismus has never appeared. Streptococci have on every occasion been isolated from the blood. A careful examination of the flora of these wounds has never revealed the presence of the tetanus bacillus. The temperature has been that of a typical streptococcal septicemia, and in those cases which died, the post-mortem examination, both clinically and bacteriologically, proved septicemia to be the cause of death. Treatment of tetanus. Prophylactic. In tetanus, above all other diseases, the surgeon should remember that prevention is better than cure. Earlier in the campaign, this complication was of frequent occurrence. Today, this is just the reverse, and we may safely rest assured that if every care be exercised in the carrying out of prophylactic measures, then one of the most dreaded and fatal complications of wounds has been overcome. Prophylactic treatment comprises 1. Thorough surgical excision of the wound as soon after injury as possible. 2. Application to the excised wound of an efficient antiseptic, preferably by the method of Carrel and Dotkin. 3. Administration of anti-tetanic serum to all classes of wounds, however large or trivial. The first two of the above mentioned are described in the chapter dealing with the general treatment of wounds. Administration of anti-tetanic serum. This should be carried out at the earliest possible moment after the infliction of a wound. 500 units are given beneath the skin of the abdominal wall, between the shoulders, or beneath the skin of the anterior chest wall. The skin at the site of administration should be cleaned with spirit and then painted with iodine prior to giving the serum, which should be administered with a serum syringe that has been previously sterilized. This part of the treatment is carried out at the field ambulances and is carefully recorded on the soldier's field card. All cases, however trivial, such as scratches from barbed wire, cuts contracted while opening tins, skin abrasions, and the like, should be immediately sent from the line to the field ambulance for a prophylactic dose. All cases of frostbite or trench feet in which the skin is broken should receive prophylactic treatment. It has been found that in large, dirty wounds, such as those complicating bone, 1 dose of 500 units is insufficient, as cases of tetanus have occurred some days later while the wound is still dirty. In the instance of large, dirty wounds, the dose of 500 units must be repeated weekly until the wound is clean and healthy. From a good many thousands of cases where the dose has been repeated, we have never seen any anaphylactic symptoms result. Whenever a second operation is necessary, such as is required for secondary suture of a wound or the subsequent removal of a foreign body after the wound has healed, a prophylactic dose of 500 units should be given subcutaneously at the operation. Complications attending the administration of anti-tetanic serum. The only complication is serum disease. This manifests itself either in the form of urticaria or by effusion into joints, and slight pyrexia, the latter symptom being perhaps the most frequent. If the administration be continued, it has been asserted by some that anaphylactic symptoms, albuminuria, and other complications are apt to follow. We may repeat that we have never seen such a result in thousands of cases. Urticarial rashes very soon disappear after the exhibition of calomel, followed by a dose of salts, and joint effusions also rapidly subside under the same treatment. We would, however, mention that in the case of wounds of large joints we do not, unless the joint is grossly infected, repeat the administration of the serum. We think this is justifiable because synovial sacs possess a greater immunity from infection than other tissues, and further, in 6 cases of knee joint injuries which were doing well and showing normal temperatures at the end of the 10th day, a second dose of serum was given. This course was adopted because the wound in the skin, which was open, was not quite clean. The result in every case was an effusion into the damaged joint, and in 4 of these cases the effusion became slightly infected, necessitating repeated aspiration. Recovery followed, however, and good movable joints resulted. The remaining 2 cases showed an effusion which subsided, but which caused us many anxious moments. This was a lesson, and now, gaining by this experience, we never administer a second dose of serum to any case of injury of a large joint unless the joint is grossly infected. Treatment of established tetanus. When tetanus symptoms, either early or late, become established, most energetic measures must be taken. The earlier the treatment is commenced, the better the patient's chances of recovery, hence no time must be lost. The patient should be removed at once to a quiet ward, allowed no visitors, and should be kept shaded from the light. All requisite nursing should be carried out as quickly as possible, for it must be remembered that any small stimulus is quite sufficient to induce a spasm. Washing and any necessary attention should therefore be performed quietly, quickly, and deftly. The temperature should never be taken by mouth, owing to the danger of breaking the thermometer, but should always be taken in the axilla or the groin. Feeding the patient is very important, though difficult. The food should consist of nourishing fluids such as egg flip, beef tea, jellies, and the like, given frequently between the spasms, for it is very important at this stage to maintain the patient's strength and resistance. If unfed, these patients rapidly waste, and their chances of recovery are seriously jeopardized. Nasal feeding should never be practiced. On no account should these patients be fed by rectum. The act of performing this is quite sufficient to induce a spasm, which not only further distresses the patient, but results in all the rectal feed being immediately expelled. The bowels should be kept moving by means of aperients, and of these the saline purgatives are preferable. Enemata should not be given, as they only result in inducing another spasm. The floor of the ward should be covered with linoleum or some kind of fabric to damp all noise of footsteps, and doors should be opened and closed as quietly as possible. Stimulants should be avoided. Surgical treatment aims at removing the cause. The wound, if dirty, should be widely excised under chloroform anesthesia, and active sterilization of the excised wound should be carried out by means of the Krell-Dakin or some other suitable and efficient method. We particularly recommend Carrel's method, as the dressing need only be changed every second day, and it is perfectly painless. It is advisable to give a fourth grain of morphia half an hour before changing the dressing. Antitetanic serum should be administered freely, intrathecally, intravenously, and subcutaneously. 1,500 units or more may be given at one sitting intrathecally, and this may be repeated at the end of 24 hours. At the same time, 1,000 units may be administered intravenously and another 1,000 units subcutaneously, and this also may be repeated at the end of 24 hours. If after 3 such administrations the symptoms are tending to subside, the spasms becoming less frequent and of less severity, then 500 to 1,000 units may be given subcutaneously daily for the next 5 or 6 days. In 2 cases, we have injected the serum into the cerebral meninges. The procedure consists in making 2 small trephine holes, one over each frontal lobe, and very slowly running in 250 units on each side through a needle which is made to penetrate the meninges. This was combined with subcutaneous administration, and both cases recovered. For control of the spasms, various measures have been suggested. Good results have been reported from the injection of a solution of magnesium sulfate intrathecally, but we have never tried this. Morphia, a mixture of bromide and chloral, with an occasional few whiffs of chloroform, are usually sufficient to control or profoundly modify the spasms. The patient's color must be watched. Should he become cyanosed with an irregular pulse, it may be that too much hypnotic has been administered, and so stimulant treatment under these conditions is called for. End of Chapter 8. Chapter 9 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 9, General Complications of Wounds, 3. Secondary hemorrhage. Secondary hemorrhage has been a frequent complication of gunshot wounds. It may appear as early as the 5th day, or it may be delayed as late as the 20th day after infliction of the wound. In a series of 1,000 consecutive cases of serious gunshot wounds, secondary hemorrhage occurred in 25. This gives a percentage of 2.5. Of these 25 cases, 8 died, giving a mortality of 0.8%. 10 of the 25 cases had been submitted to amputation by the guillotine method through the lower third of the thigh at the casualty clearing station, and the amputations had been carried out through infected tissues. Usol dressings had been applied, and advanced sepsis was present in the stumps when the base hospital was reached. Of the remaining 15 cases, hemorrhage occurred from open amputation stumps in 3, and here the amputation had, of necessity, to be performed through flaps infected with gas gangrene. 2 cases were the result of an imperfectly reduced compound fracture of the femur, and 1 of an imperfectly reduced compound fracture of the humerus. 2 occurred as a result of the giving way of an arteriovenous aneurysm in the thigh, and the remainder were confined to extensive comminuted fractures of bones of the leg, 5 cases, and compound comminution of bones around the elbow joint, 2 cases, where the common interosseous artery was involved. Causes of secondary hemorrhage. Predisposing causes are 1. Infection, 2. Mechanical. Exciting causes are 1. Constipation, 2. An irritating cough, usually due to pulmonary embolism and not infrequently associated with compound fracture of bone, especially of the femur. 3. Giving of stimulants and too liberal a diet. Infection. When infection exists in a wound, a catgut ligature soon dissolves, and at the same time the thrombus in the end of a divided vessel becomes digested and broken up. Infection further tends to constipation and to the dissemination of emboli. There is no doubt that the presence of sepsis in a wound is, above all, the most potent factor in the production of secondary hemorrhage. Mechanical. Secondary hemorrhage has resulted from the imperfect reduction of a compound fracture. The unreduced ends of the fractured bone by exerting pressure upon an artery erode it, and hemorrhage results. It is very important to procure as perfect a reduction as possible in the case of all compound fractures of long bones, and any rough fragments or ends of fractured bone should be carefully manipulated from the neighborhood of a large artery or vein after the wound has been excised. This done, the limb should be thoroughly immobilized prior to the application of a Carrel-Dakin dressing, and the surgeon should not apply such a dressing until he has convinced himself that the splinting apparatus employed is certain to maintain the reduction he has already effected. It sometimes happens that when a bone is badly comminuted and splintered, very small fragments are widely disseminated amongst the surrounding tissues. One of these fragments, which can very easily escape the eye of the surgeon, may be the cause of a secondary hemorrhage, although the main fracture be satisfactorily reduced. This unfortunate occurrence, though rare, has happened, and it should always be borne in mind. Carrel's tubes should never be allowed to rest against a vessel, for an artery is rapidly eroded by such means, and secondary hemorrhage results. Constipation. Straining at stool has brought about secondary hemorrhage not only at the time of performing defecation, but also shortly afterwards. The act of passing a constipated stool puts considerable strain on a ligature, which, if applied to an artery in tissues that are infected, is very apt to give way. An irritating cough. A patient suffering with a constant irritating cough is continually putting strain on a ligature, and the time comes when either the ligature gives way or the artery wall just above it. Cough, the result of pulmonary embolism, was not at all an infrequent complication of septic compound fractures of bones, especially of the femur, and secondary hemorrhage was the dreaded result. Even after amputation, emboli have traveled to the lung, and by giving rise to a constant painful cough, have produced serious secondary hemorrhage from the stump. Fortunately, since the Carrel-Dakin treatment has been established, we very rarely now see embolism. Stimulants and too liberal a diet. Stimulants, by raising the blood pressure, tend to cause secondary hemorrhage, and a too liberal diet will produce the same effect. These should be carefully avoided until all risk of secondary hemorrhage has passed. Effects of secondary hemorrhage on the individual. Secondary hemorrhage forms only a part of a vicious circle, and from what has been already said, it will be understood that the only cause of secondary hemorrhage, other than mechanical causes, is sepsis. Sepsis is responsible for by far the greatest percentage of all cases of secondary hemorrhage. The direct effect of a secondary hemorrhage on the individual is to lower his resistance further, the degree varying with the amount of blood lost. Secondary hemorrhage invariably occurs at a time when a wounded man can ill afford to lose any blood at all, that is, on about the 10th day after the wound was inflicted. With a still lower resistance brought about by the secondary hemorrhage is associated an increase of spread and virulence of infection, this latter in turn being the cause of another hemorrhage a day or two after the bleeding vessel has been religatured. The result of this last hemorrhage is again to enhance the virulence and spread of the existing infection, and so the vicious circle goes on. In the case of repeated hemorrhages, the interval of time between each succeeding hemorrhage and the ligature for the arrest of the preceding one gets shorter and shorter. This is explained by the increase in sepsis brought about by a proportionately lowered resistance. One example will suffice to make this point more clear. Private blank, 7th Royal Berks, was wounded on May 9, 1917. His right lower extremity was amputated at a casualty clearing station on the same day owing to excessive comminution of the bones entering into the formation of the knee joint, and a Usal dressing was applied. He had already suffered severe hemorrhage during transit from the battlefield to the casualty clearing station. On arrival at the base hospital on May 12, the amputation stump was very septic. A Carrel-Dakin dressing was applied, but on May 14, that is, on the 6th day after his wound, he had a severe secondary hemorrhage from the femoral artery. The artery was immediately religatured in the stump. The stump during the next 2 days was extremely dirty and septic, showing no tendency to clean despite every effort to sterilize it. At the end of the 2nd day following religature, there was another hemorrhage from the same vessel, which was again religatured after further dissecting it up in the stump. The patient's general condition during the next 24 hours was grave, and the local condition remained apparently stationary. It was at this time that he had a 3rd hemorrhage from the same artery, and although religatured for the 3rd time, he died 18 hours later. Secondary hemorrhage, by its lowering effect on the general resistance, is often responsible for the onset of general septicemia and pyemia. We may quote one instance out of a few to demonstrate this. Sergeant blank, wounded on April 24, 1917, sustained a severe compound fracture of his right femur. The wound was thoroughly excised, a Carrel-Dakin dressing applied, and the fracture was, as far as we could make out, satisfactorily reduced. All went well for 12 days, and for 5 days the temperature and pulse were normal and the wound clean, the bacterial count being 5 per field. Without any warning, on the 12th day an extensive hemorrhage developed from the profunda femoris artery due to pressure on it of an unnoticed spicule of bone. The artery was tied and the patient put back to bed. 4 days later, the temperature rose in the evening to 103 degrees Fahrenheit, returning to just above normal in the morning, and this continued to be the case for a week, when a blood culture showed the presence of Streptococcus pyogenes in the circulation. The wound became again highly infected, showing over 100 organisms per field, chiefly Streptococci, B. coli, and B. perfringens. Active sterilization of the wound was persevered with, and an autogenous vaccine made from the blood organisms was administered along with anti-streptococcal serum. The temperature gradually fell and was normal again at the end of the 3rd week. The patient made a good recovery. Another case of interest is that of Private blank, wounded on May 5, 1917, who sustained a compound comminuted fracture of the right tibia. He progressed well up to the 9th day, when he had a secondary hemorrhage from the anterior tibial artery, the result of an imperfectly reduced fracture. 4 days after arrest of the hemorrhage, the wound showed a count of 50 organisms per field, though 2 days before the hemorrhage occurred, the count was 2 to 3 fields. In the grossly infected wound, coliform bacilli were present in considerable numbers. On the 4th evening following the hemorrhage, the temperature reached 102.5 degrees, returning to 101 degrees in the morning. A blood culture showed the presence of a coliform bacillus in the circulation. No vaccine was given, but at the end of the 10th day the temperature returned to normal, and 5 days later the wound was sutured, the count being 2 per 5 fields. It is interesting to note that this patient had suffered from dysentery in the preceding year, and after the secondary hemorrhage he suffered from diarrhea and mucus in the stools. This is only one out of a number of similar cases and goes to prove that a secondary hemorrhage influences for the worse not only a recent wound, but also such conditions as a chronic ulcer or ulcers in the intestine. Septicemia, in which a blood examination has revealed the presence of coliform bacilli in the circulation, have not, in our experience, been infrequent. The patients have all been the victims of previous dysentery or diarrhea, and the nature of the temperature and the general aspect of the patient have often suggested an attack of paratyphoid. A Weidel reaction has proved this to be negative. The temperature lasts for 10 days only, by which time the blood infection seems to disappear. The course of such a septicemia is very typical, and we can often recognize the condition from the temperature chart alone. In 3 cases where the urine was examined, the same bacillus was present. This type of septicemia does not seem to give rise to noticeable constitutional symptoms, nor does it materially impede the sterilization of a wound. From our experience, we can say that the condition has proved practically harmless. Malaria and secondary hemorrhage. On the Balkan front, secondary hemorrhage may precipitate an attack of malaria, and this has occurred in patients who can give no previous history of an attack. Malaria following a secondary hemorrhage is a severe complication in the case of any wound, and though it may not necessarily threaten life, yet it puts the wound back for weeks. Such wounds are notoriously indolent and very slow to sterilize. Although the effects of malaria complicating wounds are described by Lieutenant Colonel L.F. Smith in another chapter, we do not think it is out of place to refer to it here also in this connection. We have constantly seen wounds that have assumed a very typical appearance, especially after a hemorrhage, though the same characters may be present in the wound of a patient who has suffered a number of previous malarial attacks. This particular class of wound strongly resembles a gumma. It takes on the appearance of a large or small ulcer with deep, punched-out edges. The serpiginous character of the edges may or may not be present. The ulcer itself shows no tendency to spread. Its base is dry and grayish, secreting but little, and covered with a glary mucoid membrane. 2 cases will suffice to illustrate this. Lieutenant Blank had 9 consecutive attacks of malaria. He had for years been possessed of a sebaceous cyst the size of a pigeon's egg and situated over the right scapula. While in hospital after the 9th attack of malaria, the sebaceous cyst suppurated. An incision was made to evacuate its contents, the cyst lining was removed, and the wound left to granulate. This patient was extremely anemic, showing well-established malarial cachexia. He was given quinine, 40 grains daily by mouth, but despite this, at the end of 7 days after operation, the wound resembled most typically a tertiary ulcer. It was not until he was given quinine, 30 grains intramuscularly each day, that his general condition started to improve, and the wound became healthy and healed. Private Blank, wounded by high explosive on October 16, 1917, had his left knee joint perforated. The wound of entry was in the popliteal space, damaging the popliteal vein, while the wound of exit was on the outer aspect of the joint. The popliteal vein was ligatured at the casualty clearing station. On arrival at the base hospital, he had a secondary hemorrhage. The vessel was ligatured, the wounds excised and sutured. The hemorrhage and operation were followed by an attack of cerebral malaria. Part of the wound on the outer aspect of the joint, which was sutured, broke down, and in many ways resembled a tertiary syphilitic ulcer, and this despite the fact that he was taking quinine, 30 grains by mouth daily. Quinine 40 grains given intramuscularly on each of 5 consecutive days sufficed to bring about a great change for the better in the general condition, and the wound rapidly healed. He has now a perfectly movable and sound knee joint. In neither of the above cases was the malarial parasite found, but this may be explained by the fact that both patients were taking quinine by mouth when their blood was examined. A blood count in both cases, however, showed 40% and 43% of lymphocytes respectively. We might mention here the important fact that an attack of malaria can be responsible for a secondary hemorrhage, though in our experience this has been rare, as all wounded men in the Balkans are systematically given quinine throughout their treatment. It is of interest that a percentage of wounds inflicted on men who have suffered repeated attacks of malaria are extremely indolent, although these men are taking large doses of quinine by mouth and are apparently absorbing it, for they show a clean tongue and no digestive disturbances. If the quinine by mouth be stopped, then within 48 hours an attack of malaria invariably follows. If the quinine by mouth be continued, the wound still remains indolent, but the patient has no further attacks of malaria. If, however, the quinine be administered intramuscularly, the wound assumes a healthy appearance, sterilizes quickly, and can be sutured. Though the treatment of malaria does not come within our province, yet malaria in the Balkans is so frequent a complication of wounds that we do not think it out of place here to mention that, judging from our observations on wounds alone in a country where a malignant type of malaria abounds, we have come to the following conclusion. A patient who has had one or more attacks of malaria may, by taking quinine by mouth, appear healthy and free from the disease. His tissues, nevertheless, as exhibited in wounds, are anything but healthy, and a cessation of the drug for 48 hours has been quite sufficient to allow of another attack occurring, although he has been taking large doses daily for as long as 3 weeks. If, however, 4 or 5 consecutive doses of intramuscular quinine be given, and this followed by quinine by mouth, the tissues of the wound assume a normal, healthy aspect, and there is a marked change in the wounded man's general condition. Further, the wound rapidly sterilizes and can be sutured. So striking and constant have these observations been that we now regularly give severely wounded men on this front intramuscular quinine, followed by quinine by mouth. Again, though physicians may not agree, we would, in the event of again contracting malaria, first treat ourselves with intramuscular quinine and follow it up with quinine by mouth. Pathology of secondary hemorrhage. There is little to say on the pathology of secondary hemorrhage, as this is so well known. When an artery is divided and ligatured, a clot forms in the end of the ligatured vessel, which undergoes organization into fibrous tissue. Should sepsis, however, be present, the thrombus, instead of becoming organized, breaks down, the ligature and part of the artery wall slough away, and hemorrhage results. When once this has occurred, the artery wall for some distance into the stump is inflamed and friable. Hence, it is most important before applying a second ligature to dissect out the artery well up into the stump until a sound part of its wall is reached. When secondary hemorrhage occurs as a result of mechanical causes, such as pressure exerted on the artery by a rough piece of bone or a Carrel's tube, it is simply a question of erosion of the artery wall. Treatment. Successful treatment is prophylactic, and this aims at subduing infection. Fortunately, since excision of wounds followed by primary suture or the application of a Carrel-Dakin dressing and later secondary suture has been practiced, secondary hemorrhage has become more and more rare and now promises to become an event of the past. Most secondary hemorrhages, in our experience, have resulted from open amputation stumps and septic compound fractures of bone which have been imperfectly reduced. When amputation by the guillotine method or open flaps is necessary, a double ligature of catgut should be applied to the main vessels. Silk should not be used, as the hypochlorites rapidly destroy it. When the amputation is complete, a Carrel-Dakin dressing should be employed and vigorous sterilization of the stump carried out. Whenever a Carrel-Dakin dressing has been immediately applied after amputation at the casualties clearing stations, there has been no further trouble, as the stump has rapidly sterilized and been submitted to secondary suture on the 10th to the 12th day. An ordinary Usal dressing applied to open amputation stumps is useless, as it loses its bactericidal power in from 1 to 2 hours. Salt packs are little better, as they again exert no bactericidal effect on badly infected tissue. Earlier in this campaign, before the Carrel-Dakin treatment was established, open amputation stumps arriving at the base with Usal dressings applied became a nightmare. On removing the dressing, the main artery could be seen pulsating in the septic stump with a slough on the end of it. This always meant only a question of hours before the slough separated and secondary hemorrhage resulted. Laterally, we did not wait for this to happen, but in every case we religatured and applied a Carrel-Dakin dressing, using hourly installations of the antiseptic. With this treatment, there was no more trouble. In the case of extensive compound fractures, there is both infection and displacement of bone to consider. When once the wound has been thoroughly excised, the fracture should be reduced and all rough pieces of bone removed from the line of the main vessels and kept away by suitably applied extension. No surgeon should be content until he is perfectly certain that he has accomplished this. This done, a Carrel-Dakin dressing is applied and sterilization of the wound proceeded with. Cases of a most extensive nature so treated have given rise to no trouble from secondary hemorrhage. Fortunately, most cases of secondary hemorrhage are preceded by an aura. There is usually some oozing of blood through the dressings. This should always be an indication for immediately taking down the dressing and doing what is necessary. For this reason, no bedclothes should ever be allowed to cover an amputation stump or severe wound of the arm or leg until the time for secondary hemorrhage has passed. By leaving the dressings uncovered, the wounded man's next-door neighbor, the orderly, or the sister will immediately detect the staining of the dressing and send at once for the medical officer. Any patient possessing a wound that is liable to secondary hemorrhage should have a tourniquet hung above his bed. In addition to oozing of blood through the dressing, there is often a rise of 2 degrees in the temperature with a rise in the pulse rate. Should these 3 aurae coexist, they are ominous of a secondary hemorrhage, and necessary surgical measures should be taken at once before the hemorrhage develops. These aurae do not call for the immediate use of the tourniquet. Sisters should be instructed to raise the foot of the bed if the lower extremity be involved, and to elevate the upper extremity if this be involved, and to retain it elevated until a medical officer arrives. Morphia of 1/4 or a half grain with atropine 1/100th of a grain should be given hypodermically as soon as possible and the patient removed to the theater. Should hemorrhage develop, the tourniquet must be applied immediately, as digital compression of an artery by a sister is unreliable. Many tourniquets are at present in use, but 2 of the most suitable are those devised by Adams and Fidian, as shown in the illustrations on page 254. Should a considerable hemorrhage have taken place in the ward, the patient, if possible, should not be allowed to see it, but if he has already done so, he should be assured that it is nothing of a serious nature. It is important to remember this, as a hemorrhage is exceedingly terrifying to a patient, and it exerts a bad influence on his mental condition. Secondary hemorrhage must be checked at once, for loss of blood to a wounded man at this stage, if not immediately fatal, is the forerunner of serious complications of a septic character. Operative treatment. Hemorrhage from open amputation stumps requires religature of the bleeding vessel. After applying the tourniquet, the bleeding vessel, usually the main artery, must be dissected up, and the surgeon must not stop until he has reached a healthy, non-inflamed, and non-friable part of the artery wall. This dissection should be carried out quickly and with as little disturbance as possible to the remaining tissues in the stump in order to prevent any further dissemination of infection. When once healthy artery wall is reached, a double ligature of either stout catgut or kangaroo tendon is applied. Silk should not be used, as the hypochlorites destroy it. If the condition of the artery wall be doubtful, then we would recommend a petticoat of muscle or other tissue being left around it prior to applying the ligature. On no account, except in certain situations, should the artery be ligatured through a separate incision in apparently sound tissues, for hemorrhage will certainly recur. By ligaturing an artery higher up, the vitality of the already infected stump is further lowered and the infection thereby increased. The result of such a procedure is therefore to favor another hemorrhage. Should hemorrhage occur from a damaged artery in the thigh or upper arm, the result of a compound fracture, the wound should be widely opened up and the divided ends of the damaged vessel exposed, clamped, and ligatured in a sound tissue as possible. To apply proximal ligature is useless in these situations. Should hemorrhage occur from the popliteal vessels, a departure from what has been said above should be practiced. Experience has taught us that ligature of the popliteal vessels for gunshot wounds in a great number of cases is followed by gangrene of the limb below the ligature. In such cases, ligature of the artery in Hunter's Canal or the apex of Scarpa's Triangle has been the operation which has given the best results. Should hemorrhage be coming from the forearm or leg and be associated with injury to the common interosseous vessels, the peroneal, the posterior tibial, or the anterior or posterior interosseous arteries of the forearm, these cases are often most difficult to deal with. In a number of cases treated at one of the casualty clearing stations in France, ligature of the posterior tibial artery was followed by gangrene of the foot, necessitating amputation, and further, if this artery be successfully ligatured, hemorrhage for some reason is very prone to recur. The same remark applies to the interosseous arteries of the forearm. In ligaturing these vessels, the surgeon must not be guided by classical incisions. It is quicker and more practical to enlarge the original wound freely while a tourniquet is applied and with a good light and retraction to find the ends of the vessel. It will often be the surgeon's experience to find the vessel at some distance from its normal anatomical position, having been displaced by the missile. Both ends of the divided vessel must be ligatured or hemorrhage will recur. Should there be extensive damage to bone in the forearm or leg associated with uncontrollable secondary hemorrhage, we have had excellent results from ligature of the brachial artery just above the head of the elbow if the forearm be involved, and the femoral artery in Hunter's Canal if the leg be involved. Secondary hemorrhage from the palmar or plantar arches is most difficult to treat. We have been concerned with a number of such cases and have found the most satisfactory solution is to make a free incision into the palm or sole and ligature the divided vessel. We have tried ligature of the posterior tibial vessel below the internal malleolus and also ligature of the ulnar and radial arteries, and in 2 cases have seen gangrene of the ends of the fingers follow with a recurrence of the hemorrhage. Ligature of the divided ends of the arch, though often a long and tedious operation, has given the most satisfactory and best results. We have confined our remarks chiefly to secondary hemorrhage occurring in the extremities, as these are the commonest sites, but the surgeon must be prepared to find and deal with it anywhere. We may quote one case out of a number to illustrate this. Private Blank, wounded on September 20, 1917, sustained a compound fracture of the right iliac bone. He progressed favorably up to the 8th day when he contracted a 3rd attack of malaria. On the 10th day there was a hemorrhage from the wound in the right buttock and pain in the right iliac fossa. Examination showed a large tender swelling to be present in this situation. The swelling was approached extraperitoneally, and it was found that hemorrhage was taking place from the iliac branch of the iliolumbar artery. A ligature was applied and disinfection of the wound carried out. Secondary hemorrhage from the sciatic or gluteal arteries in the case of large buttock wounds has occurred, and no part of the body where septic wounds exist is exempt from this complication. Instances in which mechanical causes more than infective causes were giving rise to the hemorrhage have proved satisfactory with a 5 days salt pack. The pack should be applied in such a way that it is sufficient by pressure to control the hemorrhage from the wound without interfering with the general circulation of the limb. After ligature of the damaged vessel, energetic measures towards sterilizing the wound by the Carrel-Dakin method must be taken in order to prevent a further hemorrhage. In all cases of hemorrhage, we have ligatured both artery and vein. After treatment, the cases receive hourly installation of the hypochlorite solution and the following mixture by mouth 3 times a day: magnesium sulfate 40 grains, potassium bromide 20 grains, calcium chloride 10 grains. All stimulants are carefully avoided, and should a cough develop, opium is the best remedy. Should a severe hemorrhage occur, saline solution by rectum 6 hourly with 1 or 2 pints containing bicarbonate of soda given subcutaneously in the theater during operation is recommended. Morphia may be given freely for the first day or 2 to ensure rest and keep the blood pressure low. Direct blood transfusion in bad cases has given excellent results, and as much as 2 pints may be given without causing any bad effects in the donor. Unfortunately, in the Balkans, where malaria abounds, it is not always easy to find a healthy donor. Active sterilization of the wounds is of supreme importance, and it should be thoroughly seen to that every part of an open amputation stump or large wound receives an hourly and adequate supply of the antiseptic. End of Chapter 9.
Chapter 10 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Larry Wilson. War Surgery, From Firing Line to Base by Basil Hughes and H. Stanley Banks. Chapter 10. Septicemia and Pyemia. Septicemia and pyemia, occurring as complications of gunshot wounds, should always be investigated bacteriologically. An attempt should be made in every case to isolate the causal organism, in order that, if necessary, an autogenous vaccine may be prepared and specific treatment carried out. The various types of septicemia and pyemia which the authors have met with as direct complications of wounds are as follows: 1. Streptococcal type. 2. Coliform type. 3. Gas gangrene type. 4. Mixed type. In addition, a diphtheroid type of septicemia is said to occur, but we have not seen a case. In a series of 24 cases of septicemia in which the causal organisms were found by bacteriological examination, the types were distributed as follows: 1. Streptococcal type. Long-chained Streptococcus pyogenes, 10 cases. Short-chained Streptococcus faecalis, 1 case. 2. Coliform type. B. coli, typical, 1 case. Coliform bacilli, various, 4 cases. 3. Gas gangrene type. B. perfringens, 5 cases. 4. Mixed type. Streptococcus and coliform bacillus, 2 cases. Streptococcus and B. perfringens, 1 case. 24 cases. The causal organisms may be isolated: 1. From the blood, 2. From the urine, 3. From pyemic abscesses. The first is by far the most satisfactory source, and wherever septicemia is suspected, a blood culture should be performed. Methods of examination. From the blood. The skin in front of the elbow or over any large vein is very carefully sterilized by the application of spirit soap, followed by ether, and then by several applications of iodine. Any other efficient method of sterilizing the skin may, of course, be adopted, but it is absolutely essential to use the greatest care on this point, as contaminations are very liable to appear in a blood culture. Bacterial asepsis, not merely surgical, must be secured. The veins at the elbow are rendered turgid by the firm application of a piece of bandage or rubber tubing to the upper arm. At 10 cc or 20 cc, all glass syringe is used. It should be sterilized with needle and all other parts in situ, the whole being enclosed in a large glass test tube. The sterilization of the whole apparatus should be performed in the hot air oven at 140° C for 3/4 of an hour. If this procedure be followed, there is no risk of contamination from the operator's hands. The needle of the syringe is passed through the skin into the subcutaneous tissue overlying the median basilic vein. A pause is made to secure direct alignment of the needle and vein, and the point of the needle is then plunged sharply into the vein, strictly in the direction of its long axis. An attempt should never be made to pass the needle into the vein by a sudden single plunge from the outside. This part of the procedure never fails when performed in 2 stages as described. Blood flows at once into the syringe, often under sufficient pressure to force the piston along the barrel. About 10 cc of blood are withdrawn and distributed equally among 3 or more large tubes or small flasks of media, each containing 20 to 50 cc. The culture media which we have found most useful are 1. Trypsin broth (Douglas). 2. The same with the addition of 5% saline pea extract. 3. Litmus milk. An assistant should be at hand to hold these tubes or flasks and withdraw rapidly the cotton wool plugs in turn, while the operator inserts 3 or 4 cc of blood into each. This must be done rapidly, or the blood will coagulate in the syringe. The cotton wool plugs should be replaced as quickly as possible, to prevent contaminations with air organisms. The culture tubes are incubated at 37 degrees C overnight, and then examined and subcultured according to the usual methods. From the urine. A sterile catheter specimen must be used. The meatus and glans penis are thoroughly cleansed with Usol before the passage of the sterile catheter. The first part of the urine is rejected, and that flowing towards the end of the micturition is caught in a large sterile tube. About 10 cc of this urine is pipetted with aseptic precautions into large tubes of 1. Tryptin broth, 2. Pea extract broth, and 3. 2% sodium taurocholate peptone water, in cases where coliform organisms are suspected to be present. Direct plate cultures may also be made by pouring the urine over plates of trypagar or of McConkey agar, according to the type of organisms believed to be present. The examination of the urine in septicemia is of use in various ways, e.g., 1. In a case of septicemia of the mixed type, when one or the other of the organisms may be more easily recovered in pure culture than from the blood. 2. In lasting cases of septicemia late in the disease, when the organisms may be more readily recovered from the urine than from the blood. And 3. To confirm the hemocultural findings. From pyemic abscesses. Direct tube or plate culture from the pus on trypagar or brain agar is often sufficient. It may be necessary in some cases to inoculate animals and recover the organism from the blood or lesions. Pyemic abscesses are often said to be sterile, but it is true that the causal organism, which is usually Streptococcal pyogenes, very frequently fails to grow upon the ordinary media in direct primary culture from the pus. Growths can, however, usually be obtained by the employment of the enriched protein media named above. Cultivations from pyemic abscesses may be of use. 1. In obtaining growths of the causal organism of the septicemia, where the method of blood culture fails. 2. Where the abscess infection is a mixed one, as in abscess of the lung. In the latter case it is desirable to obtain growths of the other pathogenic organisms, which can be isolated from the purulent matter in the sputum, in order that all of them may be included in the therapeutic vaccine. 1. Streptococcal type. This is the most common type of septicemia complicating wounds, and a very fatal one. Fortunately, the introduction of Carroll-Dakin treatment of wounds, and more recently of a more satisfactory method of treating penetrating wounds of the knee joint, has coincided with a greatly diminished incidence of the disease. The types of wounds with which it is most frequently associated are septic compound fractures and septic wounds of joints, especially the knee joint. Very rarely it occurs in connection with simple flesh wounds. Out of the 14 cases in which Streptococcus alone or in combination with other organisms was found in the above series, the following types of wounds were present. Compound fractures, 8 cases. Penetrating wounds of knee joint, 5 cases. Pneumothorax, 1 case. 14 cases. Pathology. The disease is almost invariably associated with bone lesions. All but a very small minority occur in cases of compound fracture or of septic joints. In the latter case, the septicemia does not occur until the articular cartilages are ulcerated and the cancellous tissue of the underlying bone is exposed. The organism appears to gain entrance somewhat readily to the bloodstream in cancellous bone. Lack of thorough immobilization of the fracture or joint is undoubtedly a potent predisposing cause, and probably acts mechanically by tearing open the mouths of the minute vessels of the bone. Secondary hemorrhage, by diminishing the patient's resistance, is also an important predisposing cause. Inefficiently treated sepsis in wounds is, of course, a most potent factor in the etiology. The organism was found by blood culture in 10 of the 14 cases. In 2 cases, verified post-mortem, the blood cultures during life were sterile. In the remaining 2 cases, blood cultures were not performed, and the organism was recovered pure from pyemic abscesses. In all cases but one, the organism formed long chains in fluid media and grew in minute discrete colonies upon trip agar and brain agar. The carbohydrate reactions were not quite constant. Acid production in mannite, saccharose, and lactose, with acid in litmus milk, and no reduction of neutral red, were constant in all but 2 strains. The latter failed to ferment mannite and saccharose. The reaction to glucose was negative in all but 2 strains, and in these acid was produced. All these organisms, except one, were taken to belong to the Streptococcus pyogenes group. This exception was an organism which formed very short chains in fluid media and gave the reactions of Streptococcus faecalis. No corresponding difference in the clinical appearances of the septicemia produced by this organism and that by the Streptococcus pyogenes group were noted. The former was equally virulent and was indeed, in this particular instance, fatal. Clinical appearance. From the consideration of our cases, there appear to be 2 chief clinical modes of onset. 1. Sudden onset, at a variable period after the infliction of the wound. 2. Gradual onset, after a prolonged period of toxemia. 1. This is the common form. The wound, which is in many cases a compound fracture, may appear to be progressing favorably, when suddenly the temperature begins to show an evening rise to 103 degrees or 104 degrees F. This occurs at a period varying from 3 to 21 days after the infliction of the wound. In our cases, the average time was 14 days. The patient at first does not look very ill. Pulse is generally good, and tongue clean, and there are no alarming symptoms. For this reason, the condition is often not suspected until the disease is well advanced. The course of the disease is variable, but usually lasts in fatal cases 2 to 5 weeks, depending upon where and when the pyemic abscesses occur. If the lung becomes involved early, the course is comparatively short. The lung becomes involved sooner or later in nearly all cases. In 2 cases, the disease was fatal in less than a week, one of them having a pyemic purulent pericarditis. As the disease progresses, the appearance becomes more typical, and gradually the syndrome of symptoms mentioned below make their appearance. They are observed in nearly all fatal cases within a few days or even a week or 2 of death. 2. The gradual onset is less common, because radical treatment for the toxemia serves in many cases to avert the condition. In this type, the wounds are always very septic. There may be a large septic surface, as in pneumothorax, or there may be a spread of the infection to neighboring structures, such as joints or bone, acute osteomyelitis, or there may be unremoved foreign bodies or pieces of necrosed bone in the wound or multiple septic wounds. These conditions cause retention of pus with septic absorption and prolonged toxemia. Unless the cause of the toxemia can be discovered and removed, septicemia may ensue after a long period. The onset of septicemia is marked by a change in the patient's general condition. The temperature may become continuously high and remittent, and the pulse more rapid and weak. The tongue, at first clean, becomes dry and fissured. The patient emaciates rapidly, and death occurs within 1 to 3 weeks of the onset. In both of these types, but more especially in the former, the following characteristic syndrome of symptoms is often found in the later stages. A. The tongue is dry, fissured, and tremulous. It is often clean, or there may be a central bar which is coated. It is with difficulty protruded beyond the lips. There are intermittent tonic spasms of the muscles of jaws, back of neck, and of limbs. This bears a superficial resemblance to tetanus, and it is at first not uncommonly mistaken for the latter condition. It does not, however, progress. There is never extreme rigidity, swallowing is not unduly interfered with, and there is no opisthotonos. A blood culture in nearly all cases yields a streptococcus. Progressive emaciation, delirium, and pyemia complete the picture. The pyemic abscesses may be found in almost any situation, in joints, e.g., elbow joint, muscles, and subcutaneous tissue, especially at the site of intramuscular or hypodermic injections of quinine, saline, etc., as well as in the lungs, pleural cavity, and kidneys. Pulmonary involvement is very common and is usually the proximate cause of death. Diagnosis. This depends upon the blood culture, which, properly performed, seldom fails. In the type which commences suddenly, blood culture is practically always successful. In the type which follows toxemia, however, repeated blood cultures are sometimes sterile, in spite of the fact that pyemic manifestations are present. It is probable that the septicemia in such cases is intermittent, and that the pyemic abscesses are of the nature of multiple septic infarcts. One such case may be quoted. Patient D was wounded by H.E. on November 30, 1917. He sustained multiple and serious wounds. 1. Left tibia and fibula were badly comminuted at lower end, and the ankle joint was involved. 2. Right knee joint was penetrated. 3. Right elbow joint was severely smashed and was excised at the casualty clearing station. He was admitted to the base hospital on December 3rd. The wound of the left ankle was badly septic, and amputation was performed a few days later. The knee joint was septic. The mistake had been made of washing out the joint with saline at the casualty clearing station. The enterococcus was cultivated from the aspirated joint fluid, which contained hemolyzed blood. The excised elbow joint appeared clean and was put up in a straight arm splint. The patient was ill with severe toxemia. The temperature was remittent and intermittent, but the pulse was good and the tongue clean. Blood cultures on 3 occasions from December 12th to 27th were sterile. The knee joint did not do well by the dry method of treatment, and the joint was opened and treated with Carroll's tubes, the limb being put on a Thomas knee splint. The pus from the open joint on December 19th yielded the enterococcus, staphylococcus, and B. perfringens on culture. The toxemia gradually became more severe, and ultimately an undoubted septicemia set in, although the organism could not be obtained by blood culture. A large pyemic abscess appeared on the gluteal region at the site of an intramuscular injection on January 2nd, and pulmonary symptoms indicative of septic infarcts appeared about the same time. Pus removed from the pyemic abscess of the buttock yielded pure Streptococcus pyogenes. A vaccine was made from this organism, but it was too late to have any effect, 2 days before death, and he died on January 9, 1918. Post-mortem, the lungs showed multiple septic infarcts which had become gangrenous. The right knee joint showed erosion of articular cartilages on the condyles of the femur. Prognosis is bad. Out of the above-mentioned 14 verified cases of streptococcal or mixed streptococcal septicemia, only 3 recovered. This gives a death rate of nearly 80%. Most of these cases occurred at an early period, when the rush of the work was too great for septicemia to be investigated, and the possibility of good results from vaccine treatment had not been altogether realized. Of the 3 recoveries, 1 recovered after very prolonged administration of large doses of anti-streptococcal serum. A photograph showing his extreme state of emaciation is given on the opposite page. 1 recovered as a direct result of autogenous vaccine treatment. The 3rd was a milder case, whose condition yielded very rapidly to vaccine treatment, but who might have recovered spontaneously without it. One of the cases which ultimately died had a very remarkable reaction to autogenous vaccine. He was practically moribund when the vaccine was given, and yet he lived for a month as a direct result of the treatment. In his case, advanced tuberculosis of both lungs was a serious complication, which seemed ultimately to turn the balance against him. His case is recorded under mixed septicemia. The prognosis, therefore, may be regarded as distinctly hopeful, provided that the condition is diagnosed early by blood culture and autogenous vaccines exhibited. The type in which the onset is sudden and the wounds fairly clean is most amenable to specific treatment. The type which follows severe and prolonged toxemia is of bad prognosis. The outlook depends here largely upon whether the source of the toxins and organisms in the blood can be cleared away by surgical means, leaving the septicemia to be treated specifically. This is usually impossible, and these cases are generally hopeless. Lastly, there appear to be rare cases in which the disease runs a very rapid course. We have seen this follow acute streptococcal osteomyelitis, complicating compound fracture of the tibia. In these rare cases, death occurs before the autogenous vaccines can be given. Such cases are hopeless. Where purulent pericarditis supervenes, the outlook is bad, unless the condition be diagnosed in time and the pericardium opened. Treatment. The treatment is prophylactic and specific. Prophylactic treatment is the most important and consists of the whole antiseptic treatment of wounds. The prevention of streptococcal septicemia will be accomplished in proportion to the thoroughness of surgical technique in complete excision of wounds, complete immobilization of fractures and joints, and complete sterilization of wounds by thorough attention to the details of the Carroll-Dakin or other efficient antiseptic treatment. In particular, the prevention of knee joint sepsis by the newer methods of treatment of penetrating wounds of the joint is responsible for saving a large number of cases from streptococcal septicemia. There is, however, a small residue of cases which arises even when the above prophylactic treatment has been as far as possible carried out. There remains for these established cases of septicemia specific treatment in the form of sensitized autogenous vaccines. Specific treatment. Sensitized autogenous vaccine. The success of specific vaccine treatment depends largely upon an early diagnosis by blood culture, and the consequent early institution of the treatment. The only way to secure this is to make a blood cultivation from all cases which have an unexplained swinging temperature for 2 or 3 days. It is inadvisable to wait until the typical tetanoid spasms, tremor, and tongue are seen, for by that time it is probable that the lung has become involved, and in addition the patient's powers of resistance, on which the vaccine treatment depends, have become much weakened. If a streptococcus be found in the blood, the autogenous vaccine should be ready within 3 days at the most, and within 48 hours if particular speed is required. The test of the vaccine for sterility being then omitted. The dose of vaccine given should be large, say 1/4 to 1/2 of a slope equals 500 to 1,000 million of organisms, as the commencing dose. 20 to 40 cc of stock polyvalent antistreptococcal serum should be given intramuscularly just before injection of the vaccine in order to sensitize it. The dose should be doubled or otherwise increased according to the local reaction produced. The succeeding doses should be given when the local reaction has just subsided, e.g., every 3rd or 4th day. Should pyemic abscesses arise, The causal organism or organisms should be cultivated as far as possible from the pus, and they should be incorporated along with the original organism from the blood in a fresh vaccine. The results of sensitized autogenous vaccine treatment in streptococcal septicemia of the lasting type with the sudden onset are often very striking, especially if it be exhibited early. A brief description of one case may serve to illustrate this point. Sergeant L., 11th Scottish Rifles, was wounded on May 8, 1917, by H.E. He sustained a very severe compound fracture of the head of the tibia and external condyle of the femur, the knee joint being involved. On admission to the base hospital on May 11th, the wound was offensive and gangrenous, and foul gas exuded from it. Carroll tubes were inserted into the joint. On May 27th, he had a severe secondary hemorrhage from the popliteal artery, and amputation was performed in the middle third of the thigh, and the flaps left open. After this, his evening temperature fell gradually to a degree or so above normal until June 6th, when it rose suddenly to 104 degrees F, and remained continuous with high evening exacerbations. The amputation stump was clean. A blood culture was therefore performed on June 10th, and it yielded typical Streptococcus pyogenes. On June 13th, he had 10 cc anti-streptococcal serum and 1/10 slope Streptococcus autogenous vaccine. By this time the tongue was dry and tremulous. The hands and head showed typical tremor, but tetanoid spasms had not yet appeared. The pulse was rapid and weakening, the temperature was high, and the patient was very ill. The local reaction to the vaccine was very slight, and undoubtedly the dose was too small. The general condition of the patient was, if anything, improved. Certainly he was no worse. On June 16th he had 1/2 slope sensitized vaccine, and the next day his condition had greatly improved. His tongue was moist, his pulse was improved, and he felt much better. On June 19th and 22nd, 1 slope of sensitized vaccine was given, and from June 23rd his temperature gradually fell to normal, the tremor disappeared, and the facies, previously drawn and anxious, became again healthy. The patient now looked and felt well. On July 1st the temperature began to rise again a little in the evenings, and a cough appeared. Dullness and ralls could be made out in the left lower lobe behind, and the patient was coughing up pus by July 3rd. The original vaccine was continued for some time, with good results. The general disturbance produced by the abscess of the lung was remarkably small, and he felt fairly well. His only discomfort was his cough and sputum. The sputum was almost pure pus, and at times he expectorated 2 or 3 fluid ounces of it almost at once. After such a bout of coughing he was relieved for a day or two. On several occasions, while coughing up and expectorating these huge amounts of pus, he almost died from suffocation. On July 3rd, a vaccine made from his sputum, and containing 1/7 slope pneumococcus, 1/14 slope pneumobacillus, 1/20 slope M. carteralis, in 1 cc was incorporated with his original vaccine. The result was excellent. After 2 doses, the cough and sputum were reduced to almost negligible proportions, and his general condition rapidly improved. The cough and sputum remained in this modified form for 2 or 3 weeks, and then gradually disappeared. His amputation stump was secondarily sutured on September 25th and healed by primary union. The patient was evacuated to hospitalship well and able to look after himself on October 28, 1917. In this case, although progress was somewhat slow, everything went to show that the autogenous vaccines saved the man's life. 2. Coliform type. This is a somewhat rare but interesting type of septicemia or basilemia complicating wounds. In a series of nearly 2,000 cases of gunshot wounds, 5 cases of this condition were discovered. As it is a relatively mild condition, it is possible that some cases have been missed. B. coli communis. In one of the cases, typical B. coli was isolated. A brief account of this case may be given. Private C., RAMC, was wounded by HE on May 8, 1917. He sustained a severe compound fracture of the upper extremity of tibia and fibula. He was admitted to the base hospital on May 9th, and the wound was treated with Carroll tubes and Usol. On May 17th, the knee joint was distended and painful, and a secondary hemorrhage from the tibial vessels occurred. The limb was amputated through the lower third of the femur, when it was seen that the joint had become infected through the superior tibio-fibular articulation. On May 23rd, secondary hemorrhage again occurred, this time from the femoral artery in the stump. The artery was religatured higher up. On May 26th, the artery gave way again, and secondary hemorrhage occurred for the third time. This time the artery was ligatured in Hunter's Canal, but death occurred 2 hours later. The temperature had been running from 99 degrees to 100 degrees F until May 18th, when it suddenly rose to 104 degrees and remained high and remittent, 101 degrees to 104 degrees, until death on May 26th. A blood culture performed on May 22nd yielded typical B. coli. Apart from the high remittent pyrexia and severe general illness, there were no typical or characteristic symptoms. In this case, the temperature chart, general appearance, and blood culture suggested that B. coli septicemia was present during the 8 days preceding his death. It is impossible to say what the course of the disease would have been had not the third hemorrhage terminated his life, but the appearance suggested that this particular form of septicemia, a B. coli basilemia, is a severe one, and one that would lend itself to specific treatment by autogenous vaccines. The correlation of this septicemia with severe compound fractures, and also with severe and repeated secondary hemorrhage, are probably points of some significance. Coliform bacilli. General features. The other 4 cases of coliform septicemia formed a single clinical group. 3 were associated with compound fractures, and 1 with a gunshot wound of the abdomen. The average length of time between date of wound and onset of septicemia was 21 days. The period of pyrexia due to the basilemia was, in 2 cases, separated from the pyrexia due to the wound sepsis by an interval of apyrexia. In the other 2 cases, the temperature never reached the normal line until the basilemia had disappeared, but the pyrexia due to the basilemia was clearly demarcated on the chart by the increased height of the temperature and the depth of the remissions. In all 4 cases, the disease ran a typical course of 7 to 9 days intermittent pyrexia. The chart from the GSW abdomen case is appended to illustrate the type of fever produced. Symptoms. The symptoms were not characteristic. They were the general ones of moderately severe fever. The condition resembled in general features paratyphoid fever, but there was no eruption nor any of the peculiar features of that disease present. Repeated Widal tests for the enterica group were quite negative, as were also the examinations of feces. The urine was not tested. After a period of 7 to 9 days intermittent and remittent fever, during which the patient was sharply ill, the symptoms subsided and convalescence was rapid. Causal organisms. A coliform bacillus was isolated from all 4 of these cases by blood culture on the 3rd or 4th day of the disease. In 3 of the cases, the organisms isolated bore a striking similarity, and their reactions did not enable them to be identified as any known or described organisms of the coli typhoid group. They were gram-negative, non-motile bacilli, growing readily on agar and on bile salt agar. They produce acid and glucose media, but not in lactose, mannite, saccharose, nor dulcite. 2 of the strains acidified litmus milk, and 1 clotted milk in addition. Although these carbohydrate reactions resembled those of B. dysentery, Shiga, the growth on agar was different from that of the dysentery bacillus, nor did agglutination by high-potency anti-Shiga serum occur. The 4th organism gave reactions similar to those of B. coli anaerogenes. Allied basilemia. The above form of septicemia is particularly interesting in that it resembles an infection which not uncommonly occurs during convalescence from acute bacillary dysentery. The pyrexia in the latter cases is of about the same duration, 7 to 9 days, and the clinical appearance resembles those mentioned above very closely. About a dozen of such cases have been seen by the authors and verified by blood cultures, the organisms obtained being in most cases B. coli, and in several cases coliform bacilli of various kinds. Treatment. In all the cases noted, except that due to typical B. coli, the condition has subsided uneventfully under ordinary general treatment. No specific treatment has been so far called for, but in case of a more severe or dangerous illness of this type, we would not hesitate to employ autogenous vaccines. The case in which coliform septicemia complicates a gunshot wound of the abdomen is quoted as an example. Private B, 220th London Regiment, was wounded on April 24, 1917, in the right leg, right upper arm, and in the abdomen. All the wounds were excised at the casualty clearing station, and Carroll's tubes applied to the wounds in the limbs. The abdominal wound was perforating, the wound of entry being over the ascending colon, and the wound of exit in the left lumbar region. The abdomen was opened at the casualty clearing station, and a hole in the descending colon was sutured. On admission to the base hospital on May 2nd, there was a fecal fistula in connection with the abdominal wound of entry. The other wounds were clean. The temperature settled to normal on May 6th and remained so until May 15th. From May 15th to 22nd, the pyrexia shown on the chart occurred. On May 18th, a blood culture was performed and yielded a coliform bacillus. The consequent progress was uneventful. The fistula was closed on May 30th, and the other wounds were sutured. On June 29th, he was evacuated to hospital ship. 3. Gas gangrene type, pyemic or metastatic gas gangrene. This type of pyemia has been described by various observers during this war. Cuthbert Wallace has mentioned 2 cases in which metastatic lesions were manifest shortly before death, and 2 similar cases are recorded by Kenneth Taylor. Mullally and McNee describe a remarkable case in which the bacillus of malignant edema circulating in the blood became localized at the sites of injections of antiseptic serum and pituitrin. Hartley has described 5 cases of metastatic gas gangrene, with recovery in 3. We have met with 5 cases of this metastatic gas gangrene pyemia. These were all so rapidly fatal that blood culture could not be performed during life. But B. perfringens was recovered from the heart's blood in all cases at the post-mortem examination, which was always held very few hours after death. In 4 of the cases, the condition was a complication of gunshot wounds with compound fracture or lung injury. In 1 case, the gas gangrene supervened on an accidental fracture of the tibia and fibula. This case is described under complications of gas gangrene. In all these cases, gas gangrene was present in the original wound. The metastases, except in cases in which they occurred in the lung, were localized to sites of pressure, 2 being in the muscles of the buttock and 1 in those of the scapular region and posterior triangle of the neck. The muscles in the area of the metastases were brick red where the process was commencing, and grayish where it was more advanced, were crepitant, and exuded thin saneous fluid and bubbles of gas with a peculiar heavy odor. Where the process was advanced, there was discoloration and Boulais formation in the overlying skin. The muscle fluid and the fluid in the Boulais in all cases contain B. perfringens in large numbers. The prognosis is bad. In all our cases, death occurred within 2 or 3 hours of the metastatic condition being observed. Hartley has described 3 cases in which the spread of the condition was much less rapid than this, and in which recovery followed early excision of the gangrenous part of the muscles in the metastasis. For further remarks on this condition, with description of cases, the reader is referred to the previous chapter on gas gangrene, and to the following section on mixed type. 4. Mixed type. On rare occasions, more than one organism may be found in the bloodstream, giving rise to septicemic symptoms, more especially at an advanced stage, when death is imminent. In such double general infections, the offending organisms may be the aerobes only or a combination of aerobe and anaerobe. We have met with 3 cases of this condition, of which 2 were found to have Streptococcus and coliform bacillus in their blood, and the third to have Streptococcus and B. perfringens. All 3 cases presented typical symptoms of streptococcal septicemia, and clinically there was little, if anything, to indicate a double hemic infection. A. Streptococcus and coliform bacillus. In both cases presented a typical clinical picture of streptococcal septicemia of the type with the sudden onset which has been described above. One example may be quoted. The tetanoid spasms were not present in this case, but were typically present in the other. Patient L, 221st London Regiment, was wounded by shrapnel on the left side of the back on April 7, 1917. The wound was a long burrowing one which terminated in a compound fracture of the 10th rib. The wound was excised and treated with Carroll's tubes and Usol. The temperature had settled to normal by April 1st and remained so until April 19th, when it rose suddenly to 103 degrees F, and remained high and remittent until death on May 16th. The septicemia lasted 27 days. He had frequent rigors. The tongue became dry, fissured, and tremulous. Pulse was at first slow and full, and later on rapid and weak. The typical tremor, delirium, progressive weakness, and emaciation were present. 8 days before death, signs of pyemic abscess in the left lung appeared, and 4 days before death the right lung also became involved. A blood culture on May 2nd yielded a typical Streptococcus pyogenes, along with a coliform bacillus, whose salient characters were as follows: a small gram-negative, non-motile bacillus growing profusely on agar and in pale colonies on MacConkey agar. It produced no fermentation of lactose, glucose, mannite, dulcite, or saccharose, but clotted milk. It liquefied gelatin and produced indole and peptone water media. This case was treated with anti-streptococcal serum without result. Autogenous vaccines had not been tried at this period. B. Streptococcus and B. perfringens. We have seen one case which resembled fairly closely the pure streptococcal type. There was never any clinical evidence of gas gangrene, either in the wound or metastatically, and this fact, so far as we are aware, makes this case unique in the literature of the gas bacilli. It is, of course, common for the B. perfringens to be isolated from wounds which show no clinical signs of gangrene, but rarely, if ever, has the corresponding condition in the bloodstream been described. That B. perfringens was in the blood for a considerable time without producing any gaseous manifestations of its presence was clearly shown, for it was cultured from the blood during life on 2 occasions at an interval of 17 days, and was cultured also from the heart's blood post mortem. All these cultures yielded the typical reaction of the perfringens group in milk culture medium, and pure anaerobic cultures of the organisms on agar were obtained. In gas gangrene pyemia, or metastatic gas gangrene, which is now a well-recognized clinical entity, the gas bacillus must reach the site of the metastases in most cases by the bloodstream. Not uncommonly, the metastatic lesions in such cases are situated on the opposite side of the body from the primary lesion, e.g., in the buttock of the opposite side. In no case, however, has gas been noted within the blood vessels during life, and one must conclude that the organism cannot undergo multiplication to any appreciable extent in the bloodstream. The case described below as mixed septicemia, whether it be regarded as primary true gas gangrene septicemia without pyemia, or as primary streptococcal septicemia, both organisms have been present in the blood, leads also to the same conclusion that gas bacilli may be present in the circulating blood without producing visible gaseous signs of its presence. The reader is referred to the chapter on bacteria of wounds, where it is shown that B. perfringens has no power of growth in fresh normal serum. This fact suggests an explanation of the phenomenon that some property possessed by the serum during life is an inhibiting influence on the growth and multiplication of the organism in the bloodstream. The relative frequency of its presence in the circulating blood without pyemic manifestations could only be determined by careful systematic blood cultivations from a large series of cases. The presence of metastases may be determined by pressure, by local devitalization of various kinds, such as that produced by gas gangrene toxemia from a primary gangrenous lesion, or by other obscure factors. One or more of such factors may then supply the lacking condition for the multiplication of the organism, and set up that explosive growth which is so characteristic of its activity. The following case is also of interest in that it shows the remarkable effect which may be produced by autogenous vaccines in cases of septicemia in which the Streptococcus is a causal organism. Patient D was wounded in May 1917 by H.E. He sustained a severe wound of the right shoulder, with compound fracture of the acromonian process and spine of the scapula, compound fracture of the upper extremity of the humerus, and penetration of the shoulder joint. The wound was excised as far as possible and treated with Carroll's tubes and Usol. In June, symptoms of septicemia arose. Temperature became high and remittent, pulse soft and rapid, tongue at first moist, later became dry and tremulous, complexion very sallow. The tremor appeared at a later stage of the disease. Tetanoid spasms did not occur. 10 cc of blood were drawn for culture on June 16th and were distributed, according to the usual procedure, between 1 tube of milk and 2 of broth. After incubation anaerobically for 24 hours, the milk culture tube was found to show the typical stormy fermentation associated with the perfringens group. After several anaerobic cultures from this tube, a pure culture of B. perfringens was obtained on agar. The broth tubes yielded no growth. A week later, the septicemic symptoms began to resemble more closely those of the streptococcal type. The tongue became dry with a central furred zone. The tremor appeared. The patient was by this time extremely ill. Since the symptoms suggested streptococcal septicemia, and the streptococcus had not been found in the blood, a catheter specimen of urine was cultured, and it yielded a pure and abundant growth of a long-chained streptococcus which grew in minute colonies on trip agar. A vaccine made from this organism was injected on June 26th in a dose of 1/4 slope, preceded by 10 cc antistreptococcal serum. The patient on this day appeared moribund, and one of us had great difficulty in persuading the medical officer in charge of the case that the vaccine should be tried on a patient who was obviously in extremis. The patient looked and felt better the next day, and although a day or two previously he had virtually abandoned the struggle and made all preparations for death, he now said firmly that he was not going to die after all. On June 29th the improvement had still continued. The tongue was moist again for the first time since about June 20th, and the tremor had almost gone. He was eating and sleeping well. The temperature, however, did not become normal, although it fell a degree or two. A second injection of the sensitized vaccine on June 29th was followed also by good results. On July 2nd, he had reached the zenith of his improvement. By July 5th, he had again become weak. The tongue was dry, his wound was very foul, with pus pocketing in various directions. He was too ill to stand the operation of amputation of the arm, complete with scapula, which would have been the only way of removing his septic wound. On July 3rd, blood was again withdrawn for culture, and on this occasion the milk and broth tube were incubated anaerobically. B. perfringens was again cultivated from these tubes, and in addition both tubes yielded Streptococcus pyogenes. On July 6th, a combined sensitized vaccine was injected, containing both strains of streptococci, that isolated from the blood and that from the urine. This was followed by a second transitory period of improvement on July 7th, 8th, and 9th. After this, in spite of all treatment, he went steadily downhill and died on July 23rd, i.e., 27 days after the first injection of vaccine had been given, when he appeared to be in a moribund condition. Post-mortem notes. The body was emaciated to an extreme degree. Lungs. The whole of the right lung was collapsed and full of tuberculous nodules, both caseating and cicatrized. Many of the lesions were active. The whole of the right pleural cavity was obliterated by adhesions, and the pleurae were greatly thickened. Similar tuberculosis lesions were scattered through the substances of the upper lobe of the left lung, and the apex was very adherent. The bronchial, mediastinal, and mesenteric glands were enlarged, some were caseated, and others calcareous. All the organs of the body were extremely atrophic. The blood contained no gas. From the heart's blood there was obtained by culture B. perfringens and streptococcus. End of chapter 10.
Chapter 11 of War Surgery from Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Dr. Beth Thomas. War Surgery from Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 11. Effects of Climate and Certain Diseases on Wounds with Diagnosis and Treatment by Lieutenant Colonel L. F. Smith, CMG, RAMC. These remarks apply to the Salonika Army. Climate. The effects of climate per se on wounds, and as a predisposing cause of their infection, have been frequently discussed. Climate itself would appear to have little effect on wounds, except in delaying union, and thus acting as a predisposing cause of infection. This delay in union was not often seen in the cases alluded to in the other chapters, but in hotter and damper climates it is a real menace. In Aden especially, it has been noticed that clean operation wounds do not rapidly heal. They exhibit a want of tone, and sometimes remain patent for a considerable period. In Salonika, where delay in union of wounds from climatic causes alone occurred but rarely, conditions vary much during the different seasons. In the winter time, frequent cold spells alternate with warm spring weather, whilst in the summer moderate heat, about 100 degrees Fahrenheit, prevails, with occasional thunderstorms. At all times, except during and after rain, dust is abundant. This is a real menace and a possible potent factor in infection. For 2 or 3 days together, when the north wind, called the Vada wind, was blowing, it was impossible to operate upon or even to dress cases. When dressings were taken down after the wind had subsided, the advantages of the Carroll-Dakin scheme of treatment were apparent. Although the dressings were in many cases impregnated with dust, which dust to a large extent was composed of dry horse dung, the continuous sterilization had been going on, and no evil effects on the wound were noticed. Beyond what has been said, climate and climatic conditions per se do not appear to further influence the progress of wounds. Diseases peculiar to the country. There is not the slightest doubt that diseases associated with climate or geographical situation do markedly influence the progress of a wound. The chief diseases met with in the Salonika are malaria and dysentery. Malaria. Malaria, as is usual, is divided into 3 types: benign and malignant tertian and quartan. The latter may be disregarded, as out of 13,000 cases only a few scattered cases were seen, and from the surgeon's standpoint not much difference is to be noted between the 2 tertian forms. It may be mentioned that in a long tropical experience, including in its scope various parts of India, Arabia, and West Africa, no malaria of equal severity to that obtaining in Salonika had been previously seen by the writer of this chapter. The rapidity with which serious and even fatal symptoms, especially of the cerebral type, came on, even in newcomers to the country, the extraordinary virulence of the attack as shown by profound anemia and cardiac symptoms, in the form of persistent tachycardia with liability to faints, are quite rare in cases of malaria as met with in other parts of the world or as described in books. As the fall of the Grecian Empire has by some been attributed to the advent of malaria introduced from the East, The explanation may lie not in the introduction of the disease, but in the pernicious type that was introduced. It was admitted by practically everybody that most wounded men on this front had suffered from malaria or were malarial carriers, even where there was no previous history of a definite attack, or at any rate an attack of such severity as to necessitate reporting sick. It will thus be seen that the disease, even though latent, must inevitably play a large part in complicating wounds and their treatment. Effects of malaria complicating wounds. The effect of malaria on wounds may be A. general, B. local, or both. A. General effect. It has been noticed that the mere infliction of a wound, whether it be received in action or in the operating theatre, is sufficient to precipitate an attack of malaria, not only in those who have had one or more previous attacks, but also in those who had not consciously suffered from the disease before. This attack may be either of the usual sharp variety, characterized by the cardinal signs of shivering, followed by sweating, headache, and sudden rise of temperature, or the more insidious type of cerebral malaria, with head symptoms coming on slowly and gradually, or coma coming on at once. In the first or ordinary type, no great difficulty is experienced by those who have any knowledge of the disease in diagnosing and treating the case. A blood film should be taken and examined as early as possible, and the usual treatment carried out. The blood film determines the type and shows as to whether the rise of temperature and the concomitant illness is due to sepsis or not. But even if the film, as sometimes happens, is negative, this does not exclude malaria. An anti-malarial treatment should be energetically carried out. Quinine, properly administered, will act as a diagnostic as well as treatment. It is the cerebral type which is difficult to diagnose accurately and to treat always with success. A man is brought into hospital suffering from a very severe gunshot injury, such as an extensive compound comminuted fracture of the femur or a compound depressed fracture of the skull. He is dealt with on ordinary surgical lines and appears to be doing well. On the same evening or the next day he goes off his head, becomes delirious, talks nonsense, gets drowsy, or even gets delusions of persecution with suicidal tendencies, as occurred in one case who attempted self-destruction by cutting his throat. The temperature may run up to 105 or 106 degrees, or, on the other hand, may keep at a lower level, not rising above 101 or 102 degrees. To one without experience, it may easily happen that the whole of this train of symptoms may be put down to the injury, and consequently the disease remains untreated. The principle adopted in the hospital in which these wounds were dealt with was to take it for granted that all these cases were suffering from malaria, and to treat them as such in addition to their wounds. If cerebral symptoms appeared, they were more energetically treated. To show the difficulty that may be experienced, we may quote one case. Private was admitted to hospital with a severe fracture of his right femur on October 12, 1917. In addition, he had sustained abrasions of the scalp and other parts of his body. He had not been given anti-tetanic serum up the line. The fracture was dealt with under an anaesthetic. The same evening he complained of difficulty in swallowing and opening his mouth, and he passed a very restless night. On admission, he was given 1,000 units of anti-tetanic serum. On the next day he still had some difficulty in swallowing, with stiffness and rigidity in the muscles of the back of the neck. He was given a further dose of 1,000 units of anti-tetanic serum. His temperature at this period was between 102 and 103 degrees. Towards evening the temperature was 102 degrees. The stiffness in the neck muscles was still present. Koenig's sign was present. He vomited and became drowsy. Cerebrospinal meningitis was thought to be a likely solution of his case. A lumbar puncture was performed, and though the fluid was under tension, yet it was clear and bacteriologically negative in every way to this condition. A blood film proved negative to malaria. He was given 40 grains of quinine intramuscularly. On the following day he was still comatose, totally incontinent of both faeces and urine, looking blue about the lips and ashen about the face. Tachycardia was very pronounced. He was given 50 grains of quinine intramuscularly. His temperature was 102 degrees, he was still very drowsy and incontinent, and the cardiac condition had not changed. Towards evening he started to improve, the tongue was cleaner and he was more rational. Since this time, and it is now the 9th day since the onset, he has made satisfactory progress. He is quite rational, taking food well, tongue clean, no incontinence by day, though he still has nocturnal enuresis, temperature 99 degrees, and there is tachycardia. He is still receiving 20 grains of quinine intramuscularly each day. This was an undoubted case of severe cerebral malaria, and it is interesting in that it shows the difficulty for those who have had little experience of the disease in making an early and correct diagnosis. There is little doubt that this severe attack was precipitated by the injury and its necessary surgical treatment. The case is also interesting in that it shows, as I have seen in other instances of cerebral malaria, rigidity of the muscles in the back of the neck, headache, drowsiness, vomiting, and the presence of Koenig's sign. Thus, the syndrome of cerebrospinal meningitis can be closely imitated by cerebral malaria. Control of the sphincters may be completely lost with dual incontinence, and this incontinence, as improvement proceeds under treatment for the malarial condition, improves during the daytime but persists while the patient sleeps. This complication appears to be difficult of treatment, besides being a very potent source of infection to open wounds. Treatment. The treatment of malaria consists in the exhibition of quinine after well emptying the bowels with calomel, followed by magnesium sulfate and an enema if necessary. Latterly it has been strongly urged by workers whose experience of the disease lay chiefly in England, that it is immaterial whether quinine is given by the mouth, intramuscularly or intravenously. This is quite contrary to our experience both in Greece and elsewhere. For benign and malignant tertian of the ordinary mild type, quinine by the mouth will suffice, especially if not less than 45 grains are given daily until the patient is well under the influence of the drug. But if there is vomiting, a dirty coated tongue or gastritis, quinine by mouth is useless because the patient cannot absorb it. Intramuscular, or if necessary intravenous administration of the drug must be carried out for all such cases, and for all cases of the cerebral type. And no small doses will suffice. 20 grains intramuscularly twice a day, as a rule, is enough, but if no improvement is shown or drowsiness continues, larger and what would be called heroic doses must be tried. One case in particular with severe anemia and marked coma was given 20 grains intramuscularly, followed in 2 hours by 20 grains intravenously, followed later in 6 hours' time by 20 intramuscularly. On the following day 2 intramuscular injections, each of 20 grains, were administered before any definite improvement took place. Objections to intramuscular administration of quinine. The chief objection to the administration of quinine intramuscularly is the risk of abscess formation at and around the site of injection. Such an occurrence can only be due to want of care and knowledge of technique. Method of intramuscular administration and the technique. After thoroughly preparing the skin and painting with iodine, the needle of the syringe is entered at a point in the skin 2 inches below the midpoint of the iliac crest. The needle should be about 1½ inches long, and it should be entered perpendicularly to the skin. Quinine bihydrochloride, sterilized in normal saline solution in the proportion of 1 to 2, is now injected up to the required amount, 10, 20, or 30 grains being given. In rare instances where after several injections the buttocks are sore and painful, the arm may be selected, the deltoid being the best and most convenient muscle. Unless absolutely contraindicated, we would always recommend the buttock as the best and safest site for intramuscular administration, for accidents have happened when the arm has been selected, a number of cases of musculospiral paresis having resulted. The medical officer giving the intramuscular dose of quinine must be sure that his solution of quinine is sterile and reliable, that his hands, the patient's skin, and the syringe are sterile, and that he injects the solution into muscle and not into subcutaneous tissues. Intravenous administration of quinine. This is called for chiefly in the treatment of the severe types of cerebral malaria. The all-important question seems to be, how much fluid can a severe case of cerebral malaria tolerate? Owing to the existing degenerate state of the myocardium in these bad cases, the heart can stand very little extra strain, and very rapidly gives out, death following as the result of paralytic distension. One case may be quoted to illustrate this. Private Blank, who had just got over the worst part of an attack of malaria, was feeling fairly well and sitting up. He made a sudden effort to kill a fly on his bed with an ordinary fly flapper. Before the act of killing the fly was completed, he fell back dead. A post-mortem examination revealed an acutely dilated right heart with advanced degeneration of the myocardium. There is at present in hospital a case of a patient who, while undergoing treatment for a fractured femur, suddenly developed cerebral malaria and became comatose. With energetic treatment he has got over the worst part of the attack, but on the slightest exertion he suffers from tachycardia, the pulse rate going up to 120 or more. This makes attention to his wounds a very difficult and anxious procedure. In a few cases, death has occurred either during or immediately following the intravenous administration of quinine. Consequently, this method of giving the drug was open to criticism, and at the time condemned by certain observers. At this particular period, the amount of normal saline solution introduced with the drug was considerable, and it is quite conceivable that its introduction into the circulation was more than the heart could then deal with. Profiting by experience, we now give with the drug an amount of saline which has been reduced to a minimum. Not less than 8 ounces, and not more than 12, appear after considerable experience to be the limits of safety. The skin covering the vein selected is thoroughly cleansed and disinfected with iodine. The medical officer, after thoroughly washing his hands, proceeds to introduce the sterilized needle into the vein. When once the needle is in the vein, the dose of quinine bihydrochloride in the 8 or 10 ounces of warm normal saline solution is very slowly run into the circulation. The process should be carried out very slowly indeed, so that no undue strain is at any time put upon the degenerate heart muscle. A case may be quoted to show what dose of quinine may be given in the 24 hours if necessary. Private Blank was admitted to hospital suffering from malaria. Despite quinine given in 30-grain doses by mouth, 2 doses of 15 grains daily, he suddenly became comatose within 48 hours of admission. He was given during the next 24 hours 60 grains of quinine intravenously and 60 grains intramuscularly, that is, 120 grains. He rapidly regained consciousness within the next 12 hours, and when seen at the end of this period, he had tachycardia and a considerable degree of jaundice. He was, however, able to take fluid nourishment and to retain it. During the following 24 hours, he was given a further 180 grains of quinine, both intramuscularly and intravenously. The change in his condition in 48 hours was magical. From deep coma he became conscious and rational, taking food well and reading the daily paper. This is only one example from a number of similar cases. Treatment of severe malarial anemia. Some of the severest types of anemia may follow malaria, and clinically these resemble pernicious anemia. They differ, however, in that the colour index is below unity, though normoblasts and other atypical blood cells are present. These cases are particularly severe and serious. Vomiting with blood in the vomit and diarrhea are 2 serious complications of malaria, besides total disinclination for food and inability to digest it when taken. These cases respond badly to quinine, and the best results have been obtained by direct transfusion of blood from a healthy donor. Direct transfusion of blood. The 2 methods that have been used in performing this operation are as follows. A. By multiple syringes. The donor is seated in a chair. After carefully cleaning the skin, the needle of a 10 cc glass syringe is introduced into the vein. The syringe is filled with blood, detached from the needle which is left in the vein, and handed to another medical officer, who immediately empties it into the vein of the recipient. While this is taking place, another syringe full of blood is extracted from the donor and again passed on to the recipient. Periodically, the needle in the vein of the recipient is flushed with 10 cc of normal saline. During this process, 8 or 10 syringes, all of equal size and pattern, may be in use. When the desired quantity of blood has been transfused from donor to recipient, the needles are removed from the vein of both and a dressing applied. The advantages this method possesses is that by its adoption it can be accurately gauged how much blood the recipient has acquired from the donor. B. By cannula and tube. This method, though less accurate, has given good results. 2 glass cannulae are connected by means of a piece of rubber tubing. The whole apparatus is boiled and then immersed in sterile medicinal paraffin. The median basilic vein is exposed in both donor and recipient, who lie in bed side by side, the feet of one being directed towards the head of the other. The 2 arms are now placed side by side, the hand of one man being directed towards the axilla of the other. The cannulae with the connecting rubber tube are now removed from the paraffin and filled with normal saline. The cannula introduced into the vein of the donor should have its apex directed towards the hand, and the vein should be ligatured above the opening made in it for the introduction of the cannula. The cannula in the vein of the recipient should have its apex directed towards the axilla, and the vein should be ligatured below the opening. A Martin's rubber bandage is now wrapped around the upper arm of the donor, not tight enough to stop the arterial flow, but sufficiently tight to interfere with the venous return. This gives a greater venous pressure in the arm of the donor than in that of the recipient, and consequently a direct flow of blood is established. To make sure the blood is running, the needle of a 10 cc syringe is periodically introduced into the rubber tubing, and after pinching the latter, 10 cc of saline are introduced into the vein of the recipient. This clears the glass cannula, and on releasing the rubber tubing, it will be seen if the blood still continues to flow. The process should be stopped immediately on any sign of faintness appearing in the donor, who will always say if he feels faint. This method has been employed in this hospital on more than one occasion with good results. The drawbacks to direct transfusion of blood are considerable. 1. It is difficult in a country like Macedonia to find a healthy donor, for most men have either consciously or unconsciously had malaria. 2. There are constitutional or acquired diseases to be borne in mind in the case of the donor. 3. Men cannot often afford to give blood in the climate and conditions that obtain in a district like Salonika. B. Local effects. 4 chief local effects have been noticed in large wounds. They are as follows. 1. A tendency to bleed. This has taken the form of a generalized oozing from small capillaries, and is especially noticeable in those cases which have a concomitant jaundice. This bleeding may last a considerable time, and is liable to occur after operation in such cases as radical cure of a hernia, appendicectomy, and the like. Hence it is inadvisable to perform operations of election on anybody soon after an attack of malaria. It is more important to wait until the patient has had treatment for at least a month. 2. In many cases it has been noticed that while wounds appear to be progressing favourably, especially those being prepared for secondary suture, a halt takes place, and the wound surfaces become pale and covered with a glary, sticky substance somewhat like mucus. No further healing occurs until quinine is exhibited, when the condition passes off, the wound rapidly sterilizes, and becomes fit for secondary suture. No other signs of malaria are present. Should the administration of quinine be delayed, the wound eventually assumes the guise of an ulcer with punched-out edges and a serpiginous margin. These ulcers in many respects resemble syphilis. They rapidly tend to heal upon the exhibition of quinine. 3. In a number of cases, especially of large wounds, it was observed that white plaques appeared on the wound surface. At first their significance was not understood. These plaques give the appearance of raised white patches resembling dead or sodden epithelium, and they vary in size from that of a pin's head to a threepenny piece. They are difficult to remove, and on scraping them off, a red bleeding surface results. Microscopically, they show structureless debris containing degenerate leukocytes and irregular granules. There did not appear to be a cause for the presence of these plaques when first they were noticed. After a short time it was found that their appearance was, as a general rule, followed within 48 hours by an attack of malaria. When the malaria was treated vigorously, the plaques disappeared. After this had been recognised, the patient, on the appearance of these patches, if not already taking quinine, was given it, or his dose was increased if already under treatment. The result was the disappearance of the plaques and their replacement by healthy granulation tissue. The attack of malaria, as a rule, was aborted, and the wound again assumed a healthy appearance. 4. A red, swollen, painless, erysipelatous condition, not only of the wound itself, but also of the skin and subcutaneous tissues at some distance from the wound, has not been an uncommon occurrence. It has been strongly argued that this complication is due to sepsis. Our answer to this argument is that if it be due to sepsis, then such sepsis occurring in a wound undergoing an uncomplicated course of continuous sterilization, with favorable bacteriological reports, is but the symptom of some underlying condition. In all these cases, some 15 in number, the onset of this angry erysipelatous condition has been ushered in with a shivering fit, severe headache followed by a sweat, with or without vomiting. In 9 of these 15 cases, the malarial parasite was found, but in every case without exception, the temperature settled and the erysipelatous condition totally subsided within 48 to 72 hours on the exhibition of quinine. These cases are too numerous to be coincidences. Hence, I think it may fairly be taken for granted that such a setback to a wound is malarial in origin. The accompanying plate illustrates the condition shown in these 15 cases. Examination of the blood for malaria. In ordinary cases, the best time to make the blood film is when the temperature is dropping, for then the parasite is relatively large and easily seen, and the type can be better determined. In many cases, however, of mixed infection and of malignant tertian, or even very heavy benign tertian infection, and of malaria following wounds, the temperature does not drop at once, and films should be made as early as possible, preferably before any quinine has been given. The administration of quinine has a very profound effect in diminishing the numbers of parasites in the peripheral blood, making it difficult or impossible to find the parasites in a blood film. The film should be made by the method illustrated. This has been found to give the most uniformly satisfactory results in this hospital, where at the time of writing over 200 blood films are examined each week. 2 grease-free slides are used. The lobe of the ear, or distal phalanx of the thumb, is cleaned with spirit and thoroughly dried with sterile gauze or wool, or by passing the thumb through the flame of a spirit lamp. A puncture is made with a sterile needle, and 2 or 3 small drops of blood are caught on the end of one slide in the position shown. The other slide is then held with one end in contact with the first and placed about half an inch in front of the drops. The inclination of the second slide to the first is about 50 degrees. The end of the second slide is then drawn backwards upon the first until it comes into contact with the drops of blood, and the blood runs along the posterior edge of the end of the second slide. The latter is then pushed along the whole length of the first slide, and in doing so drags a film of blood along with it. Any desired thickness or thinness of the film may be got by varying the angle of inclination of the second slide to the first. By this method a perfect film can be very easily obtained. When it is examined under the microscope, it is seen that the individual blood corpuscles are spread out separately side by side and not crushed up or in rouleaus. Leishman's stain has been found to give the best picture. When the slide is dry, the film is covered with Leishman's stain for 1 minute, and then 2 volumes of water added. The diluted stain is left in contact with the film for 15 minutes, and then the slide is washed and allowed to drip dry. All stages of the life cycle of the benign tertian parasite, as it occurs in man, may be seen in these films, and if the parasite be older than the ring form, Schiffner's dots are beautifully shown surrounding the parasite in the substance of the affected corpuscle. The forms of the malignant tertian parasite commonly seen are the delicate ring forms and the crescents. The quartan parasite is extremely rare, having been seen in this hospital only 4 out of about 8,000 films examined, of which 50 to 60% were positive. After an attack of malaria, a leukopenia is found in the blood, with a marked relative excess of mononuclears. In very many cases here, where, probably owing to the previous exhibition of quinine in large doses, the parasites were not discovered, It was found that the mononuclears were increased to 70 or 80% of the total leukocytes, and there was much pigment ingested in their endoplasm. This feature was considered quite diagnostic of malaria, and the diagnosis was very often justified by subsequent developments. The thick film method is very useful for detecting scanty parasites, in particular crescents. A large drop of blood is spread out very thickly on a slide by means of a needle, allowed to dry, and then treated with acetic alcohol, glacial acetic acid 2 parts, alcohol 1 part. This fixes the film and also hemolyzes the red corpuscles, leaving the white corpuscles and parasites. The film is thereafter stained with Giems's stain and examined in the usual way. Crescents can often be found in large numbers by this method in cases where the ordinary thin film method fails to detect them. Post-mortem findings in fatal cases of malaria. The chief organs showing gross changes in fatal cases of malaria are the heart, spleen, the liver, and often the kidneys. The heart is dilated and the ventricle walls are thinner than normal. The myocardium is soft and in a condition of fatty degeneration. The liver is enlarged, and here fatty degenerative changes are present. The spleen is large, soft, and diffluent, and the kidneys often show a degree of fatty degeneration. The brain, in cases dying of cerebral malaria, may or may not show an engorged condition of the vessels of the Pia. In nearly all cases the whole substance of the brain is peppered with petechiae and foci of thrombosis of the minute vessels. These vessels can be shown to be completely blocked by malarial parasites. It is a point of interest to note that out of many lumbar punctures performed on comatose cases of cerebral malaria, the cerebrospinal fluid, though usually under pressure, is quite clear, and repeated examinations by the bacteriologist have revealed nothing abnormal either as regards cell content or bacteria. Again, none of these cases have appeared to benefit clinically in any way as the result of the puncture. From the gross post-mortem findings alone, it is easy to understand that malaria, by its destructive influence on the excretory and other organs, apart from its toxins and blood destruction, must exert a very baneful influence both on wounds and wounded men. It might be of interest to note that out of the 13,500 cases of malaria treated at this hospital, the death rate works out at 0.48%. Dysentery. The effects produced in wounds by dysentery are largely due to the debilitating effects of the disease. The local effects are practically nil, except in the case of buttock and thigh wounds and abdominal wounds, in which there is likely to be contamination from the frequent stools. The number of cases in which this has occurred has been small, and it is the nursing of these cases that needs careful watching. Prompt treatment, of course, is essential. Treatment of dysentery. Preliminary purgation by castor oil is usually indicated, especially in the early stages, and thereafter sodium sulfate should be given in doses of 1 dram hourly during the acute stage. Unless there be good grounds for suspecting the dysentery to be amoebic, anti-dysentery serum up to 60 cc should be given subcutaneously as early in the disease as possible. It is of little use even in pure Shiga and Flexner infections after the first 2 days. If the toxemia be severe, intravenous saline should be given without delay. In amoebic cases, the specific treatment is, of course, emetin. Early treatment with emetin offers a very fair prospect of cure. It may be given in the form of emetin hydrochloride or of the double iodide of emetin and bismuth. The latter almost invariably causes excessive nausea and vomiting, and is, further, not now considered to be so effective in eradicating cysts from chronic cases as it was thought to be when introduced a year or 2 ago. It is administered by mouth in doses of 3 grains daily for 12 days, and this course is repeated once or twice after a week's interval. Emetin hydrochloride still remains the stock remedy, and according to Wenyon gives the best results. It should be given in doses of 1.5 grains per day for 12 days, and the course repeated once or twice after a week's interval. 1 grain should be given hypodermically in the morning, and a ½ grain tabloid, keratin-coated, at night. Stools, however, containing blood and mucus, must not always be taken as dysenteric unless confirmation be obtained by bacteriological examination, as many cases of malaria pass blood and mucus, and the treatment must be directed against the primary cause. Quinine must, of course, be given if the case be one of malarial colitis. In cases of wounds of joints, where dysentery is afterwards a complication, it is quite possible that a dysenteric arthritis may supervene in the joint that has been wounded. As dysenteric arthritis, especially of the knee joint, has not been by any means uncommon in Greece, but so far I have not seen a case of dysentery complicating a knee joint wound. Symptoms of dysentery. The disease is characterized by abdominal pain, distension, and vomiting, with very frequent passing of stools containing blood and mucus. Tenesmus is a constant and distressing symptom. The tongue is dry, brown, and coated. The temperature is raised, often to 103 degrees, and the patient rapidly becomes dehydrated. The actual diagnosis of dysentery and the identification of the type rests with the bacteriologist. Bacteriological investigation of dysentery. Early examination of the blood and mucus passed is desirable to obtain good results. The macroscopic and microscopic appearance of the stool should be noted. This often gives a very fair indication of whether the case is bacillary or amoebic. The bacillary dysentery stool usually contain many more pus and other cells than the amoebic stool, and may often contain macrophages or large endothelial cells ingesting blood corpuscles. Amoebic dysentery is a disease of the submucous coat of the colon, and the discharge contains mucus and sloughs rather than puffs. For microscopic examination for entamoeba histolytica, a small piece of the mucus is spread out on a slide in a drop or two of saline, covered with a cover slip, and examined with an oil immersion lens. The diagnostic feature of the entamoeba histolytica is the ingestion of one or more red blood corpuscles within its protoplasm. This distinguishes it finally from amoeba coli. The pseudopodial movements are usually active, but if the amoeba is seen just before encystment, movements may be sluggish, and the ingested red blood corpuscles may have lost their colour. This is a practical point worth noting. Histolytica cysts are small, usually 10 to 14 μ in diameter, and have 1, 2, or 4 nuclei. The mature cyst, with 4 nuclei and chromidial bars in its protoplasm, is typical. A report on the microscopic examination of the stool can be given without delay, and if the entamoeba or its cysts be found or suspected, then emetin treatment should be commenced at once. If amoebic dysentery be not definitely diagnosed but suspected, examination of stools must be repeated daily for several days. In all cases, whether the entamoeba has been found or not, the stool should be examined for bacillary dysentery. Several pieces of the mucus should be teased out in saline in a watch glass or petri dish, and when thoroughly washed with saline, part of it should be transferred to another watch glass with saline. After a second thorough washing and teasing out, a few loopfuls of the fluid with adherent small tags of mucus are plated out upon 2 plates of McConkey agar, and the plates incubated overnight. Next day, any small colourless colonies that may be present are picked off and transplanted into a series of agar tubes. These are incubated for 24 hours, and any tube which shows colonies resembling the slimy, semi-translucent colonies of the dysentery bacilli is tested with regard to sugar and agglutinin reactions, and also as to motility. B. dysenteriae, Shiga, is non-motile and produces acid in glucose, but not in lactose, mannite, maltose, or dulcite, and it is agglutinated by a specific antiserum in at least 1 in 200 dilution. B. dysenteriae flexna forms acid not only in glucose but in mannite and maltose also, but otherwise resembles Shiga's bacillus. A variant of Flexner's bacillus, called Bacillus Y, ferments glucose and mannite but not maltose. Each of these bacilli is agglutinated by its own specific antiserum in dilutions of not less than 1 in 200. The examination of stools for bacillary dysentery usually takes at least 2 or 3 days before a report can be issued, and hence the specific serum treatment should be instituted at once in all suspected cases of bacillary dysentery without waiting for the bacteriological report. Dysentery occurs mainly in epidemics, and if several cases in an epidemic have been worked out, the specific treatment required in further cases, whether serum or emetin, is usually known at the commencement. End of Chapter 11.
Chapter 12 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Sarah Jennings. War Surgery, From Firing Line to Base, by Basil HUGHES and H. Stanley Banks. Chapter 12. Antiseptics. The question of antiseptics in the treatment of the present war wound is both a vexed and important one. The pre-war antiseptics, such as carbolic, perchloride of mercury, etc., have proved of little use in the treatment of the present war wound. They are harmful to the patients generally and to the tissues locally when applied to large wound surfaces. They are strongly inhibitory to the leukocytes, and in the presence of serum and wound discharge, they rapidly lose their bactericidal powers. In brief, they aid infection rather than prevent it, and have consequently fallen into disuse. In selecting a suitable antiseptic for the present war wound, the first important point to consider is the general condition of the soldier, both at the time of receiving his wound and when efficient surgical treatment of his wound can be carried out. Wounded men are usually suffering from severe shock. They are fatigued and have often lost a considerable quantity of blood. They are therefore in a very poor condition to help themselves, as their body resistance at this stage is low. We must therefore seek an antiseptic which is going to help the patient and rely in the least possible degree on the patient helping himself, especially for the first few days following his infliction of the wound. A suitable antiseptic should fulfill the following conditions. 1. It must be innocuous to the tissues. It must be remembered that damaged tissues are of low vitality, hence an antiseptic with a deleterious action upon sound tissues will not only further reduce the vitality of damaged tissues, but will also favor the spread of infection. 2. It must be non-poisonous to the individual when applied in large quantities to an extensive wound. 3. It must be innocuous to leukocytes and not inhibit their function. 4. It must possess high bactericidal properties. 5. It must dissolve and remove sloughs. 6. It must aid and not hinder tissue repair. 7. Its action must not be delayed in the presence of serum or wound exudate. 8. It must be cheap and easily prepared. The chief antiseptics we have employed have been the hypochlorites, viz. Usol and Dakin's solution, Delfresne's modification. The method of preparing these solutions is appended at the end of Chapter 15. It has been argued that the hypochlorites fall short of the ideal antiseptic, in that they do to a certain extent act deleteriously upon the phagocytes. This has not been our experience either clinically or microscopically. The hypochlorites have, when applied to the very worst wounds by the method of Carroll and Dakin, brought about a rapid and complete state of sterilization over a very large number of consecutive cases. The microscopical investigation of these wounds undergoing sterilization has been given on pages 107 to 113. It is quite possible that in vitro the hypochlorites may be to some degree inimical to the leukocytes, but clinically we cannot corroborate this, and we think it is doubtful if such occurs in vivo. If, however, it does, then we can only infer that it is but a question of degree. Otherwise, wounds could not possibly sterilize at the rate they do, nor would the wound show such a preponderance of healthy staining leukocytes with active phagocytosis in progress. We have been constantly asked both by British surgeons and also by surgeons of other nationalities the following question: how do you provide for the drainage of the wound during the time that it is undergoing sterilization by the Carrel-Dakin method? Our answer is that we do not wish to drain the body resources, for why drain away healthy leukocytes from any wound while they are actively phagocytic? In deep sump wounds which have, owing to the Vardar wind, been left for 3 days without dressing, the wound secretion at the end of this time has been wholly composed of healthy leukocytes actively phagocytic. This wound secretion is not pus, as we understand it, for pus consists of degenerate leukocytes, broken down and digested tissue, and bacterial toxins. Further, in such sump wounds which have been full of wound secretion and hypochlorites for 3 successive days, there has been no evening rise of temperature, which would surely be the case if such secretion was pus. On the contrary, these men are fit, they eat and sleep well, and their wounds are very soon sterile. Drainage in wounds of today is wholly unnecessary, and we think the time has now come when this objectionable practice must be definitely abandoned. We might add that such cases as acute suppurative appendicitis, acute liver abscess, empyema, cystitis, carbuncles, and other inflammatory conditions have cleared up in a remarkably rapid way when treated by continuous instillations with the hypochlorites, and have given results which have been far more satisfactory than those achieved by the older methods, both as regards speed and end results. Flavine. This substance is diaminomethyl-acridinium chloride, and was originally prepared by Benda at the suggestion of Ehrlich for the treatment of trypanosomiasis. Its action as a strong bactericide was first pointed out by Browning and Gilmore. It is claimed by these latter observers that this substance has a strong bactericidal action in the presence of serum, and further that serum enhances its action. We have given this compound a trial in 200 consecutive cases of severe gunshot wounds, using the methods both of intermittent and regular instillation, with Carroll's tubes and of gauze dressing saturated with the solution, carefully and loosely packed into every crevice of the wound. In the latter method of treatment, the wound and gauze have been carefully protected with sterilized jaconette prior to applying the wool and bandage. 50 cases were submitted to intermittent instillation, applied 3 hourly, half dram being instilled into each tube. Large wounds by this method received 2 to 3 drams of a 1 in 1,000 dilution in normal saline 3 hourly. By intermittent 3 hourly instillation of flavine into a wound, we arrived at the following conclusions. A. Clinically. In the case of surgically prepared wounds, the wound surface soon assumes a healthy-looking aspect, becoming covered with firm rosy red granulations. This healthy appearance of the wound surface is visible in from 24 to 48 hours after the first application. The wound progresses well up to the 4th or 5th day, when there is a halt. The granulations become covered with a sticky mucoid substance, yellowish in color, and evidently containing flavine. These sticky mucoid patches have been submitted to microscopical examination, and a report on them is given in a succeeding paragraph. Let it suffice here to say that they were not by any means sterile. From this point onwards, the wounds go back both clinically and bacteriologically. Clinically, they become indolent, showing no further active tissue repair, and bacteriological examination shows a marked increase in the number of organisms present in the wound secretions. B. Bacteriological behavior of wounds undergoing sterilization by intermittent instillation with flavine. 25 of these 50 wounds were investigated by the method of taking smear counts performed at 2-day and 3-day intervals during treatment. These wounds were of all varieties, the majority of them being compound fractures. There was a remarkable similarity in the bacteriological behavior of the wounds as estimated by this method. The sequence of events was somewhat as follows. Flavine instillation was commenced at times varying from 2 to 15 days after receipt of the wound. The wounds had been excised and preliminary Carrel-Dakin treatment or Usol dressings applied at the casualty clearing station or elsewhere. On admission to the base hospital, the flavine instillations were at once commenced. The wounds were all discharging and showed smear counts which varied from 2 to 40 per field. Stage 1. Period of apparent improvement. During the first 3 days, a wonderful change took place. The discharge diminished greatly, and in some cases was so small that it was difficult to scrape, even from the deepest part of the wound, sufficient material to make a smear. During this period, the count of bacteria in the smears became reduced to 1 per field or less, and in many cases no organisms were seen at all. The cellular elements in the smears were scanty and gave good staining reactions. There were a considerable proportion of endothelial and fixed tissue cells, and the number of polynuclears was relatively small. The latter must either have been prevented from entering the wound by the flavine, or must have re-entered the tissues after performing phagocytosis. And from what we know of the non-inhibitory action of 1 in 1,000 solution of flavine on the phagocytes, we cannot but conclude that the latter is what really occurred. Stage 2. Indolent period. During the 4th, 5th, and a few subsequent days, a sticky mucoid discharge commenced to appear. This was present particularly in the form of little gelatinous flavine-stained masses adhering to the surface of the wound. These consisted of a heterogeneous mass of broken-down cells and debris embedded in a matrix of fibrin. They contained numerous organisms, including in several cases a number of gram-negative, long, slender, spore-bearing bacilli, in addition to cocci, short bacilli, and various other aerobes. The nuclear structure was indistinct and often lost. During this stage, the smear counts ranged from 2 to 20 per field. The wounds still looked comparatively clean, but sterilization, as shown by smear counts, could not be obtained. Stage 3. Period of retrogression. After the 5th to 7th day, free discharge gradually reappeared. For many days, these sticky gelatinous masses continued to be thrown off in the discharge. Flavine installations were persisted in for a varying period of up to the 21st day, without a sign of improvement. Thereafter, as sterilization seemed to be indefinitely delayed, the wounds were treated by the Carrel-Dakin method. Sterilization then proceeded uninterruptedly, and secondary suture was performed within a week or 10 days after recommencing the hypochlorite. The smear counts during the flavine retrogression period varied from 4 to 30 per field. It may be argued that the smear count method is not an accurate test of wound progress, as it can take no account of the virulence of the bacteria observed in the smears. It has been said that diminution in numbers of the organisms may not necessarily be synonymous with loss of power to cause pathogenic action. In wound therapy, however, since the principle of excision of wounds is now practiced almost universally, the object of all antiseptic treatment is to render the wound ready for secondary suture in the shortest possible time. Now, the only secondary suture that can at all be commended is that which results in healing by first intention. It has been proved in this hospital over a series of nearly 2,000 cases that such secondary suture is practicable in almost every wound. The control of secondary suture by the smear count method has proved an unqualified success. Indeed, this method makes it possible to forecast with mathematical accuracy what the result of secondary suture will be. Accordingly, however little information the smear count method may give regarding virulence of organisms, it yet gives all the necessary information for the successful control of secondary suture, and any further information is simply of academical interest. Hence, from the practical point of view of the surgical treatment of wounds, it is all that is required in the way of a criterion of wound progress. This criterion was not satisfied in our hands by the flavine installation method, and so far as this was the case, the method was a failure. In a number of the 200 cases treated by flavine, experimental secondary sutures were carried out in order to determine whether a higher bacterial count was allowable before suture in the case of a wound thoroughly impregnated with flavine. We were not able to convince ourselves that this was the case. There certainly were a very few cases in which a somewhat higher numerical standard than that adopted in the case of hypochlorite treatment did not interfere with primary union, but these cases were the exception. Almost all of these experimental sutures were failures, and the higher the bacterial count above our standard for secondary suture, the more complete was the failure. We continue, therefore, to place complete reliance upon the smear count, properly carried out and interpreted, as a method of gauging the practical efficiency of any treatment of wounds. The following 2 cases are given as examples of the results obtained by the intermittent installation method of flavine treatment. The first is chosen as representative of compound fractures, the second as representative of large flesh wounds. They are quite typical of this series of cases, as all presented exactly the same features. Case 1. Private A.T. was wounded by high explosive on June 3, 1917, and admitted to the base hospital on June 6. He had a compound comminuted fracture of the neck and head of the femur, involving the hip joint. On admission, he was collapsed and sallow and toxic in appearance. The wound was foul and exuding synovial fluid. The foreign body had been removed at the casualty clearing station. Treatment at the base hospital. The wound was explored and thoroughly opened up. Carrel tubes were inserted deep down into the wound as far as the hip joint, and intermittent installation with flavine 1 in 1,000 solution and saline was carried out. The limb was put up in a Wallace-Maybury splint. On admission on June 6th, his smear count was 40 per field. On the 9th, under Flavine, it fell to 0. It was 0 on the 11th, 2 on the 15th, 8 on the 17th. And here there was a slight rise of temperature and free discharge from the wound. The count was 6 on the 19th, 6 on the 21st, and 8 on the 23rd. On June 23rd, as the free discharge continued and the bacterial count showed no signs of diminishing, hypochlorite solution was substituted for the Flavine. The count fell to 1 on the 25th, to 0.2 on the 27th, and to 0 on the 28th. Secondary suture was performed on June 28th. On July 3rd, he was up on crutches, the limb being fixed in a Thomas's knee splint. The wound healed absolutely by first intention. In this case, the end result was good, but after a trial of Flavine for 27 days, there seemed, from the amount of discharge and relatively high smear count, to be no immediate prospect of sterilization being attained. Consequently, the hypochlorite was substituted, and sterilization was then effected within 5 days. Case 2. Private C.H.S. was wounded in jaw, shoulder, forearm, etc. on May 31st, 1917. He sustained a very severe compound fracture of the lower jaw, with so much laceration that the tongue protruded through the wound in the neck. He had in addition a large flesh wound of the forearm, measuring 4 inches by 3 inches, and a large flesh wound of the shoulder and upper arm, with denudation of skin surface over an area 12 inches by 6 inches. He was admitted to the base hospital on June 9, 1917. The jaw was treated by the Carrel-Dakin method and was sutured on June 12th, while the smear count was still as high as 6 per field. It healed per primum. N.B. This high bacterial standard applies only to wounds of the jaw. The huge shoulder wound was treated by Flavine applied by means of Carrel's tubes. On admission on June 9th, the smear count was 40 per field. It was 30 on the 11th, 2 on the 12th, and 0 on the 15th. It then rose to 3 on the 17th, was 4 on the 19th, 5 on the 21st, and 12 on the 23rd. On the 23rd, hypochlorite was substituted for the Flavine. On June 25th, the smear count was 15. It fell to 8 on the 27th and to 0.2 on the 28th. It was sutured on June 28th and healed per primum, although the tension was very great. In this case, the Flavine was tried for 14 days, and as the discharge was then copious and contained numerous little gelatinous masses, as the bacterial count was steadily increasing, and as the wound showed no tendency to sterilization, the Carrel-Dakin method was substituted. Sterilization was then attained in 5 days more, and the secondary suture was completely successful. By using Flavine on gauze loosely applied to a surgically prepared wound, and changing the dressing twice in 24 hours, carefully sponging the wound surface with swabs wrung out of the antiseptic before each successive dressing, the following observations were made. A. Clinically. The wound progressed well up to the 5th or 6th day. The surface was particularly dry, very little wound discharge being seen. The granulations were of a firm, healthy rose-red color. The temperature rapidly fell, and the patient's general condition corresponded with the change seen in his wound. After the 5th to 6th day, the wound came to a standstill, and unless the antiseptic was changed, it rapidly became reinfected. The wound discharge increased in amount, and the result was what we now look upon as indolent, resembling in nature the old second intention wound discharging laudable pus. B. Bacteriologically. The results were very similar, but on the whole rather better than those obtained by the intermittent installation method. The bacterial smear count fell almost to 0 during the first 5 or 6 days, but unlike the similar stage in hypochlorite treatment, the spore-bearing organisms and bacilli of the perfringens type did not disappear altogether. The formation of a gelatinous membrane and masses on the wound surface was not quite so obvious, but was present in a lesser degree. After the 6th day, free discharge recommenced, and the bacterial count rose again. It remained in most cases at a level of 5 to 10 per field for a considerable time, until the Flavine was replaced by another antiseptic. The leukocytes in the discharge showed good healthy staining reactions and gave, in considerable degree, Bond's iodophil reaction test for healthy phagocytic function. But the one outstanding objection always remained that, except in the case of the smaller flesh wounds, a sufficient degree of sterilization could not be readily attained to permit of a good result from secondary suture. Application to septic wounds of the skin and septic skin conditions such as boils, abscesses, etc. When applied to septic cuts, boils, abscesses, and the like, flavine has given excellent results. The wounds both clean up and heal rapidly, leaving the minimum amount of scar tissue. In quite a number of these cases, which are purely cases of a staphylococcal infection, we have been able to suture these breaches in the skin in from 4 to 5 days, and they have healed by first intention, thus saving time and the formation of an excessive amount of scar tissue. Use of flavine in dirty gunshot wounds. A number of wounds have reached the base hospital in a dirty condition, but at a date too late for a complete excision to be undertaken. Into 15 such wounds we instilled flavine, to 10 we applied gauze soaked in the antiseptic and loosely packed into every recess of the wound surface. Bacteriological examination of all these wounds showed B. perfringens to be present, with streptococci and staphylococci, besides a number of other organisms. By both these methods, the results were equally unsatisfactory, in that sloughs were very slow to separate, sterilization was very incomplete at the end of 4 to 5 days, and at this juncture the wounds appeared to come to a standstill in a very highly infected condition. We have used flavine with success in 5 cases of severe compound fracture of the femur, and in 4 cases of gunshot wounds by the knee joint, where the bacterial count of the wound discharge, as shown by smears, did not exceed 1 to 2 organisms per field, and these cocci. In the case of the fractured femora, all of them the result of high explosive, the wounds had been excised at the casualty clearing stations, and the Carrel-Dakin treatment commenced. After arrival at the base hospital, where the bacteriological count was immediately carried out, flavine was substituted for the hypochlorites. In 2 cases, the count was 3 and 4 organisms per field respectively. After 2 days' treatment with flavine, the count had fallen to 2 organisms per 4 fields. This was 6 days after injury. The wounds were immediately sutured over flavine and healed per primum. Both these patients were up on crutches with some bony union, and their wounds soundly healed at the end of the 25th day from the date of their injury. Of the 3 other cases, one man had sustained a compound fracture of both of his femora, with compound fracture of the tibia and fibula on the right side, continuity in the femur still being preserved on one side, whereas the other 2 had suffered unilateral fractures. The former patient had 5 large wounds of excision. The latter 2 had a large wound each. The bacterial count of these wounds on arrival at the base hospital was in the case of the former 1 per field, 1 per 2 fields, and 2 per 3 fields respectively. All these wounds were immediately sutured and healed per primum, with one exception, namely the wound involving the tibia and fibula, which gaped but slightly. This last named fracture showed extreme comminution. In the 4 cases of knee joint injury, all showed a healthy leukocytosis in the joint exudation, one case showing a mild infection with Staphylococcus aureus. In each of these cases, a foreign body was present in the joint cavity and was removed. 5 cubic centimeters of a 1 in 1,000 solution of flavine were left in the joint cavity. The wound was sutured completely both as regards capsule and skin, some flavine being included in the skin wound. The results were highly satisfactory, all of these 4 cases recovering with sound, movable joints, walking quite well at the end of 5 weeks, and it was not necessary for them to leave the country. Some 50 cases of large flesh wounds have, after sterilization by the Carrel-Dakin method, been sutured over flavine. They have healed in all except 5 cases per primum, these 5 showing some separation of the wound surface, in parts only. The results from performing secondary suture in these cases over flavine have been no better than when the suture has been performed without the inclusion of any antiseptic in the wound. Flavine has been used in the form of pastes, this compound being rubbed into the resulting wound surface after early and complete excision of a wound. This injunction of the wound is followed by primary suture, and satisfactory results have been claimed by some surgeons. There is, however, no work yet published giving either the end results of these cases or the percentage of successes and failures. The fact that Flavine seems to lose its highly antiseptic properties in wounds within a short interval of time, usually 4 to 5 days, for this has, after every care and precaution, been our experience, is difficult to explain. Perhaps the tissues may develop a rapid immunity to the antiseptic. This is but a suggestion, for we have undertaken no work either to prove or disprove the idea. Again, in this climate where malaria and dysentery abound, Flavine may not produce the same results as it would do in more healthy surroundings. The salient fact, however, stands out that serious gunshot wounds after excision improve rapidly for 4 to 5 days on Flavine, but at the end of this period they become retrogressive, both bacteriologically and clinically. Again, we have not observed the rapid spreading in of the epithelium from the skin edges, which has been described by others in wounds undergoing treatment with this antiseptic. It is quite possible that Flavine may be highly bactericidal to certain organisms, but less harmful to others. We know that different organisms exist in the same wound symbiotically, and if this symbiosis can by any antiseptic be broken up, then the whole nature of the infection and its method of spread may be profoundly altered. The conclusions we have then arrived at from the use of Flavine tried in 200 consecutive cases of severe gunshot injury are as follows. A. Clinically. 1. Flavine in a dilution of 1 in 1,000 in normal saline rapidly diminishes the residual infection in a surgically excised wound up to the 4th or 5th day, but after this period its action as an antiseptic is retrogressive. In the instance of dirty wounds containing large sloughs, Flavine has proved to be of little use. 2. In an excised wound, the wound secretions for the first 4 days are minimal in amount. The granulations are of a firm character and a healthy rosy red color, quite different from the granulation in wounds treated with other antiseptics. At the same time, the rate of formation of these healthy granulations is extremely rapid. This again appears to slow down after the 4th or 5th day. 3. When used immediately consequent to the Carrel-Dakin treatment for the 24 hours prior to secondary suture, the wound has appeared drier and has healed well after suture, but no better than in similar cases where Flavine was not employed. 4. In primary closure of wounds after excision, Flavine has been used and left in the wound after suture. In a small percentage, the wounds have healed, but this percentage is far below that seen when secondary suture has been performed after complete sterilization of the wound by the Carrel-Dakin process. 5. In 5 cases of compound fracture of the femur, good results have followed the use of Flavine after a course of 4 to 5 days treatment by the Carrel-Dakin system. In 4 cases of penetrating knee joint injury, Flavine has been left in the joint cavity after extraction of the foreign body prior to closure of the capsule. Results in these few cases, though highly satisfactory, are no better than those obtained by methods previously in use and described in later chapters. 6. In all cases of serious gunshot wounds, the Carrel-Dakin treatment has proved so rapid and satisfactory from every point of view over now 2,000 consecutive series cases that we see no reason to deviate in any way from its use. And though Flavine has, in conjunction with the Carrel-Dakin system, given good results in 200 consecutive cases, yet this latter addition has not in any way influenced the results either in speed or quality, and at present we see no reason for adopting an expensive adjunct to what has already proved both a cheap and efficient course of treatment. B. Bacteriologically. 1. In wounds treated by Flavine instilled intermittently through Carrel's tubes, the smear count method showed a great diminution in the number of bacteria during the first 4 to 6 days. Polynuclear cells disappeared from the wound and apparently re-entered the circulation after performing phagocytosis. After the 6th day, the bacterial count gradually became increased, and polynuclear cells reappeared in considerable numbers in the discharge. The number of spore-bearing organisms in these latter smears was relatively increased. The phagocytes, judged by every standard, were healthy and active. The wounds, however, did not become sterilized, at least not within a reasonable period of from 3 to 4 weeks. 2. In wounds treated by the flavine gauze method, the results were similar but rather better. After a preliminary period of diminished bacterial counts, there came a stage of retrogression when the counts remained high. Sterilization was not obtained within a reasonable period, except in the case of the smallest flesh wounds. 3. In primary and secondary sutures over flavine in 1 in 1,000 solution, the solution being left in the wound, primary union has in a number of cases been obtained with bacterial counts averaging up to 2 per field. With higher bacterial counts, the method was a failure. This standard is somewhat higher than that adopted here for secondary suture after sterilization by the Carrel-Dakin process, but primary union in the flavine cases was not a mathematically certain result. The flavine solution appeared to have a slightly beneficial action when so employed in wounds at the time of suture. Brilliant green. We have tried this antiseptic in 50 consecutive cases of gunshot wounds, and would have given it a further trial had more of the antiseptic been available. Like flavine, it was tried both by the method of regular intermittent installation by means of Carrel's tubes and by application on gauze, the gauze being carefully packed into all the wound diverticula. We have also used it in a few cases of primary suture after excision of the wound. The results have been as follows. 25 excised wounds were submitted to intermittent installation. Of these, 15 were submitted to secondary suture at the end of the 5th day, when the count of organisms per field was 2 to 3. After suture was complete, 1 or 2 drams of the antiseptic were forced into the sutured wound between the stitches. In 8 of these cases, primary union occurred. Of the remaining 7, 4 developed malaria, and the wound showed a degree of infection which rapidly subsided on the exhibition of quinine. The wounds completely broke down and gaped in the remaining 3 cases, 2 of which had typical malarial attacks. Of the 8 cases that healed per primum, 1 was associated with compound fracture of the femur, 2 with compound fracture of the humerus, the remainder being large flesh wounds. The remaining 10 cases of these 25 showed a tendency to come to a standstill after the 5th day, and the antiseptic was changed, the hypochlorites being substituted. The latter antiseptic rapidly brought about sterilization, and the wounds were sutured. 25 excised wounds were treated by the application of the antiseptic on gauze. The wounds clinically remained remarkably clean, but in not one case did the bacterial count reach the low standard necessary for secondary suture. After the 5th day, the bacterial count rose, and there was more discharge from the wound surface. 8 of these wounds were submitted to secondary suture when the count was 7 to 8 per field, and although 5 of them held, yet there was considerable discharge both from the line of suture and the stitch holes, which lasted for 5 or 6 days after the operation, although brilliant green solution was instilled into these sutured wounds daily through a Carrel's tube which had been included in the wound for this purpose. The remaining 3 wounds entirely broke down after suture, but 2 of these patients developed malaria directly after the operation for suture had been carried out. The remaining 17 cases of this series were after the 5th day treated by the Carrel-Dakin method. Their wounds rapidly sterilized, and secondary suture was performed. It has struck us that out of this small series of 50 cases, the action of brilliant green is much the same as flavine, but there are important differences. The character of the wound granulations is different, for they are certainly firmer, redder, and more healthy looking in the wounds treated with brilliant green. Again, we have not noticed, in wounds undergoing treatment with brilliant green, the sticky coagulum which was almost universally present in the flavine cases. Lastly, the bacterial count falls more rapidly. That is, the rate of sterilization of a wound up to a point has been more rapid in the case of brilliant green than in the case of flavine. We have sutured 20 wounds with a high bacterial count, 10 per field and over, after thoroughly swabbing them with brilliant green. Carrel's tubes have been included to the depth of these sutured wounds, and brilliant green has been instilled into the wound twice daily, just as in the case of flavine. Results attending this method have been unsatisfactory, primary union only occurring in 2. In 10 of the remaining cases, the wounds held together in parts and eventually healed, but in the remaining 8 cases, the wounds entirely opened. In no case have we seen any harm following the use of flavine or brilliant green, either locally or generally. We have in a number of cases swabbed wounds which have been sterilized by the Carrel-Dakin method with brilliant green prior to secondary suture, and though these wounds have healed per primum, the result was no better than in many other cases in which this antiseptic was not employed. We are again at a loss to explain why it is that wounds undergoing sterilization with brilliant green suddenly come to a standstill at the end of the 5th or 6th day, just as they do in the case of flavine. We have had but little opportunity to submit wounds to primary suture after excision, as by the time this base hospital has been reached, it has been too late. We have, however, had opportunities of trying primary suture over brilliant green in 6 cases of gunshot injuries. These cases were all admitted within 4 hours of the receipt of the wounds. The results were very encouraging, as 5 of the 6 cases, 2 of them being complicated by compound comminuted fracture of the tibia, healed by primary union. These 2 men were up and walking at the end of 8 weeks. Here again, we have obtained equally good results in a number of cases submitted to primary suture where a Carrel's tube has been included in the wound, and installation of the hypochlorites has been carried out 6 hourly for 48 hours, when the tube has been omitted. An article of much interest is published in the British Medical Journal of October 6, 1917, by Captain Hay, RAMC, on the early closure of gunshot wounds. Captain Hay has devised and used a paste with the following formula: boric acid, 11 ounces, French chalk, 1 ounce, liquid paraffin, 8 fluid ounces, brilliant green, 17.5 grains. He says, the boric acid and French chalk must first be intimately mixed in a mortar, then the liquid paraffin worked in, and finally the brilliant green dissolved in rectified spirit. We have as yet had no opportunity of trying this paste, but from results obtained from primary suture over brilliant green solution of strength 1 in 1,000, we can quite conceive that good results would follow its use, as Captain Hay has proved. Bismuth, iodoform, and paraffin paste. Although we have not yet personally given this compound a trial in wound treatment, yet we have been able to observe some of the results of others. Certain surgeons, after bringing a wound to a degree of sterilization by other methods of treatment, have thoroughly rubbed the wound surface with small quantities of this compound, and obtained satisfactory union after suture. This method has been applied to cases of compound fracture, and satisfactory results reported. The compound has also been employed in cases submitted to primary suture after wound excision. All surgeons are not agreed upon the efficacy of the use of this antiseptic in wounds. Amongst a series of 10 cases which we were invited to see, 2 were suffering from bismuth poisoning and 2 from iodoform poisoning. There appear to be certain drawbacks to the use of this compound. 1. Idiosyncrasy to bismuth and iodoform. 2. It may delay healing, so causing the wound to gape after the sutures have been removed. 3. It may cause trouble at a later date by leaving a residue in the tissues which is opaque to the X-rays. The antiseptics that have been universally employed at all units on this front are the hypochlorites. The antiseptic has been instilled into the wound hourly or 2 hourly by the method of Carrel and Dakin. Treatment has been commenced at the casualty clearing station, and in some cases at the field ambulance. It has been continued on the hospital train and completed at the base hospitals. Whenever an action has taken place, it has been found possible during the rush to give the greater percentage of the wounded the benefit of this treatment. Those patients who have not received it have in the main sustained only minor wounds. At the base hospitals, all patients have been kept until their wounds were soundly healed and they were able to get about. They were then, if necessary, sent to an orthopedic depot until they could either rejoin their units or be given some duty on the lines of communications, or, if necessary, be invalided to England. But in the latter case, they had to be sound enough of limb to get about and jump into a boat if necessary. During the last few months, we have witnessed the end results of nearly 2,000 cases of serious gunshot wounds, treated from start to finish by the method of Carrel and Dakin. Subsequent chapters will show results and statistics of a system of continuity in treatment between firing line and base hospital from the date of the wound to its complete healing. We do not in any way wish to insist on the use of any one particular antiseptic, but we do most strongly advocate a continuity in treatment. Thus, if at the advanced dressing station one antiseptic be employed, at the field ambulance another, at the casualty clearing station, after the wound has been excised, another, and a new method of applying it, and finally, if at the base hospital a still different treatment with yet another antiseptic be used, such a heterogeneous state of affairs is bound to militate strongly against the best and quickest results. We have found that the Carrel-Dakin system, when its continuity is not broken, is not only rapid and efficient, but is easily carried out and cheap to the state. The cost of material per patient over our own series of 2,000 cases, from the time of infliction of the wound up to the time of healing and the patient getting about, works out at 7 shillings, pre-war catalogue prices, as already stated in Chapter 1. It is a rare event to get a setback in a wound, or for a wound to come to a standstill. The patients arrive in a comfortable state at the base hospital, are put to bed, and there is no need to touch their wounds until the following day, as the installation of the antiseptic is carried on through the night, often without waking them. In the great majority of cases where the wound has been adequately dealt with at the clearing station, there is no further need for immediate operation, but the process of wound sterilization is carried on until the bacteriologist reports it fit for secondary suture. The whole process has worked out so smoothly and simply on this front, where the question of transport has been a difficult one, and the results have been so highly satisfactory, that we feel we cannot too strongly urge the Carrel-Dakin treatment for wounded men who have of necessity to be evacuated from unit to unit, unless a definitely superior treatment can be found to take its place. We do not in any way underestimate the difficulties of the treatment during transport, for we have had considerable experience in this connection, both on the Western and Eastern fronts. End of Chapter 12.
Chapter 13 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 13, General Treatment of Gunshot Wounds. Such an extensive subject as the general treatment of gunshot wounds must needs fall under several headings. The following main headings would seem to the authors to embrace everything. A. The general care and personal hygiene of the soldier. B. The treatment of the wounded man on the battlefield. C. The treatment of the wounded man at the advanced dressing station. D. The treatment of the wounded man at the field ambulance. E. The treatment of the wounded man at the casualty clearing station. F. The treatment of the wounded man at the base hospital. G. The treatment of the wounded man at the institutions set apart for special classes of wounds. The general care and personal hygiene of the soldier. This is a large and highly important subject. It might be said that the case of an unwounded man should not be classed or discussed in a chapter dealing with the general treatment of gunshot wounds. Our answer to such an argument is that every soldier should be looked upon as a potentially wounded man. For although he be lucky enough to escape the sniper's bullet or a piece of shell for a considerable period, yet if he be in the line long enough, his turn by the ordinary rules of chance will most surely come. Never more apt than now to the men in the trenches has been the biblical warning, "Let him that thinketh he standeth take heed lest he fall." The general care of the soldier is the duty of the commanding officer, the medical officer, and company officers, but more especially that of the medical officer. It is for him to advise his commanding officer on matters which influence the soldier's general health and also on the equally important prophylactic measures that should be taken against wound infection. This simply amounts to following out a treatment for the prevention of the predisposing causes of wound infection already mentioned. First and foremost is fatigue. What can be done to combat this condition? There are many minor important points which aid in the production of fatigue. Sores on the feet, flat feet, metatarsalgia, sores rubbed by the equipment, and the like, all call into play additional muscular effort for their protection, and consequently a degree of superadded fatigue on that already existing. Scabies and body vermin, by their irritant action on the skin, interfere with sleep and so aid fatigue. This points to the importance of a thorough inspection both of the men and their clothing while out at rest, and for this reason both company and junior officers should be instructed and acquainted with what to look for at such an inspection. Foot inspection. As soon as a battalion arrives in rest billets, whatever the hour, a foot inspection should be held. Flat feet, corns, and callosities, undue length of toenails or ingrowing toenails, and sores from the rubbing of the boot are the main points to look for. Any man so affected should be instructed to parade sick on the following day. It should be remembered that the feet of men who have been wearing gumboots in the trenches soon get swollen and sodden, and it is often difficult at the end of a week's duty in the trenches to get the service boot on. A march of 4 to 5 miles is then often quite sufficient to make a man very footsore, especially if he has any foot deformity. Treatment of the feet. There are but few conditions of the feet that cannot be treated by the regimental medical officer. Foot affections, as seen in the line, come under 2 headings. 1. Those affecting the skin with its appendages, the commonest being friction sores, corns, callosities, ingrowing toenails, overgrowth of the toenails, hyperhidrosis, and bromidrosis. 2. Those affecting the deeper structures, and these include flat foot, metatarsalgia, clawfoot, hallux valgus, hammer toe, and sprains about the ankle joint. After the feet have been thoroughly washed with soap and water, the regimental medical officer can decide the course of treatment for those cases coming under the first heading. Blisters on the feet are best treated by puncture with a clean aseptic needle, evacuating the contents, and then painting over with iodine. Friction sores heal rapidly and do well with a few applications of the tincture of iodine. Though these sores heal very rapidly, they are apt to recur unless precautions are taken to remove the cause. The 2 chief causes are worn-out socks and deficiencies in the boot. New socks can always be obtained in lieu of those which are unfit for wear, and it is always a good plan to soap new socks before wearing them, and to include in the soap a small percentage of boracic powder. Cases of foot affections coming under Class 2 can, as a rule, be treated by some alteration to the boot. Thus, flat foot, which is always exaggerated by trench life and the wearing of gumboots, can be compensated by raising the inner side of the sole and heel of the boot and extending the latter further forwards on the inner side towards the sole. The condition of flat foot improves markedly with physical drill and exercises. It is noteworthy that men with flat feet do not complain of the condition while they are wearing gumboots in the trenches, yet as soon as they resume the service boot, they suffer much pain, and to march any distance is a difficulty. Metatarsalgia and clawfoot can be treated by a leather bar placed across the sole of the foot just posterior to the ball of the toes. The weight of the body when walking is by this means taken off the ball of the toes and the pain thereby relieved. Both these simple alterations to the boot can be easily carried out by the battalion cobbler. Hallux valgus and hammer toe, if the medical officer can satisfy himself that they are sufficiently severe to be causing disability, are best treated by surgical means, and the soldier must, under these circumstances, leave the line. Hyperhidrosis and bromidrosis are usually associated with flat foot, and show a great tendency to improve when measures are taken for the relief of this deformity. In the line, sponging the feet with weak solution of formalin did more good than anything else. Bunions are generally associated with hallux valgus and should be dealt with at the same time, and their cure results after the hallux valgus condition has been surgically corrected. One more point before leaving the subject of the feet, and that is the fitting of the soldier with new boots. It is a golden rule always to fit a soldier with a new pair of boots directly after he comes in from a route march, for then the necessary swelling of the feet is allowed for. New boots should be thoroughly well oiled or dubbed, and if possible, it is a good plan to wholly immerse them in crude oil for 2 or 3 days before issuing them to the soldier. Each man before going into trenches should be supplied with 2 pairs of socks, i.e. an additional pair to the one he is wearing, so that he has a change when the pair he is wearing becomes impregnated with sweat, so giving the latter pair a chance to dry. We feel that we have given but little space to the important subject of the care of the feet, but what has been said briefly embodies everything that has been met with during a considerable spell of time spent with the battalion in the trenches. Ablution. There is but little opportunity for ablution while doing duty in the front line, but there are usually better conveniences in the reserve line. It is, however, when the unit comes out for rest that the ideal conveniences are met with. Each division has its own baths, these being placed centrally and convenient to all units of the brigade that is out at rest. Hot and cold water with plenty of soap are provided, and during the week's rest each man gets 2 baths. In addition, ablution troughs are provided in the rest camps so that every man can have a thorough wash 2 or 3 times daily. Before going to the baths, the battalion should be inspected by the regimental medical officer with a view to detecting scabies. Most men with this disease will parade sick, but there are some who appear to be ignorant of having the disease, and it is for the medical officer to discover them. All such cases are sent to special camps set apart for their treatment and are returned to their units at the completion of their cure. During a prolonged period out of the trenches, a battalion should be inspected twice weekly for scabies, and any doubtful cases should be treated regimentally for 4 or 5 days with sulfur ointment. A common skin disease detected at these inspections is impetigo. The commonest form is Bockert's impetigo and responds well to treatment with the unguentum Hejejari ammoniati. It is probably the result of dirty underclothing chafing against the skin. A number of cases sent out of the line and diagnosed impetigo are cases of scabies on top of which a staphylococcal infection is added. All such cases should be carefully examined for scabies at the field ambulances. Another disease to be especially looked for at the medical officer's inspection is pediculosis pubis. This is not an uncommon condition in the trenches. A thorough washing of the pubes, followed by the application of blue ointment, is usually sufficient to cure the complaint. Shaving of the pubes has rarely been necessary. It is most important to impress on the soldier the necessity of keeping himself clean about the pubes, perineum, and anus, for a neglected condition of cleanliness in these parts is an ever-present danger should it be here that he happens to be wounded. If he be made to realize the importance of this simple truth, he will attend to what is undoubtedly a neglected point in personal hygiene while on active service. It is highly important that every man during the rest period should have his hair cut as short as possible all over his head. By the time the second visit to the divisional baths is due, this should have taken place. There is one barber per battalion, but there are as a rule plenty of other men capable of cutting the hair, and their services should be enlisted. Long hair is always a danger to any man who is hit in the head. While men are out at rest, recreations and entertainments are very important adjuncts, and it is here that the church and YMCA have rendered most valuable service. Rooms have been provided in which there has been an abundant supply of books, periodicals, writing material, and the like. Football matches have been instituted, the divisional band has played in the afternoons, and everything possible has been done to divert the men's attention for the short rest period from their arduous duties in the trenches. Body sores. During the rest period, all body sores, such as boils and the like, should be attended to. It is not usually necessary to send a man to hospital with these minor ailments unless they've advanced to a condition of cellulitis. On the Western Front, a small incision with evacuation of the pus, followed by an inunction of the sore with the ordinary unguentum hydrargyri 10%, has invariably been sufficient to bring about a rapid cure. On the Eastern Front, the condition is much more indolent, and many men reach the hospitals at the base with multiple body sores. Local treatment with ichthyol and glycerin 10%, followed by the application of scarlet red ointment with quinine 20 grains daily, is the most rapid method of curing the condition, but never forget to give the quinine. In the Eastern theater, small festering sores on the fingers are very prone to go on to inflammation of an extensive kind, involving the interphalangeal joints and tendon sheaths, and prompt surgical action is needed for its arrest. Free incisions followed by the Karel-Dokken treatment have given the best results, but one should always remember to give these patients a daily dose of 15 or 20 grains of quinine. On the Eastern Front, carbuncles are common, and in addition other body sores of a kind not seen in the Western theater. The exact nature of these latter is uncertain, and they are remarkably indolent and resistant to treatment. Some resemble the true Baghdad sore, while others are of a kind akin to syphilis. Tertiary syphilis should always be borne in mind, and a short course of treatment with potassium iodide, while it's doing no harm, will often do good towards effecting a temporary cure and so rendering the soldier fit to carry on. Quinine alone cures a large percentage of these sores, and it is highly probable that they are malarial in origin. See chapter by Lieutenant Colonel Smith, CMG. The teeth. During the period of rest, the medical officer's inspection should always include an examination of the teeth. Unfortunately, the condition of the teeth of the average fighting man is bad. We have seen mouths in which there was a collection of bad stumps quite inadequate for mastication, and a condition of pyorrhea alveolaris far advanced. This must necessarily interfere seriously with digestion, and often these men parade sick with symptoms of gastritis. In some cases, where men have lost or broken their dentures, they have no teeth at all for masticating their food. This state of affairs interferes with the general nutrition, and these men lose weight. When the medical officer can satisfy himself that the symptoms of gastritis are genuine, and in those cases where the loss or breakage of the dentures has not been intentional, he should send these men to the dental surgeon, who visits the field ambulances on special days to have their mouths properly attended to and new dentures fitted. On the other hand, there are many men in the line who, despite advanced disease of their teeth, never suffer from indigestion and do not parade sick for this cause. They eat well and are physically perfectly fit. It should, however, be remembered that a dirty state of the mouth, whether a man is physically fit or not, is a strong predisposing cause to virulent infection in a wound that he may receive in this region, and every man, therefore, should have impressed on him the importance of the use of a toothbrush, or if he cannot get this, of rinsing out his mouth after each meal with water. Constipation. It has been stated before that men in trenches are notoriously constipated. This is in part habit, but it is also in part inhibitory. In one part of the line where one of the authors was on duty, the latrine was in a position where rifle bullets struck all round it. On more than one occasion one went with a full desire and intention of using the latrine, but the constant ping and smack of the bullets in close proximity produced a complete inhibitory effect on which ended in a fruitless journey. This no doubt was the case with some of the men. A number of them have been actually hit while using the latrine, and benefiting by their experience, some of their comrades preferred to wait until they came out of the trenches. After coming back to rest, every man of the unit was on the next morning given 1 or 2 number 9 pills. Indeed, many would parade sick and ask for them. They were taken round by the medical officer's corporal, who saw that the men took them. The day before going back to trenches, a cathartic was again given to each man, and this was repeated when the men were in the reserve line. Besides predisposing to trench ailments, constipation militates strongly against the chances of a soldier who is hit in the abdomen. The common trench ailments and their treatment. The commoner diseases met with in trench life are 1. Myalgia, 2. Trench pyrexias, 3. Trench diarrhea, 4. Trench nephritis, 5. Cardiac disorders, 6. Trench feet. 1. Myalgia. Under this term are included a mixed lot of cases which in civil life would be diagnosed muscular rheumatism, lumbago, etc. During dry weather, the complaint is rare except in the more elderly men. It is most prevalent in the wet, damp months. A cause for the complaint is difficult to assign, but probably many factors are at work, the chief being fatigue, wet and exposure, bad teeth, and in older individuals, arteriosclerosis. A man who is tired out falls to sleep full length on a damp fire step for 2 hours while his comrade is on sentry go. When his 2 hours' rest has expired and he is roused to take his turn, he finds he has pain, stiffness, and aching of his muscles. This wears off with exercise. The second attack is more persistent than the first, and each succeeding attack is more persistent than the one before, until finally the condition becomes permanently established. It is probable that a great number of these cases are in their early stages due to the inability of a tired muscle to empty itself of catabolic toxic products. After a short rest, the muscle, somewhat recovering, can by its tonus get rid of a part but not all of these waste products of metabolism. There is thus a gradual accumulation of these products taking place in the muscles until the time is reached when short rests are insufficient to produce any appreciable recovery. If, added to this supercharging of the muscles with toxic catabolic products, the soldier has septic foci elsewhere from which absorption is taking place, e.g. a septic condition of the teeth and constipation, or if he be suffering from arterial disease, the condition is exaggerated. If this state of affairs be allowed to continue over a prolonged period, a chronic inflammation, the so-called fibrositis, is set up in the affected muscles and tissues, which is very difficult and tedious of cure. Treatment. It should be remembered that myalgia is only a symptom, and treatment must be directed towards removal of the cause. In the early stages, all that is required is a short rest of 48 or 72 hours. Sodium salicylate or aspirin in 10-grain doses may be given 3 times a day and do good, and combined with this, magnesium sulfate, 1 dram every morning. An initial aperient of 1 or 2 cathartic pills should be administered, as no doubt constipation has a part in the production of myalgia. If taken early, a man need not leave his unit for the treatment of this complaint, for this can be carried out at the transport lines. When the disease has become established and it becomes aggravated by changes in the weather, the soldier becomes temporarily unfit for service in the line and he requires hospital treatment. Active massage of the affected muscle and fasciae, followed by exercises, combined with the following prescription thrice daily, should be tried for 10 days or a fortnight. Magnesium sulfate, 40 grains, aspirin, 10 grains, potassium iodide, 5 grains, aquamarine, 1 ounce. If there be no improvement at the end of a fortnight, a mustard plaster or some other sort of blister often does good, and after the skin has recovered, massage can again be practiced. During his stay in hospital, the patient should be seen by the dental surgeon and any necessary treatment for the teeth should be carried out. If, owing to the situation, the soldier cannot leave the line, a belladonna plaster will often give great relief and enable him temporarily to carry on. 2. Trench pyrexias. There are 3 distinct types of pyrexia met with in trench life. 1. Trench fever. 2. Pyrexia associated with diarrhea. 3. Pyrexia with symptoms of what is commonly called influenza. 1. Trench fever. It is now widely believed that the infective agent of this disease is conveyed by the body louse, but when once established, it can be transmitted from man to man by the blood, as first pointed out by McNee. The disease is remittent, recurring at intervals of from 4 to 10 days. It is characterized by its sudden onset, by pains at the back of the eyes and in the shin bones, and with a fever running as high as 103 degrees Fahrenheit. The tongue, at first, is usually clean, and the appetite suffers but little. It was most prevalent in a certain sector of the line during the winter of 1915 to 16. Men leaving the line at this period were treated at the rest camps or the field ambulance. At the end of 10 days, they were returned to the line, only to relapse and again need evacuation. For further information on this subject, the reader is referred to the excellent work of McNee. Treatment. If we are to remove the disease, it would mean the eradication of body lice, a problem yet unsolved. Much can be done, however, to minimize the number of these vermin. At the divisional baths, the trousers and tunic, as already stated, are put through a thresh, but it is doubtful if the thresh, with the number of clothes it has to deal with in a given time, successfully kills the eggs. The female louse deposits her eggs in the seams of the trousers and the shirt. Before putting the clothes into the thresh, the seams of the trousers, especially in the region of the perineum, should be brushed out with all the eggs and fluff from the clothes. After treatment in the thresh, and before putting the trousers on again, the seams should be thoroughly rubbed with vermicelli or Oxford grease, and the shirt dusted with Oxford powder. Blankets should be frequently stoved, as these pests abound in them. After being stoved, they should be lightly dusted with Oxford powder. Unfortunately, dugouts are badly infested with these vermin, and their disinfection is again a problem that has yet to be solved. When once the disease is established, hospital treatment is required, although during a certain period when the strength of the unit with which one of us was serving was low, it was necessary to treat these cases in the line. A good aperient in the form of No. 9 pill is given, following by 10-grain doses of aspirin or sodium salicylate combined with quinine sulfate, 5 grains, 3 times a day. The pain in the shins, which is the most persistent symptom and which is probably due to a low form of periostitis, is best treated by massage or, failing this, by counter-irritation. It is a question if any medical remedy will prevent the onset of the disease. Perhaps it may be a coincidence, but it is worthy of mention that during the latter part of 1915, when the number of men contracting the complaint was increasing in a certain battalion, prophylactic doses of 5 grains of quinine per man 3 times a week were distributed throughout the unit and were administered under the supervision of the company officers. The number of cases of trench fever immediately fell and steadily diminished up to the day on which the unit left these particular trenches at the end of the year. 2. Pyrexia associated with diarrhea. This complaint was not at all uncommon during the winter of 1915 to 16. The onset is preceded by a short period of malaise, and the symptoms are characterized by diarrhea, headache, a dirty tongue, and a clammy condition of the skin, with fever as high as 103 degrees Fahrenheit. The cause of this disease is doubtful, but it has been suggested, and possibly not without grounds, that the trench rat may be responsible. It was most prevalent in a part of the line that was literally infested with rats. These animals were large, coarse creatures and appeared to be quite fearless of human beings. They would run over the men's blankets, and on one occasion a signaller awoke to find one asleep on his neck. This will give the reader some idea of how near these animals, which might easily be carrying infection, could and would get to the soldier when asleep. They are harmless to the normal individual, but have been known to attack a wounded man while helpless. Treatment. 1 ounce of castor oil with 1 ounce of brandy is the quickest cure for this condition. The temperature falls rapidly, and after a night's rest is normal. The man feels slack for a day or 2, but rapidly picks up. For 2 or 3 days after the fall of temperature, he is given the iron and arsenic pill 3 times a day. 3. Pyrexia with symptoms of influenza. The cause of this disease is not known, but the symptoms are headache and malaise, with a temperature ranging from 101 degrees to 102 degrees Fahrenheit. The onset is sudden, and there is strong disinclination for food. The tongue is slightly coated and the eyes are watery. Treatment: an aperient No. 9 pill followed by 10 grains of aspirin or sodium salicylate 3 times a day rapidly brings down the temperature, and in 48 hours the soldier is fit for duty. For the last 2 conditions, it was hardly ever necessary for the soldier to leave the line. In fact, at this particular time in our unit, the men could not have been spared. They were ultimately none the worse for remaining in the trenches, and it proved a far quicker remedy than sending them to hospital. From the highly important view of the economy of the unit, it was undoubtedly correct to treat these cases in the line at the time under consideration. 3. Trench diarrhea. Diarrhea is of frequent occurrence in trenches, and the cause may perhaps be that the soldier has filled his water bottle with water from an unreliable source, or that the water in his water bottle has in some way become contaminated. Flies, which abound in large numbers, may be contaminating the food, cause the conditions, or the soldier may have been eating unsound tinned salmon or fruit. Treatment: castor oil with chlorodyne, 20 minims, is usually all that is required. 4. Trench nephritis. It is difficult to ascribe a cause for this complaint. By some it has been described as an infective condition, while others contend that it is only a lighting up of a previously unrecognized chronic nephritis. After a thorough investigation of trench conditions, it was impossible to see how it could be ascribed to life in the trenches. Fortunately, the disease is rare, and if such a disease as trench albuminuria exists as an entity, it would seem that the cause has yet to be found. The general treatment is that of acute nephritis. 5. Cardiac disorders. Excluding cases of valvular disease of the heart, there still remains a condition associated with tachycardia with or without irregularity of the pulse. Much literature has sprung up on this subject during the present war, and articles on the soldier's heart have been numerous. There is no place for a discussion on the subject, but it is not beyond our province to suggest that the myocardium, like other muscle, is affected by fatigue, and fatigue of the myocardium was not of uncommon occurrence in the trenches. The condition is sufficient to render a man temporarily unfit for duty in the line, and necessitates his being sent to hospital. 6. Trench feet. The subject of trench feet will be discussed in a separate chapter. Trench sanitation. The sanitation of the trenches is a highly important subject from the point of view of the soldier's welfare and existence, for however unenviable and disturbing life in the trenches may be, yet there are probably worse existences if the trenches are properly looked after from a sanitary point of view. When we speak of sanitation of the trenches, the area of ground in their immediate vicinity must also be included. Trench drainage. Drainage of the trenches has always been a difficult problem. If the liquid which, through the constant rains, accumulates in the trenches consisted only of rainwater, then drainage would be a simple matter. This liquid, however, is a thick, adhesive type of mud, which will neither flow nor allow of the use of an ordinary trench pump. The constant traffic in the trenches never gives the mud a chance to settle. Consequently, the water never becomes supernatant. Sump holes have been sunk in the side of the trench bottom, and the water which collects in these can be pumped out. More often, these sump holes are full of mud, which constantly needs ladling out by hand. The advent of trench grids or duck boards was the first step towards the successful drainage of the trenches. These grids are fastened to wooden piers driven into the trench bottom. They keep the trench traffic above the mud, and by this means the mud separates into its two constituents, earth and water, the former sinking to the bottom, the latter becoming supernatant. The water collects in the sump holes and can be pumped out. Drainage systems that were instituted became so disorganized by enemy shell fire that they were quite inadequate to deal with the situation. Disposal of refuse. Up to a certain period, all trench refuse, such as the unconsumed part of a daily ration, empty jam tins, and the like, was thrown over the parapet or the parados, or trodden underfoot in the trench bottom. This refuse in the summertime was an attraction for flies, which at this period abounded in great numbers. Flies are always a source of danger, and everything possible should be done to abolish them. Later, empty sandbags were hung along the trench side, into which all refuse, such as meat bones, bacon rind, pieces of bread, empty jam tins, pieces of paper, etc., was deposited. These sandbags were taken down to a dump each evening, where transport was provided for their removal to the divisional incinerators. Here this refuse was burned under the supervision of the divisional sanitary officer. Empty jam tins or other tins that contained food were, after incineration, put to useful purposes in the making of paths, etc., in different rest camps. The larger tins, when filled with Flanders clay, made excellent bricks for the construction of battalion incinerators in the rest camps. Trench latrines. The two types of trench latrine most frequently used were the bucket system and the deep pit system, and of the two, the latter was both simpler and more effective. The latrines are situate in small diverticula of the trench, but one big shell can obliterate the small communication between trench and latrine and so bring about a very undesirable result. When the bucket system is adopted, each man, after using the latrine, covers his excreta with earth. Dry earth in some parts of the line was an impossibility. Consequently, feces were often left uncovered in the buckets and formed a dangerous attraction for flies. The excreta were disposed of by burial, usually in a shell hole, a little distance behind the parados. As this ground was being constantly churned up by shell fire, it can be imagined what the resulting condition of the ground would be. These latrines were cleaned out daily, and it was important for the medical officer to see that plenty of chloride of lime and cresol was used, both in the latrine itself and in the shell hole into which the excreta were emptied. The deep trench system consists of a deep trench over which are fitted a series of wooden boxes, each with a round hole through which the man defecates. Fitting over the hole is a lid, provided with a spring, and this lid automatically closes the hole after the latrine is finished with. Periodically, chloride of lime is thrown into the trench with some earth to cover the excreta to a depth of 2 inches. By this means, the action of flies is eliminated, and there is far less risk of dissemination of the excreta by gunfire. Further, the excreta are never exposed, and there is no smell. The boxes on which the men sit are apt to get soiled and should be washed over with a weak solution of cresol each day. A urinal is made out of a biscuit tin with perforations in the bottom. This tin should be placed over a hole which is in direct communication with the deep trench. In perforating these biscuit tins for use as urinals, it should always be remembered to perforate them from within outward, so that there are no rough edges or dents within the tin around which urine can stagnate. These tins should each day be washed with a weak watery solution of cresol. Ablution in trenches. Trench ablution is a difficult problem. In one part of the line, ablution conveniences had with care and diligence been erected. No sooner was the work completed than a high explosive shell scattered the whole structure. It was generally necessary to wait until the period in the support line came, for here there were better conveniences. Disposal of the dead. This very important question has always found a satisfactory solution at the hands of the British for men killed in the line. After an action when there may be many dead in no man's land, any bodies near the parapet have, at the risk of the living, been recovered and taken back to a recognized plot of ground for burial. Bodies lying farther out and unrecoverable have been left. Certain saps have after an action contained dead bodies, the removal of which would entail considerable risk to the party undertaking it. Some of these, for necessary military reasons, have had to be left, though such saps have of necessity to be manned. Whenever possible, the bodies have been recovered and sent farther back for burial. In some cases, it has been absolutely necessary to fill in a sap for sanitary reasons, and whenever the exigencies allowed, this was always done. Men killed in the line during quiet times were always taken back at night to the cemetery and buried 5 feet below the surface. After the Battle of there were many bodies, including those of other nationalities than our own, lying about the ground behind the parados and in disused trenches. These trenches were filled in, and a number of the other bodies were recovered and buried in the same trench. Men of other nationalities than our own have, of necessity or otherwise, buried their dead in the parados or wherever they fell. This was a disastrous procedure, as the enemy fire was continually unearthing them, and it was not at all an infrequent occurrence to find limbs or a head or some other part of a corpse projecting into the trench. Such a condition militates strongly against good sanitation. The farther the dead are removed from the line and the deeper they are buried, the better. Another form of burial in the case of bodies which are in an advanced state of decomposition is to cover them with chloride of lime, and on top of this to heap a thin layer of earth. It must never be forgotten that scattered, decomposing human remains are a grave danger to a wounded man, and whenever possible such remains should be removed or covered up. Unburied bodies further strongly attract flies, rats, etc., another urgent and important reason for their proper disposal. The feeding of the soldier. There is no doubt that the feeding of the British soldier during the present war has been a miracle of organization. When one comes to look back and to realize that in the very worst parts of the line in Flanders, the appetizing smell of fried bacon was present every morning while one was doing an early round of the trenches, that a fresh meat issue each day never failed, despite the enemy's then superior artillery, that tea, bread, butter, and jam were always to hand, in addition to comforts from home sent by the mail, which also never failed, it really should make all very thankful to and appreciative of those responsible for such organization. During spells of time in trenches, it is most essential that every man should receive the greatest benefit from his ration, even to the last calorie. The human body, after all, is but a complex machine, and the fuel must be both good and sufficient if that machine is to do efficient work. It was with a view to combating fatigue and the trench ailments that follow in its wake that the following scheme, which worked smoothly and satisfactorily over a period of nearly 12 months in trenches, was adopted by a certain unit. The fresh meat issue was kept at the transport lines, where the meat was cut off the bones, cut up into small pieces, and passed through a mincing machine. The service biscuit was soaked in brine for 24 hours and was then passed through the same mincing machine. The minced meat and biscuits were then mixed together and again passed through the mincing machine. The mixture was then made up into rissoles, which were cooked on the battalion traveling cookers. If the fresh meat was short, which was rarely the case, the deficiency was made good by bully beef. These rissoles were sent up to the trenches cold in dixies, and were heated up by the men in their mess tins on spiritine stoves, which gave rise to no telltale smoke. This food was easy of digestion, very appetizing as regards both smell and taste, and it was well suited to men whose teeth were defective. The bones from the fresh meat issue were all saved in the transport lines, as was also the suet. The bones were stewed on the battalion cookers, and to their extract was added oxo cubes and a small quantity of vegetables. After skimming off the fat, this soup was put into dixies, where it set to a jelly. This was sent up to the trenches each evening without fail, so that every man about 9 p.m. had nearly a pint of hot, nourishing soup. The suet saved at the transport lines was made up with flour and raisins, bought from the profits of the dry canteen, into plum duff, which was sent up to the trenches and thoroughly appreciated by the men. Soup, rissoles, and the plum duff were all served at headquarters mess, and we can testify that the whole diet was both appetizing and excellent. In addition to this diet, the men regularly received their comforts from home, and any extras they liked to buy from a dry canteen which was present in the reserve line. They also, without fail, received their tot of rum at stand to in the morning. By such a scheme, it will be seen that practically every calorie of the ration was put to good use. It was thoroughly appreciated by both officers and men, and it quite repaid the extra bit of trouble in that the sick parade of this particular battalion was always, having regard to the existing conditions, remarkably small. The general health of the battalion, though short in numbers, kept at a high standard, and such a condition must stand a man in good stead when his time comes to be wounded. Further, there was no waste. When leaving the trenches to go to rest billets, a hot stew was always waiting for the men at whatever hour of the day or night they might arrive. The contents of this chapter, though not actually bearing on the treatment of the wounded man, are nevertheless most important in that such attentions as those referred to, small as they may seem, keep the man in a far better position to resist the infection which his tissues must inevitably fight if he chance to be wounded. Let it be repeated that 1 ounce of prevention is better than many pounds of cure, and after all, it is the body defenses that the surgeon has principally to rely on in gunshot wounds. His skill can do nothing beyond assisting the body defenses, and if those be unduly weakened, both surgeon and patient are severely handicapped. A surgeon may satisfactorily excise a wound, immobilize a fracture, or stitch up a perforated viscus, but if the all-important vital force is not present to back him up, his best directed efforts must fail. It should ever be remembered by the regimental medical officer that it is up to him to see to all these important points that matter, and remember that all these details, which help to keep a man as fit as possible while he is serving in the line, give him his best and quickest chance of recovery when he is wounded. End of Chapter 13. Chapter 14, Part 1 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 14, General Treatment of Gunshot Wounds. Part 1. Treatment of Wounded Men on the Battlefield. The main points to consider in connection with the treatment of the wounded man on the battlefield are 1. Relief of pain, 2. Arrest of hemorrhage, 3. Temporary immobilization of fractures, 4. Dressing of the wound, 5. Correct filling in of the tally, 6. A short note in special cases. 7. Removal to the advanced dressing station. 1. Relief of pain. Most gunshot wounds are painless for some little time after their infliction. This is due in part to the stunning effect produced on the tissues by the missile and in part to the degree of shock occasioned. This painless period varies from half an hour to 2 hours in duration when edema of the damaged tissues sets in. With the onset of edema, pressure is exerted on the unyielding deep fascia, which gives rise to severe pain. The actual blow of the missile is so rapid that the immediate effect on the individual is universally described as resembling a blow from a heavy stick. The only remedy for the pain is morphia given hypodermically. Tablets of the drug put under the tongue are very slow in taking effect and far less potent. 2 very important precautions must be taken with regard to administering this drug, and these are 1. Never fail to record on the tally the dose given and the date and time of its administration. 2. Always before giving the drug, make sure that the wounded man, especially if he be an officer, has not already taken a dose. Morphia is obtainable in book form along with other drugs, and such books are in the possession of many officers, and not only will they help themselves, but will, with the best of intentions, give a dose to a wounded man, and this without the knowledge of the medical officer. 2. Arrest of hemorrhage. It is on the battlefield that a wounded man can least afford to lose his blood. Loss of blood not only increases the original shock occasioned by the wound, but it also aids infection by seriously crippling the wounded man's resistance. Every ounce of blood is valuable at this stage, so the first care of the medical officer and stretcher bearers should be the arrest of hemorrhage. The importance of instructing both stretcher bearers and combatants alike in the simple methods of stopping hemorrhage cannot be exaggerated, for such knowledge has often meant the saving of many lives. Fortunately, large wounds do not show a tendency to hemorrhage immediately after their infliction, probably owing to the crushing of the divided vessels by the missile and the fall of blood pressure occasioned by shock. A reactionary period will most surely follow if the wounded man survive. Consequently, every precaution should be taken against the occurrence of a hemorrhage during transit to the casualty clearing station. There is a small percentage of wounds which do bleed directly after their infliction, and it is all important in dealing with these to act promptly and arrest any hemorrhage. It is almost incredible how much a severe primary hemorrhage can put back the convalescence of a wounded man and how difficult of sterilization his wounds become. A severe compound fracture of bone in a case where a severe primary hemorrhage has occurred is exceptionally prone to develop a fulminating osteomyelitis, costing the man his limb, if not his life. If the hemorrhage be from a limb, stretcher bearers and combatants alike should be instructed to tie immediately a piece of the man's putti around the limb and above the wound. This done, an entrenching tool handle is passed beneath the putti and twisted round until the bleeding stops. Points of pressure are not to be relied upon if left to stretcher bearers. Besides, when these bearers have to carry the wounded man in, they cannot at the same time be exerting digital pressure on an artery. Another point against the use of digital pressure is that while the stretcher bearer may be feeling for the correct spot, much blood may be lost. The wounded man cannot afford the loss, neither is it giving him his best chance towards a speedy recovery. The putti and entrenching tool handle have never failed to arrest hemorrhage, and any man, combatant or stretcher bearer, can rapidly apply this simple apparatus. Morphia, 1/4 of a grain, is given hypodermically and the wounded man carried down to the advanced dressing station. Should the hemorrhage be taking place from a wound in the neck, thorax, or abdomen, then tight plugging of the wound with a cyanide gauze must be resorted to. Hemorrhage from the scalp can be controlled by a gauze pad covering the wound, over which pressure is exerted by means of a bandage. In cases of badly shattered limbs, where vessels, nerves, and bone have been irretrievably damaged, it is safer, quicker, and absolutely correct treatment to amputate at once, and to go through clean tissues if possible. The operation is quite painless if done soon after infliction of the wound. The main vessels are tied so that there is no further fear of immediate hemorrhage. Shock of transport is abolished, which is great if a limb which is useless is allowed to drag and shake for 12 miles over rough roads. A very potent focus of infection is early removed, and but little shock is occasioned by the operation if done at once. One of us has performed this operation on several occasions while in the trenches, and in not one case was there a death. The men all reached England and were heard of later, doing well. 3. Temporary immobilization of fractures. In connection with fractures of the extremities, there is one important point to bear in mind, and that is never attempt to reduce a compound fracture, however severe, on the battlefield. For by such an effort, no good can accrue, but much harm may be done. Any fracture, whatever its nature, even if the ends of the bone be protruding through the soldier's clothes, should be as perfectly immobilized as is possible in the position in which it exists. Good immobilization will stand the man in good stead against shock and pain in transport, will do much to guard against hemorrhage before he reaches the casualty clearing station, will prevent the fractured ends of the bone from undue movement with a consequent further damage to the soft structures, and will delay the further dissemination of sepsis. These are all points of paramount importance to the future of a wounded limb. Splints can be readily improvised, and these will be referred to in the articles dealing with the fracture of individual bones. 4. Dressing of the wound. Every soldier is provided with a first field dressing and an additional ampule of iodine. As soon as he is wounded, he or a comrade applies the dressing. The ampule of iodine is emptied into and around the wound, and the dressing is fixed on over this. The first field dressing is inadequate for wounds of large size. Consequently, the shell dressing has been issued. The shell dressing, which is a magnified first field dressing, is carried by the stretcher bearers and is not issued to the soldier. There is one important point to be remembered in the application of these dressings, and one that should be thoroughly driven home into the head of every officer and man, and that is, In every case, apply the dressing loosely. A dressing that one would apply to a clean operation wound would be fatal if applied to a recent gunshot wound. Swelling of the wounded limb, which is always delayed, must be allowed for. It was not at all infrequent for wounded men to arrive at a casualty clearing station with the bandage having literally eaten its way into the swollen soft parts. Not only does this cause unnecessary pain, but the bandage acts as a powerful tourniquet restricting the circulation, and gangrene of the limb may result. This has happened on more than one occasion, and even if gangrene does not result, the vitality of the limb below the constriction is greatly impaired and infection thereby favored. Yet one more important point. After the skin around the wound has been painted with iodine, a perchloride of mercury dressing must not be applied, for the combination of the two antiseptics will badly blister the skin, causing the patient additional pain and making the surgeon's task more difficult. 5. Correct filling in of the tally. This is an all-important point for the guidance of the medical officers from the line down to the casualty clearing stations. A correct diagnosis of gross lesions, such as a compound fracture of the femur, a penetrating or perforating wound of the knee joint, a penetrating wound of the abdomen, and the like, are of the utmost assistance, in that such cases are not detained at the field ambulances or the Corps collecting stations, but are immediately sent on to the casualty clearing stations or other units where special conveniences exist for the treatment of particular wounds, such as penetrating abdominal injuries, penetrating wounds of the chest, etc. Above all, it should be noted on the tally whether or not the wounded man has had morphia, and if so, how much he has been given, and the time and date at which it was given, and whether it was given under the tongue or hypodermically, thus, date, time, morphia, a fourth of a grain, hypodermically or per os. 6. A short note in special cases. Such cases are the following. 1. Severe primary hemorrhage. 2. Gunshot wounds of the spine. 3. Gunshot wounds of the head. 4. Gunshot wounds of the abdomen. 5. The case of an airman hit while flying. 1. Severe primary hemorrhage. It is of the highest importance to know if a man has suffered hemorrhage directly after being hit and the degree of the hemorrhage that has occurred. It has been mentioned before that a severe primary hemorrhage strongly favors infection, and if the facts are known, much can be done for such wounded men prior to and during any necessary surgical procedure which will favor their chances of a more rapid recovery. 2. Gunshot wounds of the spine. Most important information can be here given by the medical officer who sees the man directly after he is hit. The medical officer should never fail to state whether or not an interval of time, however short, existed during which the wounded man could voluntarily move his limbs, or if he had any sensation in the part of his body below the lesion. Such information is invaluable to the surgeon at the casualty clearing station or the base hospital, for by the time these later units are reached, paraplegia or paranesthesia may be complete. 3. Gunshot wounds of the head. In these cases, it is very important to know whether an interval of consciousness did or did not exist between the time of infliction of the wound and the onset of unconsciousness. For instance, a man hit in the head walked 300 yards to a regimental aid post. On reaching the aid post, he lapsed into unconsciousness with stertorous breathing. Although it was broad daylight, this man was, with a short note of the condition, dispatched to a special motor ambulance which took him to the casualty clearing station. The regiment was never informed of his death, so it is to be concluded that a timely operation at the casualty clearing station saved his life. If the wounded man is unconscious directly after receiving his wound, this should be noted, for although most of these cases die in the line, yet a percentage do reach the casualty clearing stations. 4. Gunshot wounds of the abdomen. In connection with these wounds, the regimental officer can again furnish valuable information. In many cases of penetrating abdominal wounds seen in the line, with the exception of those complicated by severe intra-abdominal hemorrhage, there was little shock so long as the patient was kept quiet. There was, however, always present on palpation a definite tender area, evidently denoting the site of the damaged viscus. This localized tender area after transport was invariably lost, the tenderness and rigidity becoming diffuse in general. The three main points in abdominal wounds to be noted by the regimental officer are A. Date and hour of the wound. B. The interval of time that has elapsed between receiving the wound and the last meal taken by the soldier. C. Marking in indelible pencil on the abdominal wall the earliest area of maximum tenderness. On arrival at the casualty clearing station, the soldier, as a rule, can only give the surgeon indefinite information as to points A and B. 5. The case of an airman hit while flying. It is important to know in this connection A. The height at which the wound was sustained. B. The extent of the hemorrhage. C. The exact date and time at which the man was wounded. D. The pulse rate and general condition immediately on landing. It is important to know the height at which the aviator was hit because the higher he is flying, the longer it takes for the necessary equilibrium to become established after he has been forced to land. Wounded airmen have of necessity to land quickly from a rarefied atmosphere into normal atmospheric pressure, and this produces a curious effect in the wounded tissues, resembling surgical emphysema. It is always important to know the extent of the hemorrhage, which, in the case of airmen hit whilst flying, is always excessive. The date and time at which the airman was hit should be noted, because it is both unwise and unsafe to attempt any operation until the circulation has again accommodated itself to the atmospheric pressure at ground level. The pulse rate and general condition immediately on landing are important points to note, for a man may have lost much blood, and yet this quantity may not be represented by what is seen in the machine or on his clothes. Besides, there is an idiosyncrasy to rarefied atmosphere, and it is important to know this before performing any operation. 7. Removal to the advanced dressing station. In most cases of injury to the upper extremity, face, scalp, and the soft structures of the lower extremities, provided that they be not extensive, the wounded man with assistance can walk to the advanced dressing station. It is often remarkable what some men can do in this respect who are suffering from compound fractures of the bones of the extremities. On more than one occasion, we have met a man with an arm hanging on by only a few tendons walking down a communication trench to the regimental aid post. Men hit while in action who have sustained such severe injuries as a compound comminuted fracture of the femur have by some unknown means crawled into shell holes or disused trenches for cover. We can recall 2 cases of men who, having sustained compound fractures of the tibia, had actually walked, with the aid of a comrade, nearly 300 yards to an advanced dressing station. On another occasion, a soldier with a large loop of small intestine protruding from a wound in the abdomen walked 250 yards to a regimental aid post. Soon after the infliction of a wound, a man can in a large degree help himself, and when an action is in progress, it is advisable not only to permit this, but to encourage it. It must never be forgotten that the wounded are an encumbrance, and their rapid evacuation from the battlefield is a matter of grave necessity. It is a golden rule to get rid first of all of cases that can walk and help themselves. That is to say, men who in a short time will probably be fit again for duty, and to leave the heavy cases who require carrying until the last. The journey from the battlefield to the advanced dressing station is of necessity rough and hazardous. It may be along a trench. It may, on the other hand, have to be undertaken in the open. Whichever route has to be taken, this part of the journey, and the work connected with it, should be as rapidly carried out as is possible, and serious cases such as head wounds, abdominal wounds, chest wounds, compound fractures of the femur, and the like should be so labeled, and every convenience for their rapid transit to the casualty clearing station arranged for. The jointed pole trench stretcher. In transport, apart from the cases which cannot be immediately reached, the chief delay occurs in the front-line trenches owing to the difficulty of passing round traverses with any kind of rigid stretcher. A short poled stretcher held horizontally cannot pass round a right-angled corner in a trench less than 28 inches wide, and as the average size of this type of trench is 24 inches, the patient, who is carried sitting up, is tilted in all directions and if unconscious may fall out. The strain on the bearers is very great and their hands get knocked up. Most of the weight comes on the front bearer. Owing to their hands being occupied, they cannot save either themselves or the patient if they slip. There is therefore a risk of producing 3 casualties instead of 1. The webbing suspension band rucks up on the neck, producing constriction of the vessels and tiredness of the muscles. These facts were well known by August 1915, and many devices had been tried to obviate them without success. This led to experiments being undertaken to try to overcome the difficulties. An article on this subject was published by Major G.H. Colt in The Lancet of January 22, 1916, in the hope that it would aid those at the front to design an efficient apparatus. But in this respect, there has been a signal lack of success, chiefly because the subject is such a difficult one. The problem of moving a badly wounded man along a narrow frontline trench, and we do not refer to large winding communication trenches, is one of inches, both as regards the size of the trench and that of the apparatus. The illustration shows the only practical solution of the problem. It should be particularly noted that the apparatus is shown turning a right-angled corner, the shoulders of the bearers being at right angles to one another. When the pole is straightened out, there is just room for the patient's legs. He is carried in the Fowler position, the best for all injuries down to the level of the knee. Below that, the leg may be splinted, or a rifle splint may be applied from the hip after bringing the leg into line with the thigh. Figure 76, Major Colt's jointed pole trench stretcher turning a right-angled corner. For mere demonstration, the apparatus is rigged up as per photograph and the patient gets into it. In actual use, proceed as follows. Carry patient to nearest convenient place if necessary. Bearers wear shoulder straps adjusted in crossed position as per photograph. Unhasp and lay canvas on ground with head end in the direction of transit. Lay patient on it, placing knee piece under the knees. Bearers lock the lever and hold the pole in position over the patient and stoop down. Third man hasps up canvas portion to ropes. Both bearers lift and third man hasps up eyelets on body girdles to shoulder suspension and straps patient in. Party moves off. Back bearer unlocks lever and guides round corners, holding restraint against collapse of pole. Release in reverse order. Rest is obtained by swinging patient sideways onto ledge of dugout by assistance or by crutched poles. In this apparatus, the weight is evenly distributed between the two bearers and is borne by direct shoulder suspension. There is no constriction round the neck. The hands of the bearers are free to aid the patient or to save themselves if the ground is uneven. The use of the apparatus has to be learnt, and this takes an average of 4 minutes. So far, it has not been possible to raise the patient further off the ground without greatly increasing the strain on the bearers or making the apparatus too complicated, nor can a very tall man be carried unless his head is placed to one side of the pole. No doubt it will be improved with further experience. The total weight is 22 pounds. Inasmuch as it is the only apparatus so far designed that can be guaranteed to move a patient without discomfort from tilting and with ease to the bearers along new trenches of average size and construction, there will be a large sphere of usefulness for it. Work of the Regimental Medical Officer. The work of the Regimental Medical Officer is perhaps the most difficult and arduous of all. He has much to think about. He has the daily sick parade, sometimes carried out in the trenches, sometimes at his regimental aid post, the latter usually situated in no safe place. During an action, he has to work several hours on end under heavy fire, which calls for great resource and endurance. But he has ever to remember that he is doing much toward saving the lives of wounded men. This impressed itself most strongly on one of us after leaving the line to take up surgical duties at a casualty clearing station. There is not the slightest doubt that what is done for the soldier immediately after he is wounded, and the manner in which it is done, has far more influence than any subsequent treatment on the final result. The work that was done by regimental medical officers and the officers in charge of the advanced dressing stations during the Somme offensive in 1916 was, from what could be judged at the casualty clearing stations, little short of marvelous, and it was disappointing that they could not be present at these latter units to see the results of their well-directed efforts. Treatment of the wounded man at the advanced dressing station. The amount of attention that can be devoted to a wounded man at the advanced dressing station depends entirely upon whether an action is in progress or not. Facilities for treating wounded men under these two different circumstances must be discussed separately. 1. When an action is not in progress. Under these conditions, the advanced dressing station has to deal only with the daily wounded and sick from the line. The treatment consists in getting men warm, giving them, if permissible, hot drinks and food, readjusting any faulty splinting of fractured limbs, and thus thoroughly immobilizing them for motor transport and especially readjusting dressings. It must be seen to that the dressing is slackly put on before the wounded man leaves. Often by the time the motor ambulance arrives, the first field dressing has, through swelling of the part, become too tight, and it is of paramount importance to readjust it before the wounded man leaves the advanced dressing station. Hemorrhage, a not uncommon occurrence, must be arrested at this unit if necessary under an anesthetic. It is a cardinal rule never to send a wounded man in a motor ambulance with a tourniquet applied unless it is absolutely necessary. Tourniquets that have been left on for any length of time, 1 to 2 hours, have in the present war done untold harm, as cases so treated have presented gangrenous limbs on arrival at the clearing station. It is always a justifiable and correct practice to ligature any large bleeding vessel during quiet times at the advanced dressing station rather than trust to a tourniquet. Cases of hopelessly shattered limbs in which vessels, nerves, bone, and other structures have been irretrievably damaged, it is far wiser to amputate, if possible, at the advanced dressing station and to ligature the main vessels. Such cases have invariably done well, shock is decreased, and the risks of hemorrhage, further shock, and infection are minimized during transit to the next unit. Any treatment of the wounded man at the advanced dressing station should be carefully noted on the tally for the information of those at the next unit to which he is transferred. Before leaving, it should be ascertained that every man's rifle is unloaded and that he has left all his ammunition behind. 2. When an action is in progress. During an attack or an advance, the advanced dressing station has to cope with much work. Of great importance is the rapid evacuation of the wounded, either to the field ambulance or the corps collecting stations. Consequently, the more lightly wounded, i.e. the men able to walk, should be rapidly inspected first of all. If the dressing be not tight and if there be no hemorrhage, these men should be sent on in batches to the next medical unit. Walking cases with larger wounds should have fresh dressings applied loosely. Any tourniquet applied on the battlefield should be removed, and any large bleeding points clamped and ligatured. Fractures of the upper extremity should be immobilized and the arm put up in a sling. No attempt should be made at this stage to reduce a fracture. Perfect immobilization, the application of a suitable loosely bandaged on dressing, and the arrest of any serious hemorrhage are the important points to attend to. These men can now proceed to the next medical unit. The more serious wounds, such as head, abdominal, and chest injuries, and compound fractures of the bones of the lower extremity, next need attention. Little can be done at this stage for head, abdominal, and chest injuries. They are stretcher cases and will have to be carried or taken by wheel stretcher to the motor ambulance. This part of the journey should be undertaken slowly if circumstances permit and with as little shaking as possible. Moribund cases should be kept until the last, as it is obviously unwise to send a moribund case before one which would stand a better chance of recovery. It may be necessary to administer more morphia before the next part of the journey is undertaken, the date, hour, and dose being written on the tally. Compound fractures of the bones of the lower extremity should be thoroughly immobilized. This is a point of vital importance. Reduction of the fracture should not be attempted, but if the limb be not thoroughly immobilized prior to transport, shock is increased, hemorrhage may readily occur, and more damage may be done to the soft parts owing to the fractured ends of the bones having too free play in them, and as a result infection is both further disseminated and favored. Hot drinks may be given to all serious cases other than abdominal injuries before this part of the journey is undertaken. When the lower limbs are hopelessly shattered, immediate amputation through the site of the injury with ligature of the vessels is by far the best and safest treatment, and there is no contraindication to carrying this out at the advanced dressing station, for such cases have done well and undoubtedly lives have been saved. Treatment at the field ambulance. It has been a debated question as to whether operations should be carried out at the field ambulance. A field ambulance is a mobile unit, and an answer to the question will depend upon whether the Army is advancing or not. During stationary warfare, many cases have been operated upon at the field ambulances and have done well. For at these units, they certainly receive earlier surgical treatment than can be the case at the casualty clearing stations. It is on the whole better not to operate upon cases at the field ambulances if they can reasonably and without risk wait until the casualty clearing station is reached. This reduces itself to operating only upon cases of extreme urgency at the field ambulance. These cases will include the following. 1. Ligature of large arteries for uncontrollable hemorrhage. This procedure is most necessary and is far preferable to sending a man on a motor journey to the casualty clearing station with a tourniquet applied. The latter practice has much to condemn and nothing to recommend it. 2. Amputation in the case of hopelessly shattered limbs. At the casualty clearing station during the Somme offensive, we saw several amputations that had been performed at the field ambulance. The stumps were beautifully clean, the patients extremely comfortable, and shock in these cases was a negligible quantity. Whereas in the case of badly mangled limbs which reached the casualty clearing station, shock was so pronounced and severe that a very hurried amputation had to be performed, and consequently these patients neither had so good a stump nor so good a chance of recovery as those who had received treatment at the field ambulances. 3. Abdominal wounds. If these cases have to be operated upon, then the sooner the better. It must never be forgotten that cases of abdominal injury stand a motor journey very badly, and on this account special hospitals for their treatment were provided nearer to the line than the ordinary casualty clearing stations during and before the Somme offensive of 1916. Abdominal wounds have been operated upon at certain field ambulances, and the results have quite justified the undertaking. Urgent cases in which intra-abdominal hemorrhage has occurred and which have survived to reach a field ambulance should, if there be any hope of success, be operated upon immediately. 4. Tracheotomy. This operation should be performed early for serious wounds about the neck or jaw in which the larynx is involved. All bandages should be inspected prior to evacuation to a casualty clearing station in order to see that they are not too tight and are not causing constriction of the limb. Anti-tetanic serum, 500 units, should be administered to every wounded man and a record of this made on the field card with notes of any operation that may have been performed. Fractures should be inspected and, if necessary, appliances readjusted in order to maintain absolute immobilization during motor transport to the casualty clearing station. This should, if possible, be done without the aid of an anesthetic, as these wounded men have usually to undergo another operation at the clearing station, and 2 anesthetics in rapid succession at this stage are badly borne. Medical comforts in the form of beef tea, stimulants, etc. can be given to suitable cases before undertaking the journey to the next unit. Dressing of wounds at the field ambulances. Wherever time permits, severe wounds should have the skin around them shaved, thoroughly cleansed, and a dressing of gauze soaked in hypochlorite solution applied. If the wound be deep and open and situated on the upper aspect of the trunk, it is a good plan to fill it with Usol or Dakin solution before applying the gauze, and after the gauze is applied, to cover the dressing with jaconet, which has been sterilized, prior to putting on the wool and bandage. If the wound be penetrating, it is good practice to inject the hypochlorite solution into it with a sterilized glass syringe prior to applying the dressing. A short note on the dressing and treatment of the wounds should be entered on the field ambulance medical card. The treatment of the wounded at the casualty clearing station. It is at the casualty clearing station that the first conveniences exist for a thorough surgical treatment of wounds. These units are situate anywhere from 6 to 10 miles behind the line, yet the route taken by the ambulances has, owing to necessary military reasons, to be circuitous, and such a journey by road may mean anything from 8 to 15 miles. Convoys of wounded arrive at the casualty clearing stations from the field ambulances, the corps collecting stations, and in some cases direct from the advanced dressing stations. Each man's kit and empty rifle should accompany him, but in an action this cannot always be the case, and some kits are bound to get lost, having been either left on the battlefield or at the advanced dressing station. Nobody, except those who have witnessed it, can picture the rush and hurry at these latter places in getting the wounded away. Hence the loss of some kits is inevitable. Dealing with convoys of wounded at a casualty clearing station. The following method of dealing with large convoys of wounded at a casualty clearing station in France may be of interest, as it worked efficiently and well over a prolonged period. In front of the casualty clearing station there was a semicircular drive. The cars entered, discharged their burden, and then proceeded to a stretcher and blanket dump situated on one side of the drive. After taking stretchers and blankets in lieu of those left with the wounded, they left the hospital by the exit at the other end of the drive. The wounded man's special private belongings, such as he carried in his pockets and kit, were placed in a special bag which was tied to the handle of his stretcher. Officers' kits were placed in a special pack store. The men's kits, other than their special belongings, were dumped. Stretcher cases were taken first from the cars into the reception tent. Walking cases were directed to a special hut set aside for the inspection of their wounds. Every stretcher case had his clothes removed in the reception tent by orderlies and his wounds inspected by a medical officer who decided whether his was a case needing immediate operation or not. If needing immediate operation, he had a white piece of bandage tied to the stretcher handle and he was sent to one of the operating marquees. Men wounded in the abdomen or chest were sent direct to marquees set apart for them and which were situate close by the operating theater. These men were put straight to bed and were made warm with hot water bottles for an hour or two before any necessary surgical measures were undertaken. Severe cases, such as compound fracture of the femur, cases of severe hemorrhage and the like, were sent to beds where every effort was made to lessen shock prior to operation. Cases of hopeless mutilation of the limbs requiring immediate amputation were taken direct to the operating theater. Cranial and special injuries were kept in special marquees, as also were all cases of shell shock. Wounded Germans had special marquees set apart for them, but any serious case requiring a bed was given one amongst our own wounded. A special marquee was set aside for cases arriving in a moribund condition. A considerable number of the walking cases required surgical treatment, and these were usually attended to in a special operating theater. If their wounds were of a serious nature, they were transferred to the main operating theater. There was a special stretcher party working night and day between the marquees set apart for cases needing immediate operation and the theater. After operation, the surgeon decided whether the case should be detained or whether it should be taken direct to the evacuation area. The evacuation area consisted of a number of marquees near the railway siding. All walking and all stretcher cases not requiring immediate operation were, after the dressing of their wounds, sent direct to the evacuation tents. Here they received hot drinks and other necessary medical comforts prior to entraining for the base. Abdominal, chest, and head injuries were detained until they were fit to stand the journey. All clothes taken off the wounded men in the reception tent were dumped and were later sent on to the base, where presumably they were handed in to ordnance. Kits that had been dumped were similarly disposed of. Officers' kits accompanied them to the base. The work of the casualty clearing station therefore consists in 1. Segregating the wounded, 2. Carrying out necessary surgical treatment, 3. Evacuating the wounded men who are fit to travel to the base. These 3 operations may convey only a surgical significance to many, but behind them, and perhaps more important, is the enormous problem of the organization and administration of the units which carry them out. They are units of the most expansile character, and it is only by the punctual performance by the commanding officer and his administrative staff of their highly responsible and arduous duties that the large number of wounded who sometimes pass through a casualty clearing station in a day can be adequately dealt with. It is difficult to credit the amount of work that is entailed in the receiving and evacuating of large numbers of wounded officers and men, or the small worries which follow, such as the loss of small articles which in a large number of cases did not accompany the wounded man to the casualty clearing station. The segregation of the wounded has already been referred to. Carrying out any necessary surgical treatments. Strictly speaking, all cases requiring surgical treatment should be operated upon at the casualty clearing station. In quiet times, when there is not an undue rush of casualties, this can always be accomplished, but when an action is in progress, many cases have of necessity to be evacuated to the base, although surgical treatment would have been better started at the casualty clearing station. This, of course, cannot be avoided, but it must ever be remembered that surgical treatment, though incomplete and sometimes crude through pressure of work, may save many limbs and lives if performed at the casualty clearing station, because of the time often taken by the hospital train to reach the base, and that in a few hours virulent infection may have progressed to such an extent that by the time the base is reached a limb may have to be sacrificed, if not a life. All serious wounds should therefore be surgically treated at the casualty clearing stations, and only wounds of lesser severity in which there is no undue risk of any spread of infection during transit should be sent to the base direct. Thus, abdominal injuries, head injuries, compound fractures of the bones of the extremities, and large wounds of the soft parts should be dealt with at the casualty clearing stations. Penetrating wounds of limbs in which there is much swelling, denoting hemorrhage or gas gangrene, should be similarly dealt with, as also should large wounds of the face involving fracture of the jaws. Seton wounds in which there is but little swelling, smaller flesh wounds not involving important structures, lesser cases of compound fracture of bone in which there is little or no displacement and where the wound is small, and indeed this class of case forms a very considerable percentage of a large batch of wounded, should, after a change of dressing, be evacuated direct to the base hospitals. This then brings us to the best, quickest, and most efficient method of treating serious wounds at the casualty clearing stations. It is almost impossible to enter into such a discussion at this without first looking back and reflecting on the treatment of wounds from the earliest days of the war up to the present time. A description of wounds as they reached England in 1914 will serve no useful purpose here. We were at that time a retreating army, and under the conditions there is no doubt that the very best was done for the wounded. During the battles of the Aisne and the Marne, tetanus was not an uncommon complication of wounds, and at this time the real value of administering antitotonic serum in all cases of gunshot wounds had not been realized. To further complicate matters, the nature of modern gunshot wounds had not been grasped, though at this early period, under the then existing circumstances, no blame could be attached to anybody concerned. At the First Battle of Ypres, the wounds were gruesome. At this period, no definite plan of treatment had been laid down, for indeed the nature of these wounds was still misunderstood. Treatment was directed towards wound drainage combined with the application of the older antiseptics, such as carbolic, corrosive sublimate, hydrogen peroxide, and the like, and results were bad. The nature of the wounds received at the Second Battle of Ypres and the Battle of Neuve Chapelle was typical, in fact just as typical and no worse than those received in the earlier engagements, but unfortunately the results of treatments showed little, if any, improvement on previous work, despite the fact that all medical and surgical requirements were supplied in plenty to the casualty clearing stations and field ambulances. At this stage, surgeons were working in the dark. In brief, they were still ignorant of the nature of the modern gunshot wound. At the Battle for Aubers Ridge, which was followed shortly upon the Second Battle of Ypres, and in the subsequent engagements in May 1915, certain field ambulances were administering anesthetics to as many cases of wounded as was possible, draining the wounds with rubber tubes, removing foreign bodies, and thoroughly washing out the wounds with hydrogen peroxide. A suitable dressing was then applied, and the cases were dispatched to the casualty clearing stations. During these engagements, one of us was attached to one of the ambulances for surgical duties. Every wound was grossly infected, even satin wounds caused by undeviated rifle bullets. It must be borne in mind that the wounds received at first by the assaulting infantry are chiefly the result of machine gun and rifle fire. The aim is directed low. Consequently, the majority of early wounds are confined to the lower extremities and the abdomen. It is during the counterattack, or where reinforcements have to pass through a heavy artillery barrage, that shell wounds mostly happen. We were taught that small in-and-out wounds caused by rifle or machine gun bullets usually healed without any trouble because they were sterile. Never in this war was the teaching more false, for after the engagements of May 1915, machine gun wounds were just as grossly infected as any other. The soft parts around and distant to the wound were acutely swollen. On opening a small satin wound with forceps, a foul-smelling, dark chocolate-colored fluid escaped with gas. In fact, it may be truly said that these infected satin wounds were infinitely more dangerous than the large open wounds, which not only permitted the foul wound discharge to escape, but also, to a great extent, inhibited the growth of anaerobes. All satin wounds, together with penetrating wounds caused by both bullets and shell, were drained with rubber tubes. The results were bad. In some of the cases, the soft parts had further swollen and completely obliterated the lumen of the tube. If the lumen was not obliterated, the holes cut in the sides of the tube were. Consequently, there was no drainage, and the tubes only played the part of foreign bodies lodged in highly infected tissues. In the light of our present knowledge, such drainage tubes could, under the best of conditions, drain only a very limited extent of the wound, but in the conditions mentioned they did not even do this. They completely blocked all communication between the damaged parts and the exterior, a result which greatly favored the growth of the anaerobes and their further destructive action on the tissues. It was shortly after this that the quality and quantity of damage to tissue by the modern missile became known, and also the degree of infection to be dealt with, though this was not universally recognized nor agreed upon by all. Certain surgeons saw that the road to success lay in complete excision of these wounds and prolonging incisions into what appeared externally to be sound though swollen tissue until the full extent of all damaged and swollen tissue at some distance from the wound had been exploited. This procedure marked an important step forwards in the right direction, judging by results alone. It now remained to discover a suitable dressing for these surgically prepared wounds, and many were tried. Irrigations, both intermittent and continuous, with different antiseptics, continuous immersion in baths, and various dressings were all given a chance, but it seemed that at this point another serious halt had occurred. It was at this juncture that Sir Almroth Wright introduced the salt treatment and Colonel Grey the salt pack. Results obtained by this latter treatment applied to a surgically prepared wound outdid anything previously seen, and it seemed the long-expected cure for wounds had come at last. Salt, however, did not sterilize these wounds, and a number of cases undergoing this treatment were conspicuous by the foul smell that emanated from the salt pack, despite the fact that both the temperature and the pulse were falling satisfactorily and the wounded man was picking up. The dressing of many of these surgically prepared wounds was extremely painful, and if multiple, a general anesthetic was required, which not only put the wounded man back, but diminished his morale. It remained for Carrel and Dakin to introduce an ideal antiseptic and an ideal method for its application to a surgically prepared wound. Sterilization by the method recommended by Carrel and Dakin marks the second phase in the successful treatment of wounds. The two cardinal points to be followed out in the treatment of all wounds are as follows. 1. Prevent further infection. 2. Eradicate any existing infection. A third cardinal point in the case of compound fractures is to prevent, by thorough immobilization, the further dissemination of infection. The skin for a considerable distance around the wound should be thoroughly scrubbed with spirit soap and shaved. For wounds anywhere near the perineum, wounds of the upper thigh, and wounds of the buttock, the pubes, scrotum, perineum, and anal region, in addition to the skin around the wound, should be shaved, and the skin of all these parts thoroughly cleansed. For any wound of the head, whether scalp or skull, the whole head and neck should be shaved. Wounds of the upper arm call for shaving and untold cleanliness of the axilla. For wounds about the hands and feet, especially where compound fracture of the tarsus and metatarsus exists, most scrupulous care must be devoted to cleansing. Nails should be cut as short as possible, and while the wound is protected, the foot or hand should be scrubbed with spirit soap and soda until it is clean. Turpentine and petrol may be used if necessary to remove any ingrained dirt. Special attention to cleanliness between the toes is extremely important. While all this preliminary toilette of the skin is taking place, the wound should be carefully protected with swabs wrung out of a suitable antiseptic. When once the skin has been satisfactorily cleaned and shaved, it should be further well rubbed over with methylated ether. Iodine is then painted on the skin for some distance around the wound prior to the next surgical step. The authors feel that they cannot lay too great stress on the importance of cleaning and sterilizing the skin and its appendages. If the leg be involved, it is wise to shave the whole leg, the thigh, pubes, perineum, and anus. We have never regretted adopting this procedure, for the anus, perineum, and pubes of the average wounded man are usually extremely dirty. Nits are present in many cases and feces in nearly all, and whatever part of the body be wounded, such a focus through contamination of the bed clothing is a source of danger. Besides, removal of this hair makes the nursing more simple, and in every way it is more cleanly and satisfactorily, especially in the East. End of Chapter 14, Part 1. Chapter 14, Part 2 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 14, General Treatment of Gunshot Wounds 2, Part 2. Excision of the wound. After surrounding the wound with sterilized towels, excision should next be undertaken. There are two methods of performing wound excision, and which of the two is chosen will depend entirely upon the class of wound and the amount of damage done. A. Complete excision of the wound en masse. B. Excision of the wound piecemeal. Method A can be often applied to the following class of case. 1. Penetrating shell wounds with extensive damage to the deeper soft structures but not involving bone. After primary excision of the wound in the skin and fascia and prolonging incisions in either direction to expose the damaged deeper structures, an attempt is made to remove the whole of the injured and infected tissue en masse together with the piece of clothing and missile. This leaves a large, fresh wound surface which, though almost always inevitably infected, is far easier to sterilize than the original wound. 2. Extensive lacerated wounds of soft structures. In these wounds, most of the damage is visible and not latent, as in Class 1. Complete excision of the whole wound en masse is here often possible and is a simpler procedure than the complete excision of a penetrating wound. 3. Wounds of the scalp with or without fracture of the skull. Complete excision of a scalp wound en masse, unless an abnormal amount of scalp is involved, in which there is still vitality remaining, should be practiced in every case. Should a compound fracture of the skull complicate the scalp wound, this should not deter the surgeon from performing excision en masse. All structures, including the pericranium, should be removed to the extent of 1/4 of an inch from the wound margin. In these cases, before proceeding to excision, it is good practice to swab the wound with pure carbolic or even to apply the actual cautery to the wound surface. This procedure prevents any weeping from the edges during excision, an occurrence which is a frequent source of reinfection and consequent failure. 4. Penetrating abdominal wounds. Prior to laparotomy, the penetrating wound should be excised. This may be performed in one of 2 ways, depending upon the relative positions of the laparotomy incision and the original wound. A. Should the laparotomy incision be planned at a distance from the penetrating wound, then the wound must first be excised, and the surgeon, after changing his gloves, will with newly sterilized instruments proceed to perform laparotomy. B. Should the laparotomy incision be planned to traverse the penetrating wound, then by deviating the incision on either side of it, it can be made to include the wound so that laparotomy and excision of the wound are performed together. 5. Penetrating wounds of joints. In penetrating and perforating wounds of all joints, the wound of entry and exit must be excised en masse and made to include the wound in the synovial membrane. Excision of a wound en masse is an extremely difficult procedure in the case of penetrating shell wounds where much damage has been sustained by the deeper structures. In the case of large lacerated wounds of the soft parts, the procedure is simpler, but still in this class of case there are many difficulties and pitfalls. Within a penetrating shell wound, many pockets and diverticuli exist, caused by the tearing of muscle and its subsequent retraction. The last resting place of the missile itself in the tissue often constitutes a very awkward and difficult diverticulum to deal with. During the process, hemorrhage occurs and is sometimes excessive, requiring the use of many pressure forceps for its temporary arrest. Again, when the surgeon may think that his task is finished, he may discover another diverticulum hitherto unrecognized. Excision of this may lead to a virulent reinfection of the part of the wound already excised. Complete and successful excision of penetrating and lacerated wounds en masse requires much practice, patience, and experience, for in them there is at first much that the eye does not see, and much upon which the surgeon has not reckoned. Smaller lacerated and penetrating wounds in which there are no loculi or diverticuli are easily and rapidly excised. If time permit, it is a good precaution, in fact, for success one might say a necessity, to sponge all these wounds with pure carbolic or some other suitable antiseptic which will prevent any weeping of infective material from the wound surface during excision. Excision en masse of wounds of the head, abdomen, and joints is easily and rapidly carried out, but here again the same precaution should be taken to sear their surface with pure carbolic or the actual cautery before undertaking excision. Could every gunshot wound, whatever its nature or class, be successfully excised en masse, then the surgeon's dream would be realized. We are now undoubtedly on the right road, and each day more successes are attending the efforts of those who are diligently and patiently following out this plan of campaign. There are many setbacks yet to be overcome, and many cases in which an en masse excision is impossible owing to anatomical reasons. Thus, some penetrating or lacerated wounds of the thigh, leg, or upper extremity may demand for their complete excision removal of such structures as a part of the femoral or brachial arteries, large nerve trunks, and the like. Hence, in wounds such as these, the method of piecemeal excision has to be adopted. Dependent upon the successful en masse excision of wounds is the highly important question of primary suture. However careful and experienced a surgeon may be, and however thorough his technique, he cannot, when dealing with extensive wounds by an en masse excision, except in an infinitesimally small number of cases, procure a bacteriologically sterile wound. The resulting wound may contain but a small dose of infection, but it is not sterile. Organisms with very small particles of devitalized tissue are bound to be left behind. The all-important question is, can these wounds be safely closed immediately after excision if some suitable antiseptic be left in them? In other words, is primary suture practicable? In a large percentage of cases, it is. The method we have adopted has been to swab out the surgically excised wound with either brilliant green or flavine, and in doubtful cases, to include in the sutured wound 1 or 2 Carrel's tubes. Ether is another useful antiseptic for this purpose. Into each of the tubes, after suture, is introduced from 1 to 3 drachms of flavine, brilliant green, or Dawkins solution, the amount instilled depending upon the size of the wound. If Dawkins solution be employed, a 6-hourly installation is carried out, but if flavine or brilliant green be used, 1 injection daily is sufficient. Of the 3 antiseptics tried over a large number of cases, Dawkins solution or Usol has given the best results. Flavine and brilliant green have been used in a dilution of 1 in 1,000, the diluent being normal saline solution. Carrel's tubes are removed from the wound in from 48 to 72 hours, provided there is no evidence of inflammation. In cases of head injury, healing occurred by primary union in 48 out of 54 cases. Of the remaining 6 cases, union, though delayed, occurred in 4, while the remaining 2 cases entirely broke down. Carrel's tubes were never used for head cases. The scalp was sutured, and the antiseptic injected by means of a syringe into the wound between 2 of the stitches. In most cases of penetrating wounds of knee joints, the skin wound can with safety be closed after suturing the capsule. The skin wound before final suture is swabbed out with 1 of the 3 antiseptics, and after suture the antiseptic is instilled into the wound between 2 of the stitches in precisely the same manner as adopted in scalp wounds. Out of 24 cases of penetrating wounds of the knee joint treated by these means, 22 healed per primum, and 2 partially broke down, but only as far as the skin was concerned. In none of these cases, and they were all wounds caused by high explosive, did the joint infection progress further. B. Excision of a wound piecemeal. This method must be resorted to when structures as bone, large arteries, nerves, and the like are severely involved. After all dead and ragged skin has been cleanly excised, dead muscle and other soft tissues that are obviously a source of danger are cut away, preferably with a sharp pair of scissors. Bone detached from its periosteum or bone that is soiled is also removed. It now remains to deal with large arteries or nerve trunks that have suffered. If a large artery with its accompanying vein be exposed in a wound and be covered with infected slough, then sooner or later, however rapidly sterilization is commenced and however vigorously it is carried out, secondary hemorrhage will almost always occur. This has happened time and again, and we feel convinced from our results that resection of the exposed portion of the artery and vein is the correct practice under such circumstances. Out of 20-odd cases in which this practice was resorted to, only in 2 did gangrene result. One of the 2 cases in which 3 inches of the femoral artery and vein were resected showed gangrene limited to the toes, whereas in the second case, gangrene extended as high as the knee, necessitating amputation, resulted from the resection of 4 inches of the femoral artery and vein. Opposed to this, secondary hemorrhage resulted in 13 out of 15 cases in which an attempt was made to save the infected artery. When large nerve trunks are involved, every effort should be made to save them. If large nerve trunks such as the sciatic, the external popliteal, the musculospiral, etc. be divided, it is always advisable, if possible, after excision of the wound, to approximate the divided ends. And even if the loss of continuity be so great that apposition of the divided ends is impossible, it is advisable to bridge the gap with 4 or 5 strands of thin catgut. Whatever method be used to restore or help continuity in a divided nerve is always time well spent, because even if the anastomosis under these septic conditions is a failure, it will materially help the orthopedic surgeon when he comes to perform an anastomosis later on after the wound has healed. The question that next arises is, what are the prospects of a successful primary suture in a wound that has been excised piecemeal? To this question, it is impossible to give a definite answer. Bone that has been comminuted and infected as a result of shell fire is not only difficult to sterilize, but one can never be quite certain that all the highly infected bone has been removed. Consequently, the closure of such wounds by primary suture after excision is not without considerable risk. Some surgeons have had success from primary suture in this class of wound after smearing the freshly prepared wound surface and the ends of the fractured bone with various paste preparations such as the bismuth, iodoform, and paraffin paste, brilliant green paste, etc. We have not used these paste preparations, but have had a percentage of successes, 40%, from primary suture in this class of wound by including in the wound after suture 1 or 2 Carrel's tubes and instilling Dockins solution 2 hourly in exactly the same way as in the after treatment of extensive wounds excised en masse. It is very difficult to lay down any hard and fast rules for the after treatment of large wounds excised piecemeal, but on the whole, out of a large number of cases amounting to between 1 and 2,000, the safest and most satisfactory results have been obtained by secondary suture after the wound has been rendered bacteriologically sterile by the method of Carrel and Dakin. A. Seton wounds. The inlet and exit wounds in the skin are cleanly excised, about 1/4 of an inch of skin being removed all round. The incision extends down to the deep fascia. The perforation in the deep fascia is next looked for and is frequently at a different level from the perforation in the skin. If this be so, the skin should be incised from the excised skin wound up to the level of the perforation in the fascia. With a clean knife, the perforation in the fascia is next excised. If the soft parts be very swollen for some considerable distance from the wound and in the neighborhood of the wound itself, both skin and deep fascia should be further incised by prolonging the wound of excision in either direction to the required extent. This is a most important step, as the immediate relief of tension in a swollen limb by the incision of the deep fascia removes a serious brake on the circulation, besides giving a good exit for any pent-up gas or fluid. It may be that the swelling is the result of hemorrhage into the limb. The position of the wound will give a good indication which vessel has been wounded. Any damaged vessel should be immediately ligatured as it lies in the wound, i.e. at the site of injury. Under exceptional circumstances only, which will be referred to later on, should a large vessel be ligatured in its continuity, for such treatment invariably ends in disaster. It is hardly necessary to mention that a damaged vessel should be ligatured both above and below the breach in its wall, and if the damaged vessel be an artery, it is advisable to ligature the accompanying vein at the same level. After excising the wounds and making any further necessary incisions to relieve tension, a long pair of Spencer-Wells forceps is carefully introduced into the inlet hole in the deep fascia, and the points are made to emerge at the exit hole. A strip of sterile gauze soaked in hydrogen peroxide is then drawn along the track of the wound through the soft parts once or twice. By this means, any small pieces of clothing are removed from the track of the wound, together with any debris in the form of dead tissue. B. Penetrating wounds. All skin for a distance of 1/4 of an inch from the wound, or more if necessary, should be cleanly excised, together with the subcutaneous tissues and deep fascia. Incisions should now be made from the excised wound with a clean knife in either direction. The finger is then gently inserted into the wound through the deep fascia and is made to travel along the breach produced in the muscles and soft parts. No force should be exercised while inserting the finger, as it is extremely easy to make false tracks in the damaged tissue, and when once this is done, the hunt for the missile usually ends in disappointment. A certain amount of practice and experience is needed in order to follow successfully with the finger the track of a missile in damaged tissue, but with patience and perseverance the knack is soon acquired, and the surgeon knows almost instinctively whether or not his finger is going in the right direction. The sense of touch in wounds is very important to develop, and the feel of the track of a missile is both familiar and characteristic to a surgeon who has had experience at a casualty clearing station. The important point, let it be repeated, is to use no force at all in introducing the finger. Far rather let the finger find its own way than the surgeon find a way for it. When once the missile, with its concomitant piece of clothing, has been found and removed, the surgeon can now deal with the damaged tissues. It must not be forgotten that it is just as, if not more important, to remove the piece of clothing from the wound as it is to remove the metallic missile. As a rule, the clothing is usually adherent to the missile, but this is not always the case, for on many occasions clothing and other foreign bodies have been found in the tissue independent of the missile. At the casualty clearing station, such articles as coins, pieces of pencil, matches, remnants of letters, and in one case a portion of miniature New Testament have been extracted from various wounds. Surgeons should always anticipate the presence of these foreign bodies when dealing with wounds in which the missile has traversed the region of one of the soldier's pockets. It was a rule to lecture all NCOs and men on the inadvisability of carrying unnecessary articles in their pockets while in trenches or during an attack. When wounds have been fully opened up, it is often surprising to find the amount of damage sustained by the soft parts. There is usually present a quantity of foul-smelling, dark-colored discharge, and not infrequently the divided ends of the muscles and the deeper structures lining the wound are covered with a grayish diphtheroid membrane, or the muscles and soft parts may present a dark-colored, dry, and lifeless appearance. In the former case, an organism commonly present is Vincent's bacillus, whereas in the latter, the usual combination met with is that of Streptococcus faecalis and B. perfringens. All infected tissue must be completely excised, and this is best accomplished by means of stout, sharp scissors. Wounded and stunned tissue, when cut, does not bleed, and if it be muscle, it does not contract. Excision should continue until healthy, bleeding, contractile tissue is reached, and the surgeon must not stop until he has accomplished this, because every piece of dead and stinking material he leaves behind in the wound is further pabulum for the organisms of infection. When excision of all dead skin, muscle, bone, and other structures is complete, it is very important to secure absolute hemostasis. Any blood clot left in wounds forms a very favorable pabulum for organisms left behind to luxuriate in. After complete exploration and excision, the wound is stitched widely open with silkworm gut sutures to allow of suitable and adequate application of the antiseptic. A safe rule is, if in doubt, err rather on the side of doing too much than too little when excising a wound, and freely prolong incisions into distant edematous tissue. It is only after considerable experience and practice that a surgeon learns exactly how far to go, and until this experience is acquired, it is the lesser evil to err within limits on the side of doing too much. C. Large lacerated wounds. Here, most of the damage done is apparent and not latent, as in penetrating wounds. The treatment is complete excision of all dead skin and devitalized tissue, procuring at the same time absolute hemostasis, just as was done in penetrating wounds. This class of wounds is, as a rule, freely laid open by the missile, hence it will not, in the majority of cases, require sutures to keep it patent, as in the case of penetrating wounds. D. Multiple wounds, usually the result of hand grenades. Such wounds are practically always of the penetrating variety and are small. The immediate treatment called for is not so much for the wounds themselves as for the shock occasioned by them. This class of wound may be divided into two groups as follows. 1. Numerous multiple wounds. The wounds, as a rule, are not deep and are more the result of dirt and very small fragments of thin metal. They result from one of the high explosive hand grenades used by the Germans. See Chapter 1. 2. Multiple wounds, not so numerous as in the former variety, but in which the fragments have penetrated deeper into the tissues, and these result from a different type of hand grenade, which is charged with metallic debris in the form of broken nails, screws, broken bolts, and the like. See Chapter 1. Bomb wounds now form a very considerable percentage of the present war wounds. They are of a serious nature and call for special consideration. Shock is especially pronounced, and it is well before operating to get the wounded man thoroughly warm in bed and to administer, if possible, a subcutaneous saline. Wounds coming under Class 1, in addition to containing many small pieces of dirt, practically always show a degree of scorching. They are most commonly met with about the exposed parts of the body, such as the face and hands, but in a number of instances large pieces of the soldier's clothing have been torn off, and his whole back may present a superficially riddled appearance, or the legs and thighs or buttocks may be affected. The whole part should be most thoroughly cleaned by scrubbing with hydrogen peroxide after the surrounding skin has been prepared. Hydrogen peroxide cleans this class of wound better than anything else. After thorough cleaning with this antiseptic, the whole wounded area is dried and scored with the point of a scalpel or sharp cutting needle. This done, a salt pack is applied to the whole surface. In the case of the face, the best dressing is hypertonic saline. If the skin in addition be badly scorched, after treatment with peroxide and scoring, the wound is washed with sterile saline, carefully dried, and dressed with paraffin No. 7. With the salt pack, these multiple superficial wounds have progressed rapidly and satisfactorily. The patients seem comfortable and complain of little pain. In the second variety of multiple bomb wounds, if the missile be large, it must be removed after excision of the wound. Usually multiple wounds from this cause are all small. There is but little swelling around them, and the patients on the whole do infinitely better if left alone for 2 or 3 days, provided important parts, such as the head, abdomen, and the larger joints, have not been penetrated. Shock at this stage is the main condition that calls for treatment. It is quite soon enough if the operation for the removal of these foreign bodies be undertaken at the base hospitals about the 5th day after injury. At the end of the 5th day, it is usually evident which of the remaining foreign bodies are going to give rise to trouble. The plan we have adopted with this class of case at the base hospital is to squeeze gently round the wound which appears to be inflamed. Those from which a purulent discharge emerges are dealt with, the track can be easily followed, and the foreign body removed. The patient himself is a surgeon's best guide. He will pick out the wounds which at this stage have become painful, and the wounds he picks out are invariably those which require surgical treatment. A number of the wounds heal without any further trouble, hence it is always best to wait and see which require treatment and which do not, before making a bold attempt to remove all the foreign bodies at one sitting, a procedure which jeopardizes the patient's chances of recovery much more than waiting. We feel completely justified in offering this advice, as we have seen the results of both early and late treatment in a large number of these cases, and can definitely say that the plan of waiting is in every way advisable. Cases in which the wounds have healed with the foreign body still in can always be dealt with at a later date when the patient is in a far better condition to stand the operation. Treatment of shock. Shock is the serious complication of all severe wounds. It may result from reflex causes, such as seen in multiple wounds or severe compound fractures, especially of the femur, from large lacerated wounds, or it may be the result of severe primary hemorrhage. Reflex causes of hemorrhage may coexist, giving rise, as before stated, to intensified shock, which makes the prognosis in any particular case much more grave. Transport does much to increase shock, especially in the case of penetrating abdominal wounds and imperfectly immobilized compound fractures. It should never be forgotten that wounds are usually inflicted on men who are already suffering from fatigue, and that very soon after their infliction, virulent organisms which have gained entrance into the wound begin to exert their toxic action. Hence, superimposed on shock, there is a degree of fatigue and toxemia to be reckoned with. Psychic shock has also to be considered, as it is present in a large number of men, especially officers. horror at some sight they have seen, such as the mutilation of a comrade, the fact that a large portion of their regiment has been wiped out, and the like, are sufficient to produce psychic shock of an advanced degree. Wounded men arriving at a casualty clearing station suffering from severe shock with the accompanying conditions of fatigue and toxemia must be put in bed, well warmed, given normal saline with sodium bicarbonate subcutaneously or intravenously, and not taken direct to the operating theater unless immediate operation is indicated for such reasons as hemorrhage or advanced gas gangrene of a limb. Stimulants may be given by mouth and hot drinks if the patient is not vomiting. Pituitrin administered hypodermically along with the saline is a valuable asset. If after 3 or 4 hours the pulse has improved, the patient can be taken to the theater if this is necessary. The operating table should be warmed, and if a heating apparatus is not provided with the operating table, hot water bottles should be substituted, but great care must be taken not to burn the patient. During the operation, which should for serious cases be performed under ether, preferably given by the endotracheal method in combination with oxygen, saline and bicarbonate should be slowly administered all the time, subcutaneously or intravenously, and with it brandy or pituitrin. The operation should be performed as rapidly as possible, consistent with efficiency. Hemostasis should be procured throughout the operation, for at this stage the patient can ill afford to lose any blood. The dressing should be applied and the wounded man returned to a warmed bed with the foot raised. As soon as he is recovered from the anesthetic, provided he is not vomiting, hot stimulating drinks should be given, and additional saline per rectum if necessary. This latter part of the treatment is often impossible, as so many wounded men are profoundly constipated and the rectum is usually full of hard feces. Often after returning to bed from the theater, the patient breaks out into a copious perspiration, and with this there is a rise of temperature and a more rapid, though improved, condition of the pulse. This is a good sign, as toxic bodies from the tissues are being eliminated by the skin and the patient is reacting to treatment. As soon as possible after operation, an aperient, aided as is usually necessary by an oil and turpentine enema, can be given. As early as possible the patient may be given solid food, and it is often amazing to hear severely wounded men who have suffered considerable shock ask for meat and potatoes on the day following an operation. This should never be withheld, for often one man's meat is another man's poison, and a man's stomach is its own best judge under such circumstances as these. Saline with sodium bicarbonate administered early hypodermically or intravenously has, whatever the critics say, clinically proved itself of the utmost value to men who have been severely wounded and who are in addition suffering from shock, hemorrhage, fatigue, and toxemia. Not only does it replace temporarily the fluid that is lost, but it also washes the tissues of the products of fatigue and bacterial toxins. It is also highly probable that the addition of sodium bicarbonate to the saline brings about the good effect that it undoubtedly does by neutralizing the acid products of fatigue, and so helping the wounded man's natural resistance. We can, after an extensive trial, strongly recommend its use. We feel that we cannot too strongly emphasize the fact that the surgical treatment of a wound, though highly important, is only a part of a necessary routine procedure. Equally important is the treatment of the wounded man's general condition, for after all, it is his own defensive forces that have to carry on the battle against shock, fatigue, and infection after the surgeon has treated his wound, and it is the surgeon's duty to help his body resources in every possible way. He must be put under the best conditions possible to battle against the formidable foe of infection, and although we cannot hope to simulate nature's work, yet we can aid, and to some extent direct it. Dressing the wound. After a wound has been surgically prepared, the question of the dressing remains for consideration, and this brings us to the subject of antiseptics. Here we must again look back and reflect for a brief period on the history of antiseptics during the present war and recall our treatment of wounds in civilian practice. In civilian practice, wounds are treated very soon after their infliction. In the casualty department of one of the big London hospitals, the two cardinal principles of wound treatment, viz. the prevention of further infection and the eradication of any existing infection, were almost most conscientiously carried out on Listerian lines. The skin was thoroughly cleaned and shaved around the wound. The wound itself was thoroughly cleansed with Lister's strong mixture after cutting away any obviously dead tissue, and dressings of 1 in 2,000 perchloride of mercury were applied. Smaller wounds after this treatment were sutured and on the whole healed well. Wounds involving bone were swabbed out with pure carbolic acid and afterwards washed out with a 1 in 2,000 solution of perchloride of mercury, this treatment giving highly satisfactory results and often resulting in healing by primary union. This, however, was not the case in regard to wounds of the present war, because here there is an entirely different type of wound to deal with. Wounds treated by pre-war antiseptics have turned out disastrously because the older antiseptics fail to fulfill the conditions of an ideal antiseptic. What then is an ideal antiseptic? An ideal antiseptic must possess the following properties. 1. It must be a highly potent bactericide. 2. It must be innocuous to sound tissue, but must rapidly remove dead tissue and sloughs. 3. It must be non-poisonous to the individual when applied in large quantities to an extensive wound. 4. It must be innocuous to leukocytes and not delay their functions. 5. It must act in the presence of serum or wound exudate. 6. It must not delay, but rather hasten tissue repair. 7. It must be an antiseptic which will help the patient for the first few days following his injury and not rely upon the patient helping himself. 8. It should be cheap and must be easily prepared. It will at a glance be seen that none of the older antiseptics fulfill these 8 conditions. Carbolic acid is poisonous to the individual and also to the leukocytes, whereas perchloride of mercury is not only poisonous to the individual and the leukocytes, but its action as an antiseptic is soon nullified in the presence of serum as it rapidly forms albuminates. Further, the dilution in which these antiseptics must be applied to the present war wounds renders them as rapid bactericides quite inefficient. Earlier in the war, irrigation of wounds, either continuous or intermittent, with various antiseptics was freely practiced. Carbolic acid, a mixture of carbolic acid and hydrogen peroxide, various strengths of potassium permanganate, and the like, were tried and advocated by different surgeons. Better results were claimed in wounds treated with certain antiseptics than in wounds treated with others. In brief, the whole question of antiseptics and their mode of application to gunshot wounds was indefinite and inconsistent. Wright and Gray then introduced the salt treatment, and though results were better than anything hitherto seen, the salt treatment for early wounds failed in the following important details. 1. Hypertonic saline or salt packs do not promote, but actually impede, diapedesis of the leukocytes. 2. Hypertonic salt solution possesses very low bactericidal powers. 3. It is a treatment which does not help the individual throughout the period immediately following the infliction of a wound, but relies rather on his own natural power of resistance. 4. Hypertonic saline withdraws serum from the body at a time when it not only inefficient to combat infection, but also at a time when the wounded man can ill afford its loss. Wounds undergoing treatment with the salt pack were often extremely offensive, though the temperature and pulse were satisfactory. This in itself in the hot weather, especially in the Eastern theater, was sufficient to attract a large number of flies to the ward and was therefore not only undesirable, but dangerous. Salt treatment applied early after excision of a wound relied upon the wounded man assisting himself with his own blood serum, which in fatigued, shocked, and completely knocked out men was useless. Hence, at this stage in the history of wound treatment, it was better suited for men who had materially recovered as far as their general condition was concerned. The inadvisability of the salt treatment for seriously wounded men in the period immediately following infliction of their wounds, when their natural resistance was low, was known to many who were working at the casualty clearing stations. Irrigation by normal saline solution did good locally by washing away toxins and sloughs as they separated, and it probably washed away many bacteria. It did good in that it encouraged rather than prohibited the immigration of leukocytes into the wound, but it failed in that it is not a bactericide, but rather in the presence of wound exudates and serum, it enhances the growth and proliferation of bacteria. It further tends to make the tissues sodden and so delays tissue repair. At this stage, there was no recognized standard method of wound treatment. In fact, many surgeons were going their own way, but little advance towards a sound, rapid, and efficient method of treating wounds was being made. A certain cabinet minister, while visiting France and the various British hospitals there, made the observation that it seemed to him curious that one hospital was adopting one method of treatment while another hospital was adopting another. In fact, he said, "Why can't you all meet and decide on one satisfactory method of treating wounds?" or words to this effect. There is little doubt that a satisfactorily standardized method of treating wounds would save many lives and limbs, would be of the greatest help in the organization and administration of the medical services, and would save the state considerable expense. The Corral-Dakin treatment of wounds. After considerable experience in all medical units from firing line to base, the authors are firmly convinced that the Corral-Dakin treatment of wounds is so far the most satisfactory. Out of nearly 2,000 consecutive cases treated at a base hospital by this method, the results have not only been the quickest and the best, but also the cheapest and most economical to the state. The treatment consists in the regular intermittent watering of a surgically prepared wound surface with an ideal antiseptic, that is, an antiseptic which as nearly as possible fulfills the 8 conditions already enumerated. Corral and Dakin used the hypochlorites as their antiseptic, the one selected being the Dauphren modification of Dakin's solution, available chlorine 22%. The treatment practically amounts to dressing a surgically prepared wound hourly or 2-hourly with an ideal antiseptic. The method of surgically preparing a wound has already been described, but it must be remembered that a surgically prepared wound, however thorough the excision, is not bacteriologically sterile. As far as possible, all pabulum for bacteria has been removed, and the wound put under the best conditions for rapid sterilization. It is of the greatest importance that the wound be excised at the earliest possible moment after injury, for the earlier excision is undertaken, the more rapid and simple becomes the subsequent sterilization, and vice versa. The hypochlorites, when applied on a gauze dressing, rapidly lose their bactericidal properties and become quite inefficient at the end of an hour. If the dressings had to be changed hourly, this would cause much extra work, much pain to the patient, and would interfere with wound rest. Corral overcame these difficulties by the introduction of his tubes. Method of applying a Corral-Dakin dressing. After the wound has been excised, sterile carbolized Vaseline spread out on sterile butter muslin is first laid on the skin around the wound. This preliminary dressing should come to within 1/4 of an inch of the wound edge. If the wound be a deep one and contain recesses, its walls should be kept apart and its recesses kept open by some device such as sterile struts made from pieces of stout rubber tubing or pieces of metal. We have found it a far more satisfactory method to stitch the wounds widely open by means of stout fishing gut. It may be necessary in some cases to use a combination of the two. Over the Vaseline dressing is placed sterile gauze wrung out of hypochlorite solution. This layer of gauze should be about 1/4 of an inch in thickness. Corral's tubes are now laid in the wound, and these must be arranged in such a way that every part of the wound, especially the recesses, gets its share of antiseptic hourly. The tubes are kept in position by means of gauze. After the tubes have been suitably placed, small rolls of gauze wrung out of hypochlorite solution pass from one side of the wound to the other and rest on the gauze which has been placed over the carbolized Vaseline. Over the rolls of gauze which bridge across the wound is laid a gauze dressing. It will thus be seen that the wound has been converted into a virtual box or sump, and the gauze dressing placed over all constitutes the lid. It will also be seen that no gauze touches the wounded surface, hence the changing of these dressings is an absolutely painless procedure. Over all is now placed the final part of the dressing, and this consists of wool old bandages, and other re-sterilized and absorbent material included between two single layers of gauze resembling a gamgee tissue. The final part of the dressing completely surrounds the limb or other wounded part and is fastened by safety pins. The tubes emerge through holes cut in the gamgee tissue, and their ends are attached to 4-way glass pieces. We've employed as few as 4 and as many as 20 tubes for wounds of different dimensions. In large wounds, it is better to err on the side of using too many than too few. 1 or 2 drachms of the antiseptic per tube are instilled hourly, and the dressing is preferably changed daily. In cases of emergency, a dressing may be left for 48 or 72 hours, and out of a very large number of wounds we have seen no harm result from this practice, though a daily dressing, if possible, is preferable. There is much to be learned with regard to the successful application of a Carrel-Dakin dressing, and no surgeon, however skilled, can grasp all there is to be known about the Carrel-Dakin method in a day or two. There are many pitfalls, not only during the subsequent treatment, but also in the application of the original dressing. Hence, it is only after 2 or 3 months' experience that a surgeon can become au fait with Carrel's method of wound treatment. To arrange Carrel's tubes adequately in different wounds, such as dependent wounds of limbs, wounds of the face and jaws, wounds of the buttock, back, and the like, in such a way that they will act efficiently, and to arrange a convenient and comfortable posture for the patient during the few days of sterilization, calls for considerable ingenuity and affords scope for originality and suggestion. Each day a surgeon discovers some new and original piece of apparatus which is an improvement on what he was using before, and each day he learns something new. After the dressing has been applied, it should be ascertained that all the tubes are working efficiently and that none of them are kinked. The ends of the tubes must never be allowed to occupy a dependent position, but must be above the level of the wound. If this be not the case, the antiseptic will siphon back immediately after being instilled, the wound will not get its proper supply of antiseptic, the bed becomes wet, and the patient's skin becomes sore. The practice of leaving the ends of the tubes in a dependent position is an extremely common fault and should never be allowed to happen. End of Chapter 14, Part 2. Chapter 15 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 15, General Treatment of Gunshot Wounds, continued. Treatment on lines of communication and at the base hospital. As soon as the patient's condition permits, he is sent to a base hospital. Hourly or 2-hourly installation with the antiseptic is carried out on the hospital train, and this is continued at the base hospital until the dressing is changed. It is very important to realize that when once a wound is surgically prepared and the first dressing applied, it is then a wound undergoing a process of continuous sterilization. Hence, at each subsequent dressing, the very strictest aseptic precautions must be practiced, and as much attention paid to one of these wounds as would be given to a clean abdominal incision or a clean incision opening the knee joint, because surgically prepared wounds are most easily reinfected through any small error in technique. This cannot be too strongly emphasized, for it is inattention to what appear to be trivial details that has so often brought about failure and caused the Carrel-Dakin treatment to be unfairly criticized. We are convinced that wherever failure occurs, it is not the treatment that is at fault, but the way in which it has been carried out. Application of tubes. A very important precaution in the Carrel-Dakin system of sterilizing wounds is to see that every part of a wound, especially its diverticula, receive a constant and regular supply of antiseptic. This means that the arrangement of the tubes in the wound must be both accurate and efficient. In what might be called a sump wound, the process is simple and one tube will suffice. See Figure 89. In more superficial wounds of considerable extent, we have adopted the plan of converting these wounds by artificial means into sump wounds by the use of gauze, see Figure 90, and have obtained excellent results. For sloping wounds, the Carrel's tubes must be laid at the highest point of the wound, so that the antiseptic runs down periodically over the whole wound surface. Tubes applied halfway down or at the bottom of such wounds are useless. See Figure 91. In dependent wounds, the tubes must be kept in contact with the wound surface by some suitable device. The method we have employed has been that of strips of sterilized gauze passed around the limb, securing part of the dressing and the tubes. Over this, the final dressing is fixed. This has given excellent results, equal to those obtained in the wounds in other situations. Seton wounds which require it can be sterilized by placing a Carrel's tube along the entire track. Carrel has recommended, in the case of dependent wounds, providing they be deep and not of great extent, that a petticoated tube be employed, bath toweling being used for the petticoat. We have tried this method, but have obtained far better results by lining accurately such a cavity with a single layer of gauze and inserting 1 or 2 Carrel's tubes. It is quite useless to insert a Carrel's tube into a small punctured wound. The antiseptic is forced into such a wound under pressure, and it can neither circulate nor escape. The wound must be sufficiently enlarged before such a process of sterilization can be properly carried out. In all wounds except the deep dependent wounds, there should be no dressing between the tube and the wound surface. If possible, it is preferable that the tube should not touch the wound surface, owing to the risk of blocking the holes. For sterilization of wounds of the back and buttock, the patient must be nursed on his side. Thus, if the right back or right buttock be wounded, he must lie on his left side. It is impossible to put into writing the very many points to be observed and carried out in the Carrel-Dockin treatment of different wounds. It is by experience only that a surgeon becomes au fait with them. The treatment invites both ingenuity and originality, and our experience goes to show that endless diagrams and hints in print will not materially help a surgeon. The following general principles will be of help. 1. Surgically prepare the wound by excision at the earliest possible moment after the wound has been received, and procure absolute hemostasis. 2. Apply the tubes in such a way that every part of the wound receives an adequate and efficient periodic supply of the antiseptic, and do not, except in the case of deep dependent wounds, put any dressing between the wound surface and the tubes. 3. If necessary, and it is usually so in the case of large deep wounds, fix the wound completely open to the fullest extent of its depth with silkworm gut sutures before putting in the tubes. 4. Keep open by plugs of gauze or stout rubber tubing every diverticulum. 5. Be sure that every tube is working and not kinked after the final dressing is applied. 6. Be sure that the open ends of the tubes do not occupy a dependent position, for if this be the case, the antiseptic after installation will simply siphon back into the bed, wet the sheets, and give the patient a sore back. This is a particularly common fault, and we draw special attention to it. 7. In the case of severe comminution of bone, be sure that the tubes go down to and in among the fragments. A tube laid into the wound and not reaching the fracture is useless. 8. Never leave a tube in contact with a large artery, vein, or nerve. 9. If there be a sinus going down to the bone, or a sinus in the tissues at the bottom of the wound, leave the end of the tube at the bottom of the sinus open. 10. Do not expect rapid sterilization of a compound comminuted fracture of a long bone, but persevere with the Carrel-Dockin treatment. In some rare cases, it has taken us as long as 5 to 6 weeks to effect sterilization, whereas in the majority of cases, it has taken 12 to 15 days. In a few cases, sterilization was complete in 4 to 6 days, and these latter occurrences are daily becoming more frequent with increased experience. 11. Never give up hope in cases of injury to the tarsus and metatarsus. These wounds are notoriously difficult of sterilization owing to the intricate nature of the synovial sacs. Perseverance will bring about sterilization even though it be long delayed, 5 to 7 weeks, and serviceable feet have resulted which but a year ago would have been doomed to amputation. 12. Do not be disappointed with early or even late failures. Wherever this has occurred, it has been found, after very thorough inquiry, that it was not the method that was at fault, but the way in which it had been carried out. 13. Always remember that wounds, when once under treatment, are wounds undergoing sterilization. Subsequent dressings must be carried out with every aseptic precaution, gloves, cap, sterilized gown, and sterilized towels being used. The wound should not be touched with the gloved hand, but only with boiled instruments. All medical officers should be dressed and scrubbed up in exactly the same way as they would be if assisting at a clean operation. Scrupulous cleanliness and asepsis must be exercised in the dressing of all wounds. This technique, laborious as it may seem, has given the best results in a series of over 2,000 consecutive cases of serious gunshot wounds treated in this hospital from start to finish. Practical considerations relating to the Carrel-Dawkins system of treatment of wounds. Apart from the immediate dangers of infection, the most serious complication of the modern gunshot wound with which the surgeon has to deal is the formation of an excessive amount of fibrous tissue, which constitutes great scars. Excessive fibrous tissue is the tombstone of a prolonged infection. The longer a wound discharges, the greater is the amount of fibrous tissue formed, and such excessive scarring is seen only too commonly in wounds today, both small and large, which have been allowed to heal by the slow process of granulation. A large proportion of the disability following wounds is due to the presence of fibrous tissue, not only in the wound itself, but in such important structures as muscle and nerve which lie in its immediate neighborhood. Disability from this cause is not only mechanical, and due to stiffness resulting from the welding together of muscles, nerves, and other structures in one dense mass, but much disability is brought about by pain, often of a most intolerable character, owing to the inclusion of sensory nerves in the scar tissue. It is therefore obvious that if gunshot wounds can be rendered sufficiently free from bacteria to permit of their closure by suture within a reasonably short period after their infliction, the result will resemble that of a clean operation wound, and excessive scar tissue with its accompanying disadvantages will be avoided. The modern gunshot wound is characterized by the excessive amount of damage wrought in the tissues, not only in those of the parts of the wound which are apparent, manifest trauma, but also in the tissues of the parts distant from the wound, latent trauma. The damaged and dead tissues form excellent pabulum for the growth of the germs of infection. Hence, if these germs be given a chance, they will not only flourish in the wound itself, but will extend into the latently damaged tissue at some distance from the wound. The first step in wound treatment, then, should aim at the removal of the missile, its concomitant piece of clothing, and the dead and seriously damaged tissue, so that as little pabulum as possible suitable for the growth and multiplication of wound bacteria is left behind. This is accomplished by complete excision of the wound as soon after its infliction as is possible, that is, before infection has become firmly established. Excision of the wound, however skillfully performed, does not leave the resulting wound absolutely germ-free. There is always some residual infection, and this can be overcome by the use of antiseptics. The antiseptic used should be non-poisonous to the individual generally and to his tissues locally. It must not materially hinder the action of the leukocytes. Its bactericidal properties must not be impaired to any extent by the presence of the wound discharges. It should be highly bactericidal, and should be capable of penetrating the tissue to some degree. Hypochlorous acid fulfills all these requirements. At the end of an hour, this antiseptic, if applied on a gauze dressing, becomes used up and requires renewing, a process which would entail a quite impracticable amount of work on the part of the staff and of distress on the part of the patient. Carrel overcame this difficulty by the introduction of his finely perforated tubes. By means of these tubes, the wound is sprayed hourly with a solution of this antiseptic. The tubes are changed daily or every second day, and the wound discharge is examined by a bacteriologist. Gradually, the bacterial count of the wound diminishes, and when the bacteriologist reports an average of not more than 2 organisms to 5 fields of the microscope, 0.4 organisms per field, a stage which may be reached in most cases from the 4th to the 12th day following the infliction of the wound, then the wound may be safely closed. By this means, the formation of fibrous tissue is reduced to a minimum, and the sutured wounds resemble in every detail wounds that have healed by primary union. The Carrel-Dawkins system has as its object the closure of a wound at the earliest possible moment after its infliction, thus causing the minimum of disability from the excessive formation of fibrous tissue, the minimum of pain resulting from scars, and the possibility of the maximum benefit being derived from any orthopedic treatment which may be instituted at a later date. Modification of Carrel's method have been advocated by other surgeons. Thus, after excision of the wound, different antiseptic pastes have been smeared over the newly prepared surface in order to deal with the residual infection, and the wound has been closed forthwith, primary suture. Though some brilliant results have been reported, the method is hazardous, for it depends upon how thoroughly the excision of the wound has been performed. That is, it relies upon the experience of the surgeon. The Carrel-Dawkins method is safer and gives equally good results. The early closure of wounds makes for economy in every direction, to the individual, to the army, and to the state. To the individual, it has meant the saving of life and limb in many hundreds of instances. It has meant the prevention of permanent disability, and in many cases of any disability at all, and it has prevented untold pain and suffering, for even the most ghastly of wounds can be treated painlessly from start to finish by this method. The Carrel-Dawkins scheme, if properly carried out, is essentially a painless one, and patients have actually slept while such extensive dressings as those required for compound fractures of the femur have been carried out. From the point of view of army economy, the fact that many cases, including those of severe compound fracture of bone, have been returned to duty without leaving the country is sufficient evidence of the practical efficacy of the treatment. From the point of view of the state, expenditure has been saved in many directions. Human life has been conserved, expenditure on pensions has been consequently diminished, and in addition, the expensive treatment of our wounded has been very materially cut down. For example, in one particular series of 1,000 seriously wounded men, the expenditure on surgical dressings worked out at the low average figure of 7 shillings per head from the beginning to the end of treatment. The Carrel-Dawkins treatment is one which can be standardized and carried on continuously between field ambulance and base. This has been found to be possible and practicable in the Balkans, where the question of transport is a very different problem from that which obtains in the Western theater of war. In carrying out the treatment, correct technique is absolutely essential, and it is failure to achieve this which has led to adverse criticism of the method on the part of certain sections of the medical profession, and has also given rise to the suggestion of various unsatisfactory modifications. Medical officers unfamiliar with the treatment must be prepared to spend at least 2 months in mastering the many and varied details of technique, attention to which alone can yield the astonishingly good results which have actually and uniformly been obtained. Close cooperation between surgeon and bacteriologist is absolutely essential to success. No surgeon, whatever his experience, can tell by clinical observation when a wound is ready for secondary suture. Moreover, every surgeon should be accurately informed of the type and degree of infection present in the wounds with which he is dealing, in order that he may be assured that his technique is correct. For instance, if the bacterial count of a wound suddenly increases, he knows that either the antiseptic is deficient or his technique is at fault, and this may occur although the wound appears clinically satisfactory. What are the advantages of the Carrel-Dawkins treatment? 1. It is a treatment which relies less than any other on the wounded man's own recuperative powers for the first few days. 2. It is at present the most rapid method we have of sterilizing a wound and rendering it fit for secondary suture, thereby making a wounded man fit to return to duty in the minimum time and leaving him without the extensive painful scar which results from healing by second intention, an important point in the economy of the Army. 3. Without hesitation, we can say that it has been the saving of many limbs in the series of cases treated at this hospital, because we have seen many limbs saved which would undoubtedly have been sacrificed even as recently as the Somme offensive in 1916. 4. The dressings are painless, which is a great advantage, for constant dressings under an anesthetic are extremely harmful to the patient because they lessen his morale and impede his progress. 5. The hourly or 2-hourly installation is appreciated by the patients. They say that it is refreshing and cool to the wound, and they remind the sister to the minute when it is due. 6. In this method, we have definitely a standard way of treating all serious wounds. We have been fortunate enough to witness the evolution of the treatment of wounds from the beginning of this war, and have seen the undeniably ghastly results of the earlier methods of treatment. Since the advent of this system of treatment, the whole outlook has changed, and today on this front and elsewhere we are witnessing the successful results of a universal and continuous treatment of wounds which has surpassed anything previously tried. 7. It marks an important era in surgery, in that the objectionable method of wound drainage can be done away with, and though no doubt it will die a hard death, yet Carrel's method we are confident will supersede it. 8. Patients are able to get up and about sooner. The average stay in bed in this hospital per patient over 2,000 severely wounded cases has worked out at 17 days. What are the disadvantages of the Carrel-Dawkins method? 1. Increased staff. This has not been so great as was at first anticipated. The secret lies in a thorough training of the nursing staff by lectures and demonstrations. We have found that sisters and VADs can carry out the treatment competently after a comparatively short period of routine training. They have grown enthusiastic at the results they have seen, at the painlessness of the dressings, the total absence of suffering in even the most gravely wounded, the absence of smell in the wards, consequently the remarkable absence of flies even in an eastern climate, because there is no smell to attract them. A thorough acquisition of the technique diminishes the demand for an increased staff, and the use of Balkan supports has very greatly relieved the heavy work of lifting these patients. Further, the wounded men are soon able to get up and help themselves. 2. Wetting of the bed. This cannot always be avoided, but experience has made it a negligible factor. Still, there have been no cases of bed sore. If it is unavoidable, the use of an air pillow keeps the patient's back off the wet sheets. 3. Complex apparatus. In the Balkans, we have not perhaps obtained the more refined apparatus procurable in the West, but douche cans, rubber tubing, and glass nozzles have given the desired results. 4. Dermatitis from the antiseptic. This complication has been entirely avoided by means of sterilized carbolized Vaseline applied to the surrounding skin. 5. Length of time dressing a wound. This is much shortened with experience, and with practice the dressings can be completed in a shorter time than by the older methods. Method of instilling the antiseptic into the wound. This can be performed 1. By gravity, 2. By syringe. The first method can be carried out by means of a reservoir, an enameled douche can placed about 3 feet above the level of the wound on the wall of the hut or hung from the roof or side of a tent. To the douche can is attached a rubber tube with a glass nozzle at the end, which can be introduced into the open end of the Carrel's tube or the tube which is fixed to the 4-way glass piece. For practical purposes, the clamp on the rubber tube leading from the reservoir is released and the antiseptic is allowed to flow for 3 seconds into each Carrel tube. On the train or ship, it is preferable to use a glass syringe unless a gravity apparatus is provided. If the height to which the reservoir is raised causes pain, then it should be lowered until the correct head or pressure is reached. An automatic apparatus for administering the antiseptic is shown in Plate 4. The second method of instilling the antiseptic by means of the syringe is perhaps more accurate, but if there are a number of tubes per patient and a large number of patients, it is a lengthy process and requires more staff. It is suitable, as stated before, for patients during transport by train or steamship. The most important part of the treatment of a wound rests with the surgical specialist at the casualty clearing station. It is he who must perform the necessary excision and apply the first Carrel-Docken dressing, and on the thoroughness of this work depends the subsequent welfare of the case. We can here speak with authority, as we have worked for considerable periods both at a busy casualty clearing station and a base hospital. During a rush, it is impossible for a surgical specialist at a casualty clearing station to excise and deal with every wound, and of necessity he has to evacuate to the base hospital cases which in quieter times he would certainly retain. Of the rushes on this front we can give the valuable information that in every case, however grave, in which the Carrel-Docken treatment, very imperfect as it was in some cases, had been started at the casualty clearing station, not a limb or life was sacrificed. But in many cases which appeared at the casualty clearing station to be of minor importance and were therefore evacuated without the Carrel-Docken treatment, gas gangrene had supervened by the time the base hospital was reached, and both limbs and lives were lost. These salient facts so strongly impressed us that we are now of opinion that if the work at the casualty clearing stations is more than the surgeon there can deal with, then it is very advisable to apply a Carrel-Docken dressing to the wound as it exits on arrival there and send the case direct to the base hospital rather than to trust to an ordinary dressing. Wounds associated with uncontrollable hemorrhage. There is still a class of wound well known to the surgical specialist and usually associated with compound fracture of the upper end of the tibia or the upper ends of the bones of the forearm, especially the ulna, or associated with a penetrating wound of the interosseous membrane of the forearm about its middle, in which hemorrhage of an uncontrollable nature occurs. It is often impossible to find the divided ends of the vessel, and the more ligatures that are applied, the more persistent seems the hemorrhage. It is this class of wound in which it is both justifiable and good practice to apply a salt pack. This must be put on after the wound has been cleaned and excised, a tourniquet being used the while. It is very important to pack tightly every pocket and diverticulum of the wound, and after the cotton wool has been applied, to fix the dressing securely with a bandage. When the tourniquet has been removed, the limb should be well elevated on a pillow and steadied with a convenient straight splint. The surgeon should not allow the case to leave the theater until he has made a careful examination of the hand and foot, whichever it may be, and is thoroughly satisfied that the circulation is still present. It has happened that a salt pack well applied in a deep wound of any extent has by pressure been sufficient to arrest the circulation in the part of the limb below, and gangrene has resulted. All fractures must be dealt with and thoroughly immobilized prior to transit to the base hospital. This subject will be referred to in a special chapter. The work of the surgical specialist at a busy casualty clearing station is both arduous and difficult. Often he has to work day and night, and under these conditions he cannot keep up the same standard of work that he could had he fewer cases to deal with as in the quieter periods. He has, in addition to the excision of large gangrenous wounds, numerous other cases requiring abdominal section, craniectomy, and amputation to deal with, all of which call for anxious attention in the after treatment. A number of his cases die, and he begins to worry and to think over small things he has left undone that might have been done. He must remember that a number of cases are bound to die, and if for a brief spell he can count up his successes and his failures, he will always find that the balance lies well on the side of success. War is war, and as long as the surgeon is conscientiously doing his best, there is no need to worry, for worry is a powerful deterrent to good work. Treatment on the hospital train and ship. This consists in attending to the general needs and comfort of the patients, and in the hourly or 2-hourly installation of the antiseptic into the tubes. The latter is best carried out with a glass syringe. One argument against the Carrel-Dawkins treatment was the want of continuity during transport. This has been shown to be a fallacy both in France and in the East. Every patient gets his hourly dose on the train, and from what we have learned from the train staff in the East, it can be carried out both easily and efficiently. Should a severe hemorrhage occur on the train or ship, though this is fortunately rare, prompt surgical measures must be taken for its arrest, and these can usually be carried out without stopping the train. Treatment at the base hospital. Convoys arriving at a base hospital are dealt with as rapidly and efficiently as possible. At this particular base hospital, segregation of cases has, whenever possible, been practiced. Thus, all amputation cases have been put into one ward, all wounds of chests, wounds of the head and spine, compound fractures of the lower extremity, compound fractures of the upper extremity, wounds of joints, and abdominal injuries have respectively been nursed in separate wards. By these means, certain sisters and medical officers get accustomed to and familiar with the treatment of a certain class of wound, and the scheme of segregation has proved itself the best both as regards efficiency and economy. Changing the ward staff. It is of the greatest importance not to change the staff of any particular ward unless it is absolutely necessary, as the sudden substitution of a new sister or a new medical officer often spells disaster. No new sister or medical officer, especially if untrained in the Carrel-Dawkins system, can pretend to take the responsibilities of a ward full of serious cases. Consequently, the patients suffer, time is lost, and efficiency impaired, to say nothing of the increased expense to the state. In the East, owing to tropical sickness amongst officers and sisters, we have unfortunately had to put up with this inconvenience, and in this way we have been handicapped. Treatment of the wounded on admission. The severely wounded men are taken direct to the wards after their field cards have been collected at the admission and discharge room, and are put straight to bed, their kit being handed in to the pack store. In the wards, they are divested of their clothing, supplied with a clean pajama suit, washed, fed, and allowed to sleep. For most of these tired men, no hypnotic is necessary, and in many cases they fall asleep for 12 hours or more. No man, unless it is absolutely necessary, is taken to the operating theater on arrival. Far more important to his welfare at this stage is a good rest and a sleep. For the foulest of wounds we have adopted this practice and have seen only good result. It is the greatest mistake in the world to hurry a wounded man. Unless there be severe hemorrhage or an abdominal condition necessitating immediate interference, into the operating theater immediately upon his arrival at a base hospital. On the following morning, the wounds are inspected. The majority of the wounds on this front have been dealt with at the casualty clearing station and arrive at the base with a Carrel dressing applied. Cases of compound fracture of bone requiring better extension, cases of head wounds in which the scalp has been left unsutured, and cases of joints, especially the knee joint, usually require further surgical treatment. In addition, limbs which are gangrenous or for other reasons useless are dealt with on the day after admission, when the wounded men are better able to stand the necessary operation. May we once more emphasize the importance of commencing the Carrel-Dawkins treatment as early as possible in every case requiring it? Even though it be impossible through pressure of work to excise every wound at the casualty clearing station, it will pay 100-fold if the surgeon or medical officer can find time to insert the tubes into a wound not excised, so that the installation of the antiseptic can be carried out until the base hospital is reached. This latter procedure has proved its worth times out of number. All wounds treated by the Carrel-Dawkins treatment at the casualty clearing station are similarly treated at the base hospital. Wounds not so treated but which are suitable are immediately submitted to Carrel's system. Wounds of large extent which are insufficiently patent are stitched widely open and the Carrel dock and dressing reapplied. Bacteriological control of wounds. From each of the wounds, smears are taken by the medical officer or sister in a manner described on pages 104 and 105 and sent to the bacteriologist for examination and report. The number of organisms per field taken over a number of fields forms the surgeon's guide as to the progress of the wound. When this count shows not more than 0.2 organism per field, such smears being taken from every part of the wound is ready for secondary suture. Secondary suture. After preparation, which involves an aperient and thorough cleaning and shaving of the skin, the patient is anesthetized. It has been our practice to shave the pubes, anus, perineum, and scrotum the day after admission in all cases in which the buttocks, thighs, legs, back, or abdominal wall have been involved, in addition to shaving the whole limb, and also to shave the axilla and limb in cases of wounds of the upper extremity. The skin around the wound is washed with ether and painted with iodine, and the wound itself is first sponged over with normal saline, followed by ether. The surface during the operation is swabbed with flavine of strength 1 in 1,000 in normal saline, or with the hyperchlorites. A scalpel is now used to incise the periphery of the wound at the junction of the skin and the wound surface down to the deep fascia. This must be carried out in such a way that the opposing surfaces to be sutured are perpendicular to the skin edge, and there will be consequently no turning in of the skin edge along the suture line. This done, the skin is now undermined to a sufficient degree to allow the edges to be approximated with the smallest amount of tension. The suture is now effected by means of tension and approximation stitches. The tension stitches, usually of double-strength silkworm gut and threaded preferably through a piece of small caliber rubber tubing, are first inserted and tied. The number of tension stitches required will vary with the size of the wound. The approximation stitches of single-strength silkworm gut are next inserted in such a way as to slightly evert the skin edges. These are placed at intervals of half an inch along the whole suture line. This done, the suture is complete, and wet dressings of hyperchlorite, flavine, or brilliant green are applied. Wool and a bandage complete the dressing, and if the wound be that of a limb, the limb is put up on a splint. The sutures are removed at the end of the 10th day. We have not used Michel's clips. In all cases of large surface and deeper wounds undergoing sterilization, there is a great tendency to retraction of the skin and tissues, which is certain to involve tension on the sutures when the time for closure of the wound falls due. Their retraction can be overcome by means of the corset shown in Figure 125. The gauze or other sterile fabric is fixed to the skin by adhesive such as Page's glue. A thin rubber lace, by its constant traction, draws the skin edges together and prevents retraction. Length of time for sterilization of a wound. The length of time that a wound requires for sterilization depends almost entirely upon the time that has elapsed between its reception and the beginning of treatment. The shorter this interval, the shorter the time for sterilization. Sterilization in wounds of the soft parts only has been as rapid as 4 days and as late as 14 days. The average time is about 8 days. When bone is involved, the interval of time elapsing between receiving the wound and sterilization has varied from 6 to 28 days, depending upon the amount of the comminution, the time elapsing between the reception of the wound and the commencement of treatment, and the way in which the fracture has been immobilized. Length of time spent in bed. There is no doubt whatever that one of the greatest errors in the after-treatment of wounds is prolonged rest in bed. Wounded men waste rapidly. They lie in bed and brood over their lot, and ultimately, if they are allowed to keep their beds long enough, they show a distinct disinclination to get up. Not only is their morale decreased by this practice, but the work of the nursing staff is made both heavy and difficult. It has been our practice to get these men out of bed at the earliest possible moment, and nothing but good has resulted. Men suffering from fractured humerus, fractured forearm, fractures of the bones of the leg, tarsus or metatarsus are got out of bed at the end of the 4th or 5th day. Men with fracture of the humerus or forearm put up on a Thomas's straight arm extension splint are made to walk with a comrade who supports the splint, while men with fractures of the lower extremity other than the thigh immobilized with suitable splints get about on crutches, the damaged limb being slung from the neck. Not only do wounds sterilize much quicker by these means, but the wounded men at once get confidence in themselves. They realize that their wounds are not so serious as they at first thought. They eat better and sleep better. Their whole outlook on life is altered, and the work of the nursing staff is lightened. Chest wound cases have been got up into chairs at the end of the 7th day and carried out of doors. Out of 150 chest wound cases, no harm occurred, but good only resulted. Cases of compound fracture of the femur, when once thoroughly immobilized on a Wallace-Maybury splint and undergoing continuous sterilization, have got up in a chair at the end of a week. The change for the good in these latter cases is almost incredible, and we have very few cases of this latter condition in which these men were not up on crutches in a Thomas's trench split with their wounds sutured and healed at the end of 6 weeks from the date of their injury. There were several who were up on crutches at the end of the 5th week and a few at the end of the 4th. Abdominal cases have been up and about at the end of 3 weeks, and most joint injuries at the end of the 2nd week. Head cases, as routine, have been kept in bed for 1 month. In not a single case out of a series of 2,000 consecutive seriously wounded men have we seen any harm whatever result in getting them out of bed early, but in every case good has accrued. This, indeed, is in great contrast to what one saw even a year ago. Early getting about in cases of wounds of the lower extremity, especially fractures, has brought about a far more rapid sterilization. It is not going too far to suggest that such ambulatory treatment has a therapeutic significance, and that on the top of the continuous sterilization by the Carrel-Dawkins scheme, there is superadded the element of passive congestion. Continuity in treatment. On the Eastern Front, we have had the opportunity and good fortune to witness the result of a continuity in treatment of wounds between firing line and base, and in this respect our experience here differs from that in the Western Theater. In the Western Theater, where the number of casualties were large, for there it was a matter of dealing with a larger army and constant fighting, the one important point was to get the wounded to the base as rapidly as possible. The base hospitals in turn had, of necessity, to resort to immediate evacuation of their wounded to England. From the hospitals in England, the wounded were, before their wounds were healed, moved on to convalescent homes in different parts of the country. The wounded man, therefore, within a comparatively short space of time, had passed through many hands, and possibly received a different treatment at each institution. In the Eastern Theater, we had, of necessity, to keep the wounded until their wounds were healed, and they could look after themselves on a hospital ship in the event of its being torpedoed or struck by mines. No lying cases could, therefore, be taken on board, and no cases of amputation or fracture unless the stumps or wounds were soundly healed. The Carrel-Dawkins treatment in the Salonika army then became universal. Wounds were dressed early after infliction at the field ambulances with the hypochlorites, and in a number of cases Carrel's tubes were introduced. If this was not possible, the wounds were filled with hypochlorite solution and the wounded were moved on to the casualty clearing stations without delay. At the casualty clearing stations, the wounds were excised and a Carrel-Dawkins dressing applied, after which the wounded man was sent on at once to the base hospital, if fit to travel. If not fit, he was detained at the casualty clearing station, where the treatment was continued. On the hospital train, each man received an hourly dose of the antiseptic through the tubes during the journey to the base. On arrival at the base hospital, he was put straight to bed, and installation of the hypochlorite into his wound was carried on until the next day. In a number of the cases arriving from the casualty clearing stations, a bacterial count of organisms per field taken at the last dressing accompanied the notes. The day after arrival at the base hospital, the wounds were inspected, the tubes replaced, and a bacterial examination of the wounds was made. This treatment was continued until the wounds were sterile, when secondary suture was performed. We would like once again to emphasize the important observation taken now over 2,000 consecutive cases of severe wounds, that in all cases, however gross and severe, especially compound comminuted fractures of the femur and the like, where Carrel's treatment had been commenced early at the casualty clearing station, limbs and lives were saved. But in all cases where rush of work prevented the Carrel-Dockin treatment from being carried out, such limbs were gangrenous by the time the base hospital was reached and had to be sacrificed, and in a considerable number of cases, lives were lost. We cannot overestimate the immense importance of a system of continuity in treatment, for today, when we see extensive compound comminuted fractures of the femur, which would a year ago have been submitted to amputation, united and healed, and the man up on crutches at the end of 6 weeks, cases of severe compound comminuted fracture of the humerus with union and good function at the end of 5 weeks, etc., it gives much ground for reflection. By the regularly organized standard method of wound treatment where continuity can be kept up, we are not only saving life and limb, a very important point in the economy of any army, but we are also saving much subsequent expense to the state. Complication of wounds undergoing treatment. Today, complications are exceedingly rare. Spread of infection, secondary hemorrhage, septicemia, embolism, and pyemia, and certain tropical diseases, chiefly malaria and dysentery, are the main complications to be anticipated. These are all dealt with in other chapters. Directions for the preparation of the solution to be used with Carrel's apparatus. The original Dockin solution was prepared as follows. 140 grams of dry sodium carbonate are dissolved in 10 liters of tap water, to which are added 200 grams chloride of lime, chlorinated lime, and 40 grams boric acid. The Dockin solution, technique of Dauphren, as now used, is prepared as follows. Sodium hypochlorite solution for surgical use must be free of caustic alkali. It must contain only 0.45 to 0.50% of hypochlorite. Under 0.45%, it is not sufficiently active, and above 0.50%, it is irritant. With chloride of lime, bleaching powder, having 25% of active chlorine, the quantities of the necessary chemicals to prepare 10 liters of solution are the following. Chloride of lime, bleaching powder, 25%, 200 grams. Sodium carbonate, dry, soda of Solway, 100 grams. Sodium bicarbonate, 80 grams. Put into a 12-liter flask 200 grams of chloride of lime and 5 liters of ordinary water, shake vigorously for a few minutes, and then leave in contact for 6 to 12 hours. Say 1 night, for example. Shake until dissolved, at least the big pieces. Not all dissolves. Large pieces float. Notice only floating pieces. At the same time, dissolve in 5 liters of cold ordinary water the carbonate and bicarbonate of soda. After leaving from 6 to 12 hours, pour the soda solution into the flask containing the macerated chloride of lime, shake vigorously for a few minutes, and leave time to allow the calcium carbonate to be precipitated. In about half an hour, siphon the liquid and filter with a double paper to obtain a good clear liquid, which should always be kept in a dark place. Titration of chloride of lime, bleaching powder. Owing to the variation of the products now on the market, it is necessary to determine the quantity of active chlorine contained in the chloride of lime which is used. This is in order to employ an exactly calculated quantity according to its concentration. The test is made in the following manner. Take from different parts of the jar a small quantity of bleaching powder. To have an average sample, weigh 20 grams of it, mix as well as possible in a liter of tap water, and leave in contact for a few hours. Measure 10 cc of the clear liquid and add 20 cc of a 10% solution of potassium iodide, 2 cc of acetic acid to free all hydrochloric acid. Then put drop by drop into the mixture a decinormal solution of sodium hyposulfate, 2.48%, until decoloration. The number of cubic centimeters of hyposulfite solution employed multiplied by 1.775 will give the weight in grams of active chlorine contained in 100 grams of chloride of lime. The test must be made every time a new product is received. The result obtained will differ more or less from 25%, and it will be necessary to reduce or enlarge the proportion of the 3 products contained in the preparation. This can easily be arranged by multiplying each of the 3 numbers 200, 100, 80 by the factor 25 over N, in which N represents the weight of the active chlorine percent of chloride of lime. Titration of Dauphin solution. Measure 10 cc of the solution, add 20 cc of a 10% solution of potassium iodide, 2 cc of acetic acid, and drop by drop a decinormal solution of sodium hyposulfite until decoloration. The number of cubic centimeters used multiplied by 0.03725 will give the weight of hypochlorite of soda contained in 100 cc of the solution. Never heat the solution, and if, in case of urgency, one is obliged to resort to titration of chloride of lime in a mortar, employ only water, never salt solution. To test the alkalinity of the Dauphin solution. To differentiate the solution obtained by this process from the commercial hypochlorites, pour into a glass about 20 cc of the solution and drop on the surface of the liquid a few centigrams of phenolphthalein in powder. The correct solution does not give any coloration, while Labarach solution and eau de Javel will give an intense red color, which shows the presence of free caustic alkali. The stock solution should be kept in blue or brown colored bottles, well corked. It will be readily seen that there is a difference between the Dauphin solution as originally made and the hypochlorite solution technique of Dauphin. The original solution contained 0.5 to 0.6% sodium hypochlorite. The modified Dauphin solution contains between 0.45 to 0.50% hypochlorite and does not contain boric acid. The method of use, technique Carrel, must be followed if successful results are to be secured. It is possible that the solution represents but 20% and that the technique of Carrel represents 80% of the result, but the success of the treatment is dependent upon the thoroughness with which it is applied and the care given to even the smallest details of the technique. End of chapter 15.